Respected dignitaries, Assalamu alaikum, good afternoon. Welcome to the 21st Postgraduate Development Program. I'm Dr. Hadia Kar, Postgraduate Scholar in the Department of Psychiatry in SKIMS Medical College, Srinagar.
And I'm Dr. Farhana, Postgraduate Scholar in Department of Psychiatry, SKIMS, Srinagar.
The beautiful thing about learning is that no one can take it away from you. Learning is not attained by chance. It must be sought for with ardor and attended to with diligence. And today we have all gathered here for a learning activity.
PTDP is yearly academic activity organized by Indian Psychiatric Society North Zone to provide a platform for learning and active interaction between faculty from reputed institutes and PG students from all over North Zone. The activity is actually meant for achieving academic excellence, enhancing skills, and learning intricacies of research in the field of mental health.
21st Postgraduate Development Program, which was actually scheduled to be held in person by Department of Psychiatry, SKIMS Medical College, Bemina, in collaboration with GMC Srinagar. However, due to COVID-19, the same program could not be held in person and hence is held by online mode by President and Secretary of Indian Psychiatric Society, North Zone themselves.
The theme of the program is metabolic syndrome and psychiatry, as we all are aware of the fact that psychiatry and metabolic syndrome are interrelated. Psychiatric disorders lead to metabolic syndrome, and metabolic syndrome causes psychiatric disorders. As we know, metabolic syndrome represents a global epidemic in which unhealthy lifestyle, severe mental illnesses, and psychotropics all play a role. Hence, this theme is pertinent because it is becoming a greatest challenge in psychiatric practice, adding to the disease burden, affecting our treatment and rehabilitation outcomes.
Postgraduate Development Program 21 aims to sensitize the next generation of psychiatrists and clinicians about the concept of metabolic syndrome, its prevalence in psychiatric patients, etiology, relation with substance use disorders, and finally, the role of psychiatrists in its management.
Now it's time to call our esteemed dignitaries on the stage. I consider it a great honor to welcome worthy chief guest, Professor A.G. Anger, sir, who will be joining online. Sir is Director SKIMS and ex-officio Secretary to Government of J&K. Professor Anger, sir.
We welcome you, sir. I feel privileged to invite our guest of honor, Professor Irfan Rabbani, sir, Principal, SKIMS Medical College, Srinagar. You're welcome, sir.
With equal pleasure, I invite our next guest of honor, Dr. Gautam Saha, sir, who will be also joining us online.
Sir, kindly acknowledge us, sir, Dr. Gautam Saha, if you are there.
Yes, I'm here. Thank you so much.
Thank you, sir. Thank you very much.
I'm glad to call our next dignitary, Dr. N.N. Raju, sir, Vice President cum President-elect, Indian Psychiatric Society.
It's my proud privilege to invite Dr. Sandeep Goyal, sir, President of Indian Psychiatric Society North Zone and organizing chairperson for the event, to grace us with the presence on the stage.
I am honored to invite the prestigious guest, Dr. Sandeep Grover, sir, Honorary Editor of Indian Psychiatric Society North Zone.
It's my greatest honor to invite our head of the department, Honorary Secretary, Indian Psychiatric Society North Zone, and organizing secretary for the event, Dr. Abdul Majid, sir.
Thank you all for gracing the occasion with your esteemed presence. Now, may I request Dr. Sandeep Goyal, sir, President, Indian Psychiatry Society North Zone, for the welcome address.
Thank you. Good afternoon to all of you. Chief guest, Dr. A.G. Hanger, sir, Director Schemes and ex officio Secretary to Government of Jammu and Kashmir. Guest of honor, Dr. Irfan Robani, sir, Principal Schemes. Guest of honor, President IPS, Dr. Gautam Saha. Guest of honor, Dr. N.N. Raju, sir, President-elect, IPS. General Secretary, IPS, Dr. T.S.S. Rao. Editor, IPS, Dr. O.P. Singh. Treasurer, IPS, Dr. Mishra. Office bearers of IPS North Zone, my friends, Dr. Nitin Gupta, Dr. Abdul Majid, Dr. Sandeep Grover, Dr. Satish Verma, speakers, chairpersons, dignitaries in the audience, and my dear friends. It is my proud privilege and honor to welcome you all to the 21st PGDP program of the IPS North Zone. I hope everyone is safe and healthy. Due to COVID restrictions, this PGDP is organized predominantly in an online mode. Theme for this PGDP is metabolic syndrome and psychiatry. We have 8 lectures and 1 panel discussion. I congratulate Dr. Rajesh Rastogi, sir, our CME chairperson, for this wonderful scientific schedule. Convincing evidence shows that psychiatric conditions are characterized by an increased risk of metabolic syndrome, a cluster of cardiovascular risk factors, including dyslipidemia, abdominal obesity, hypertension, and hyperglycemia. This increased risk is present for a range of psychiatric conditions, including major depressive disorder, bipolar disorder, schizophrenia. Contributing mechanisms are an unhealthy lifestyle and a poor adherence to the medical regime, which are prevalent among psychiatric patients. Specific psychotropic medication have also been shown to have a profound impact in increasing metabolic syndrome. I'm sure this PGDP will add to our knowledge and sensitize the PG students in identifying the metabolic syndrome from the start of their career. From this year, we have started an online CME every Wednesday, and I'm happy to share that till now, 24 such CMEs have been organized by IPS North Zone. I thank all the members of IPS North Zone for making this CME a grand success. I request PG students to become a member of IPS North Zone so that strength of our zone can increase. At last, I wish that COVID situation improves and we can have in-person scientific activities. I thank you all for joining. Long live IPS, long live IPS North. Thank you.
Thank you, sir. Now, may I request Dr. Abdul Majid, sir, Honorary Secretary, Indian Psychiatric Society North Zone, to enlighten us with his thoughts.
Good afternoon, everyone. Assalamu alaikum. To all offline and online, Dr. Gautam Saha, President of IPS, Dr. N.N. Raju, sir, who is Vice President President-elect of IPS, dear friends, Dr. O.P. Singh, Editor of IPS, Dr. Mishra, who is the Honorary Treasurer, and I can see very senior colleagues, Dr. Rastogi, sir, who is our CME Chairperson, who has beautifully designed this program, and Dr. Shekhawat, sir, I can see there, and we have offline here very senior guests, Dr. Nimesh Desai, who is Director IBHAS, Madam Savita Malhotra, who has been my examiner and is teacher of teachers, Dr. Ravi Gupta, who is a speaker for today's program, and all my friends and colleagues, my senior residents, PGs from GMC Srinagar and my department, and all PGs all across North Zone and other distinguished guests. It's always a pleasure that we have events like this which are completely focused on academics, because we know academics is the core of every specialty in medicine. And talking about mental health, we know that it needs more emphasis on academics and advocacy, and that can be achieved only by doing such programs where you have interaction and where you invite reputed faculty from the prestigious institutes to interact with our PG students. And it's our learning experience as well, as all religions say that you learn till grave, and that has to be the actually sentiment all the way through as long as you are in this world. So we had to start with, because of COVID fears, we had our midterm CME online on 4th of July, where more than 200 delegates attended. And it was again a very successful program. And then we actually started the CME series under the patronage of our president, Dr. Sandeep Goel, and Sandeep Grover sir, who has been a great support all through. Dr. Nitin Gupta has been a guiding force for sustaining that program. So it has been all a good story, and we are celebrating the Silver Jubilee session on the 25th session next week. So it's all good omen going on. Things are going. Clemity has provided an opportunity. We are still interacting with each other. That's a good thing. So we'll be having our annual conference most likely in second week of December, and all are invited to join us. We'll decide the mode of the holding conference. I thank every one of you who have come physically and those who have spared their very valuable time online, particularly the IPS office bearers, our CME chairperson, and our EC members, and nonetheless the PG students from IMHANS and my own PG students and senior residents who have come all the way through. Thank you very much. Thank you all. May I request Dr. Sandeep Goel, our president of IPS North Zone, to present a floral bouquet to our guest of honor, Dr. N.N. Raju, who is the vice president cum president-elect of IPS North Zone. We will send virtual bouquets to our Gautam Saha, OP Singh, CME chairperson, Rastogi sir, Dr. K.K. Mishra, and all the senior colleagues. But here we have Professor Nimesh Desai, Director IBHAS. May I request Dr. Sandeep Goel to present a bouquet to him as well. Sir, we are really honored by your physical presence here, sir. Thank you very much. Again, I would request Dr. Sandeep Goel to present a bouquet to Professor Savita Malhotra, who has taken all pains to come over to Srinagar to attend in person. And it's always beauty to have speakers in physical presence. So Ravi Gupta is one of them. We are honored to present a bouquet to Professor Ravi Gupta, who is not new to Kashmir, and he is a dear friend. And I request Dr. N.N. Raju to present bouquet to Dr. Sandeep Goel, well-deserved bouquet to my dear friend and president, IPS North Zone. Somebody will present bouquet to me as well? Okay, Dr. N.N. Raju. Thank you very much. Again, Dr. N.N. Raju to Dr. Sandeep Grover. Thank you very much.
Thank you, sir, for sharing your thoughts with us. Now, may I request Dr. Nitin Gupta, sir, Vice President, Indian Psychiatric Society, North Zone, to say a few words. Sir is joining us online.
Nitin, sir, can you unmute yourself and speak? Dr. Nitin Gupta.
Good afternoon. Good afternoon to President IPS, Dr. Gautam Saha, President-elect Dr. N.N. Raju, Honorary Secretary Dr. T.S.S. Rao, Honorary Editor Dr. O.P. Singh, and Honorary Treasurer Dr. K.K. Mishra, my dear friend and colleague, President IPS North Zone, Dr. Sandeep Goel, Dr. Majid, our Secretary, Dr. Sandeep Grover, Editor, along with Dr. S.K. Verma, who's our Treasurer, IPS North Zone, all our respected chairpersons, and not to forget our chairperson CME, Dr. Rastogi, who has designed this beautiful program, and all the speakers and respected teachers, colleagues, and all the delegates who are attending this wonderful PGDP, which has been organized in one of the most beautiful areas of India, Srinagar. I'm feeling actually left out because I had told Majid that I will be trying to be there, but unfortunately I'm not there. I think it will be a wonderful treat for all of us having to listen to all the wonderful lectures which will be presented by the speakers. Metabolic syndrome, as Dr. Sandeep Goyal has already enumerated, is a very important area and topic. And hopefully not only the topic, but the wide array of subjects which has been chosen under this area will shed light. And as part of the zone, we are always striving to achieve further heights in academic perfection. And as has been enumerated by Dr. Majid and Dr. Sandeep, the CME series which has been started, we have been trying to cover certain areas under that also. So hopefully the PGDP subject of metabolic syndrome will also strive towards that. And I wish this program a great success. With these few words, I wish the program a great success and thank you for allowing me to say these few words. Thank you very much.
Now, may I request Rajesh Rastogi, sir. Sir is CME Chairperson, Indian Psychiatric Society, North Zone. Sir, may I request sir to share his words of wisdom.
Good afternoon, everyone. I am particularly pleased to see our President, Dr. Sandeep Goyal, Secretary, Dr. Majid, and IPS President, Dr. Gautam Saha, the dynamic, whose ever presence is everywhere, exude warmth, and incoming President, Dr. Raju. Raju is on the dais, busy with charting out certain issues with Dr. Sandeep Grover. I can see Dr. Mishra Treasurer. I can see on the dais, Dr. Sandeep Grover. As you know, the present theme of the PG development program, which has been decided by the executive and very well worked out by the executive, in particularly with the president and the secretary and Sandeep Grover, is the metabolic theme, the metabolic and the psychiatric disorder. It is very pertinent, particularly for the young psychiatrists, to know the association between the metabolic disorder as well as the psychiatric disorder, how they are associated. So we are going to deliberate on that, on the various aspects of it in detail. The program is in front of you. The prevalence of metabolic syndrome, the topic, the concept and critical assessment, the etiology and biological marker associated with the metabolic syndrome, psychotropic, particularly the antipsychotic, which are important, metabolic syndrome, substance use disorder and metabolic syndrome, treatment of depression and diabetes, necessity and consequences, relationship of metabolic syndrome and sleep, management of diabetes mellitus and dyslipidemia with severe mental disorder. And finally, we will have a panel discussion. So comprehensively, the executive and the society has tried to cover the various aspects of the metabolic syndrome with psychiatry. With this, I'm sure this is going to enhance our academic learning, this program, and I wish good success for this. Thank you.
Thank you very much, sir, for your words of wisdom. And we are honored to have been joined by our principal, SKIMS Medical College, Professor Irfan Rabbani, sir, who is a very senior professor of radio diagnosis and currently posted as principal in our college. Sir, kindly unmute yourself and go ahead with your words of wisdom.
Thank you, Dr. Majid. Am I audible?
Yes, sir, very much.
Professor Gautam Saha, President IPS, Dr. Sandeep Goyal, Organizing Chairman and President IPS North Zone, Dr. Abdul Majid, Organizing Secretary and Chief of Psychiatry at the SKIMS Medical College, dignitaries, delegates, students, online and offline, and dear friends. A very warm greetings from the mesmerizing Jammu and Kashmir, and a very good afternoon to all of you. It's my pleasure to be here, though joining virtually at the 21st North Zone PG Development Program of the Indian Psychiatric Society. This event basically aims at developing postgraduate medical education in psychiatry in the entire country, especially in the North Zone. I believe a respected professional body like the Indian Psychiatric Society holding such programs is a boon for students, because students are our hope and they are our future. Here I would like to narrate a beautiful couplet. Tu rah nawarde shauk hai, manzil na kar kabool. Hello? Yeah, should I continue?
Yes, sir.
Yes, sir, you continue, sir.
Which means that you are a traveler. Never. And I think that should be our mantra. The history of psychiatry in Jammu is very, very significant and very, very interesting. When during the days of Raj, they carved out a psychiatry hospital from the Srinagar Central Jail. And here we are today discussing metabolic syndromes and psychiatry. It tells us the dynamicity of the specialty and the amount of good work that all of you have done. I record my appreciation at this time for the Department of Psychiatry at the SKIMS Medical College, which is a postgraduate department fully involved in teaching, research, and patient care. We are coming up with a special psychiatry block, which would also have a de-addiction facility. Anyway, this is not the forum to discuss all that, but I just want to tell you that Jammu and Kashmir stands shoulder to shoulder with the rest of the country as far as developments in psychiatry are concerned. I thank all of you, especially the students who have joined us both online and offline. I extend my good wishes for the success of the conference. Thank you very much and all the best.
Thank you, sir. Now, may I request Dr. Gautam Saha, sir, President, Indian Psychiatric Society, North Zone, to share his thoughts of wisdom.
Sir is President of Indian Psychiatric Society. North Zone is staying with us sometimes.
No problem.
Sorry, sir.
I'm the
Sir, will be
president of all
joining-
zones. Very, Dr. Gal, it's an issue. It's okay. Thank you so much. It's a really great privilege to be there, but I am really missing like anything that I am not present in person there. In the last 3 to 4 program, I was with Dr. Sandeep, both Sandeep and my brother, Dr. Majid, at the time, but I'm really missing. At the outset, I must give my thanks to the organizing committee and also the Northern office bearer, starting from the president, Dr. Sandeep Goyal, the secretary, Dr. Abdul Majid, and vice president, Dr. Nitin Gupta, editor, Dr. Sandeep Grovo, and treasurer, Dr. Satish Verma. All of them, you have done wonderful job and you are always active. In fact, I must give credits to Sandeep and Majid for wonderful in a serial academic program, what you have done from a June. It is really great and it is really appreciated by everyone of our society. And thanks to Dr. N.N. Raju, the esteemed vice president of our society, to be there in person. I'm really happy that at least one of us from the central body is there and sir is doing his job, and so happy to see that he is on the dais. Today, the to all the PGs, those who are present now, I'm telling the topic chosen by the North Zone by Dr. Rajesh Rastogi, one of the most senior and respected personalities of Indian Psychiatric Society, is really fantastic. Metabolic syndrome is one of the things students should understand why we are talking about metabolic syndrome being a psychiatrist, because metabolic syndrome can cause psychiatric illness. Psychiatric illness also may cause metabolic syndrome, maybe due to the drug administered to them, or maybe due to illness itself. So it is so important. You have to know before being a psychiatrist, you have to know what is metabolic syndrome, and if it is there, to how to tackle it, what is the management. This is very important. I am not taking much time, but what I am telling, the North Zone is always very much active. And in fact, I am really missing like anything not to be there. But definitely, I am happy that Dr. N.N. Raju is there on behalf of us, and Dada will do everything on behalf of us. Thank you so much. Thank you very much.
Thank you, sir, for sharing your thoughts with us. As a tradition in Kashmir, we begin our significant and auspicious events with the burning of rue, popularly known as Isband in Kashmir, which is believed to spread fragrance in the surroundings. May I request Dr. N.N. Raju, sir, Vice President, Indian Psychiatric Society, for the same.
Professor Nimesh sir and Madam and Ravi Gupta can join us, please.
Thank you, everybody. Now, may I request Dr. N.N. Raju, sir, to share his few words. N.N. Raju, sir.
Okay. President of the afternoon from Thank you. Good afternoon once again, everyone, both online and offline friends. President of the event, Dr. Sandeep Goyal, the chief guest, Director of Schemes, Sir Professor Ahangir, Principal Schemes, Dr. Irfan Rabani, sir, my friend and President of IPS, Dr. Gautam Saha, the other colleagues of IPS National, Dr. PSS Rao, Dr. OP Singh, Dr. KK Mishra, and others, the EC members of IPS, Dr. Shekhawat and Dr. Sandeep Gaur, who again, I think I will address him once again, being the architect of so many programs, and one more here. Dr. P.D. Garg, the two is there in North Zone. Another important person in my life, Dr. Rajesh Rastogi. I think Dr. Majid said he designed the CME, but most of you know that he designed even my life, professional life, from the beginning, almost for the last, I would say, 40, 38, 36 years. He has been a close, I would say, senior friend, mentor, advisor. Whenever I have something, just call him and talk to him. Thank you, Dr. Rajesh Da, for being there. Other members of IPS North Zone, Dr. Nitin Gupta, Dr. Satish Verma, and I keep Dr. Majid for the last, for the simple reason that I think he is one loved by everybody all over the country. It is surprising, really. I think in spite of being reasonably successful, I should learn a lot of things from him, being so friendly, so cool. So I think I would say so smart. Really, many things which we can learn from him. Surprisingly, I do not know why, but I always have some chemistry between North Zone and myself. I think whenever there was a program, always, I do not know why, but something I feel North Zone is part of my zone itself. I know North Zone is not the strongest zone as a number-wise, but I think that is the most jubilant, most, I think, effervescent zone, I would say, in the country. And I have mentioned many, but as again, I have come back to Sandeep Grover. We know that I have been introducing him. There are some people who have been keeping the IPS flag flying very much. And Sandeep, though I think some people may not like the way in which he is present everywhere. Reason being that he just deserves to be there, that's it. So we are really happy that he is there. And in the audience, we have two senior colleagues and a junior colleague. Seniors like Dr. Nimesh Desai and also our Dr. own Savita Malhotra madam. I think these are some names which really make Indian psychiatry proud. And again, keeping Ravi here, I was just introducing him. There are some people in the psychiatry who make psychiatry what it is. Unfortunately, we have done psychiatry what it is not many times. I can't understand how sleep medicine can go to pulmonologists. What pulmonologist has to do anything with sleep except snoring? So he is the one who makes us understand where we belong, and I'm sure his path would be followed by a lot of people in the country. Getting psychiatry its due. It's one of the most beautiful branches. I would say, even though many may agree, may not agree, but I also was not the greatest of the favorites when I started my career in psychiatry, but now I realize how important it is. Yes, if I missed any name, please do forgive me, and I think I will not be talking on metabolic syndromes today. I think enough we will listen to the experts. Why again here in chief guest, or go I say guest of honors? Sir, I'm really thankful to have the chief guest of the event, the director schemes, Professor A.G. Hanger, sir. And sir, if you are want to just now itself, I will break my lecture and hand the mic over to you, sir. Please unmute and
so I'll be just coming in for a moment, and then you could continue your proceedings. Is that fair enough? Okay.
Okay, sir. Whatever way, right?
All right. So my profound regards to one and all on the dais there. Dr. Gautam Saha, the guest of honor, then Professor Irfan Rabbani, Dr. N.N. Raju, Dr. Sandeep Goyal, Dr. Sandeep Grover, and Dr. Abdul Majid, head of department of the psychiatry department, and then all others there in the audience. and everybody else on offline and offline mode. I am here to be among us with you, literally on a virtual mode. Because of the constraints of time, I have an important engagement with the Honorable Chief Secretary with regard to the COVID preparations. So I have all the regards for all the delegates there who are participating in this conference, which is one of the prestigious conference under the banner of Indian Psychiatric Society, North Zone especially. And I wish I could be physically there, though I had committed to Dr. Majid a long time before. But I'm sure then, since you're already doing a wonderful job on the score of the conference, and with regard to the particular subject and the theme that I understand is very, very relevant today, is very important. We have seen a lot of people with various disorders, not only on the metabolic front, but many other non-communicable diseases or even communicable diseases of late. The corona pandemic coming in a big way and hitting us on a different platform. On account of that also, there are a lot of psychiatric disturbances, or may not be the disease or the syndromes, but I think you are the right forum to debate it and deliberate upon this issue. And I would not be taking much of the time because I'm still on the way to literally Chief Secretary's office. I wish the organizers the brilliant success here. However, my point of concern would be kindly issue whatever frameworks or the guidelines or the directions would be with regard to one of the worst menaces that the society is facing, that is the addiction of these people, especially the youngsters, the youth. The biggest asset that we see the planet all over the world is the youth we have. Whichever manpower we utilize in whatever service or whatever discipline, I think the biggest asset that we need to preserve is our youth. And I would request the gathering there to find out the modalities of how we can address that problem of the drug addiction and probably help the emerging youth fighting this problem, not only psychologically, but even otherwise also. If there are any metabolic disorders also, if there are any other organic disorders also, they need to be addressed too. With my brief remarks, I would extend my heartfelt welcome to all the participants offline, online, as well as the ones who are physically there, who come from outside the state or the Union Territory of J&K. I wish the organizer brilliant success for this program. Thank you very much. Please bear with me for not being there with you. Bye-bye.
Thank you, sir. Thank you so much for your blessings.
Pleasure
Coming
always.
back, I think you don't have respite. I will be back again. And also, it's nice to speak after the chief guest, because usually it is the chief guest who speaks last. And sometimes you have that honor of speaking after the chief guest. Thank you so much. Again, coming back, as I said, I would not be talking about metabolic syndromes because you will get bored enough later on. Basically, we are more interested in these PZ development programs because the gap of training between one institute to the other institute as far as PZ training is so huge. The one in a private medical college, you don't have a patient, you don't have a teacher, you don't have nothing. I know some postgraduate departments where unfortunately the postgraduates go to the private clinics or the practitioners in the city to get exposed to various disorders. I know so those institutions. On the other hand, you have good institutions, both at the national level and also at the state level. I think IPS has that onerous responsibility of bridging that gap. We know I think nobody can promise you to make some XYZ medical college equal to SKIMS or NEMHANS or something. That is difficult. But at least we can reduce the gap as much as we can. All cannot be AIMS in all medical colleges will not be AIMS. Even AIMS Rishikesh can't be AIMS Delhi. This is all the facts which we need to understand. But let us see what best we can do to reduce those gaps. We have somewhere around 300 institutions training postgraduates in psychiatry in the country, and perhaps about 900 postgraduate students being churned out every year after year after year, and most probably government is hell-bent on adding some more postgraduate seats, giving some figures that psychiatrists are inadequate in number. I'm not very sure about this. I don't know whether it is semi-political or purely political statements. Yes, we have less number, but unfortunately, the distribution of psychiatrists in the country is varied. If you take South, it is overfilled. It is so much overfilled that I think most of the psychiatrists students who finish their MD, they book tickets to Ludhiana, Amritsar, all Punjab's towns, even unknown names of Punjab, just to work. They give 2 lakhs, 2.5 lakhs, something which they never dream of back in Andhra Pradesh, Telangana, Karnataka, or Tamil Nadu. They don't have jobs. They don't have work. Again, that is the same case with eastern part of India. We don't have enough psychiatrists. That is a fact. So this has to be done. The government has to look into this, and IPS also should be in discussions with national media. In fact, I was fortunately Dr. Gangadhar, the president of rating and assessment, was there in my house for a breakfast meeting we had last week only. So not even last week, 4-5 days back. So I did tell him that, look, you need to increase the number of seats in the areas where you don't have. In Vizag, where just I retired from the institution, we had 20 MD seats a year, which is a bit too many. 20 postgraduates. So totally you have 60 postgraduates, and most of the teachers do not know the names of the postgraduates. So this sad situation should end. So we need to understand. And another thing is that I think recent judgments too, they have given judgments saying that still LGBTQ is being named badly in an undergraduate course as this, that, and all, and also asked NIMHANS and IPS to give their opinions. Reason being that enough exposure is not being there in undergraduate education. So something has to be done as far as that is concerned. What I mean to say is that more than anything else, the IPS has a big role to play. I think roles more than, I think, attending conferences. We have, I think, bigger role in negotiating with the people who are in power. That is the only way which we can do. There are, I think, other areas, most probably friends like Dr. Nimesh Desai, Dr. Savita Madam, or especially North Zone should be very powerful as far as negotiating with the powers that be, because they are closer to the, I think, Delhi. So obviously they are more powerful than, we are far away from it. We are almost like Kashmir. We are also away from the power. We almost feel that we are stepmotherly attitude as there towards us. So we are, I think, me and Kashmiri are on the same platform as far as feeling bad about this stepmotherly treatment by the center. So whatever it is, we should all come together. Forget about who is mother and stepmother, but still we should all children should come together and work on strengthening our psychiatry. Why I said psychiatry is important and very, very, I think basically we believe gradually we are coming back to psychiatry as something settled in brain, not something in mind. We don't know where the mind is. I think movie. So not that way. So we need to understand that. I think Mike is giving me enough indication to stop my talk. Obviously, I mean to say that what I mean to understand is that we all should come together, make psychiatry more of a brain-related. I know we have stresses, we have environmental factors, but final common pathway has to be something to do with our brain. So today's metabolic syndromes too would be emphasizing the fact that we need to be more medically alert than the earlier generations. I think few years back, most probably I lost even my own father because I didn't know that hyponatremia causes episodic psychotic episodes, which are delirious states, which we have been checking this only for the last 15 to 20 years. Earlier, anything cognitive disturbances, just nothing can be done, just leave them. But today we are more knowledgeable. We know that we need to investigate it. We need to see treatable diseases and treatable conditions. And also, we are coming across a lot of side effects which we have never imagined. How many of us ever thought of hyperammonemias? I think no psychiatrist, he doesn't even know the blood sugar values. Psychiatrist, what is calcium? Psychiatrist, what is sodium? No longer. I think again you may surprise. I have a physiology book in my bedroom because that is where I should read because I forgot it. long time back. The alkaline imbalances, the evoked potentials, all are important now. And today I'm really happy that North Zone has brought a very important topic of metabolic syndromes. It just please, for the postgraduates online and offline, I request them, don't see that just as a side effect of a drug. We need to know metabolic syndrome just because a few drugs cause it. No, we need to know the metabolism, the normal metabolism and related disorders. And I'm sure today's speakers, I think very decorative and very eminent speakers are there. I'm really happy that physically I'm present. Once again, most probably, even now my colleagues in IPS could be envious of me being physically present here. But anyway, that is what the friendship I have with the North Zone. And I thank all the members of North Zone for inviting me to this beautiful, I think it is something, if you say Srinagar is beautiful, it is something like sunrises of the east. So it's a beautiful city. I had a very brilliant time here. I did come here in 2015. And again, I'm back here. I'm sure Majid would organize some meeting next year for me to be there for a whole week. Thank you so much. Maybe he answers. Thank you so much for being here. I wish the program a grand success and I will be more than happy to be here. And once again, I thank you. And before I leave, the ANSIPS is in Visakhapatnam. If I'm sure people from Kashmir should be excited to be there because I live almost every day. Today I have seen Dal Lake, but I see a Bay of Bengal every day from my house. So it is the sea and you have hills like this, same thing like this. Instead of Dal Lake, you will have Bay of Bengal. That is the only difference. So please come in big numbers and attend conference that is on from 20th to 23rd of January in Visakhapatnam. You're all welcome there. And once again, I thank all of you and Dr. Sandeep and Dr. Goyal and two Sandeeps and Dr. Majid for making me what today. Thank you once again. Thank you.
Thank you, sir, for sharing your thoughts with us and for your valuable opinion. We are joined by Dr. T.S.S. Rao, Secretary, Indian Psychiatric Society, online. Sir, can you please say a few words on this occasion?
T.S.S. Rao, sir, are you there? You can unmute him if he's there. Sandeep, you can. Dr. O.P. Singh, editor IPS, he is there. I can see him. You can unmute him. Thank you, sir. Please go ahead.
Everybody, my regards, President of North Zone, Dr. Sandeep Goyal. Then guest of honor, President IPS, Dr. Gautam Saha and Dr. N. Raju, Director of STIMS, and all other dignitaries like Dr. Sandeep Goyal, Majid, Sandeep Grover and Majid, Dr. Nitin Gupta, CME Chairperson, Dr. Rajesh Rastogi, Dr. Savita Malhotra and Dr. Nimesh Desai. This is my pleasure, but first I will start with apology. Really, as Dr. Gautam Saha said, we are missing being there, and I apologize particularly to Majid and to everyone, Sandeep, both Sandeeps and others, that we are not there, and I will not take much time. I just say what Dr. Gautam Saha has also said, that I have been following the PG development program of North Zone, and I must say this is one of the best programs going on today in country. All the zones are trying, everybody is doing programs, but North Zone programs are really superb. And of course, we cannot expect less with Sandeep Grover, Majid, Sandeep Goyal, and CME Chairperson, Dr. Rajesh Rastogi and Nitin Gupta. So my compliments to you. All the PGs from other zones are also following. I am also following. This is a wonderful program, and this program is also superbly crafted, and I will be joining again. So thank you, my best wishes. And again, thank Dr. N. Raju for really a beautiful speech. Thank you so much.
Thank you, sir. Thank you, sir. You might be far away, Dr. Gautam Saha and yourself, but you are close to our hearts, sir. Thank you very much. Dr. K.K. Mishra.
Good afternoon, everybody. The guest of today's function, Dr. Sandeep Goyal, the President of IPS North Zone, and Chief Guest, the Director of Schemes, and Dr. Irfan Rabani, the Dean of Schemes, and all my great friends like Dr. Abdul Majid, Dr. Sandeep Grover, Dr. Nitin, Dr. Verma, and all my friends in the IPS hierarchy, starting from President Dr. Gautam Shah, Vice President Dr. N. Raj, who is enjoying the hospitality of the Srinagar and Abdul, and we are really envy of him. And Professor T.S.S. Rao, our secretary, who is not there actually, and Dr. O.P. Singh, my great friend, and all my seniors from the North Zone, like Rastogi sir, which is my Dr. N. Raju, he has been my guide, my mentor for a long time, at least for last 10 years since I joined the IPS politics when he was there at the election commission. And Dr. Nimit Desai sir, Sabita madam, Ravi, my great friend, and Dr. Makbul sir, and Dr. Manmeet. I think I have to name all. If I have to go on long, I'll just take a lot of time in that. And all my great seniors and PG residents of the North Zone. And this is really nice. And as President Dr. Gautam and Dr. We were telling, we really miss the hospitality and the beauty of Srinagar. And last year we have been to Chandigarh to attend the inaugural functions. So I'll not go much about the topics. Has already been spoken a lot about this thing, metabolic syndrome. I think Dr. Raju and all those people have already spoken. I think we started like metabolic syndrome was not really known much in the psychiatry, has been told. And it just started when we were in the PG, that time the second generation anti-psychiatry started coming. And there we started discussing about the metabolic syndrome. And over the last 20 years, and it has a lot of research and a lot of things has been done in this area. So I'll not go much about this because there are more learned speakers to speak about all these aspects. And with this, I wish you all the best and I request all the residents to attend all the programs and to at least all the great speakers are there to listen to all of them and they can clarify whatever doubt have they got in the subject. And I wish all the best to the program, the PGCME, and thank you all, the North Zone office bearers, including my Sandeep, both the Sandeep and Dr. Majid, Dr. Burma, Dr. Nitin, my great friend, to inviting us to be the part of this program and wish you all the best. Thank you very much. Maybe mic is not working.
Dr. Majid, you are not audible.
Hello, Dr. Majid. Yeah.
Yeah. Dr. Majid, you are not audible.
Anybody from organizing committee can take.
Is it okay?
Yeah,
now it's okay.
Yeah. So we are presenting mementos to the team who are actually behind the program, and we have second postgraduate student from my department, Dr. Hadia Kar, who had an honor of standing first in all India level for the program that we had through IPS mock test, and she won the first prize. We have Miss Kausar, who will be anchoring as well, and she is working with us in our department. Miss Kausar can come forward and collect her memento. Dr. Sandeep Goyal and Dr. Grover Boss will felicitate and present memento to Dr. N. Raju, sir. Thank you very much, sir. Dr. N. Raju would present memento and felicitate Dr. Sandeep Goyal, President IPS North Zone. I'll be the last, so Dr. N. Raju and Dr. Sandeep Goyal will present memento to Dr. Sandeep Grover, our dynamic editor of Indian Psychiatric Society North Zone, and the dearest friend of Srinagar-based psychiatrists. I request Dr. Anand Raju to present memento to me.
Yes.
Now may I request Dr. Abdul Majid sir for Secretary's address and vote of thanks.
Thank you very much. I have already delivered my secretary's address, so I will be doing vote of thanks from my side, and it's my proud pleasure to present it. First of all, I would like to thank my Director Schemes and ex-officio Secretary to the government, who despite his extremely busy schedule could join us online, and then Professor Irfan Rabbani sir, who is Principal of Schemes Medical College, followed by Dr. Gautam Saha, my dear friend and elder brother, I would say, Dada. We call him popularly, he is known as Dada in Indian Psychiatric Society. So thank you very much, sir, for joining us online. Dr. Anand Raju, sir, it has been an honor for us to host you as a guest of honor, and since you being the president-elect, then we have Dr. Nimesh Desai, sir, Dr. Savita Malhotra, and most importantly, the core of IPS North Zone, that is my dear friend, Dr. Sandeep Goyal, who is the president. Thank you for, sir, coming all the way from Ludhiana. Dr. Sandeep Grover, my dear friend. We have many memories. Ravi Gupta is there, Satish Verma, we could not join. So there are many people who have, and Rajesh Rastogi sir, last but not the least, who has been very dynamic, interactive, always guiding us. He has been the guiding force behind all this event that we have been able to schedule today. So thank you all for a wonderful, and last but not the least, Dr. Tajamul is there. He's heading the department of GMC Baramulla, young dynamic psychiatrist for us. PG students from my alma mater, that is Institute of Mental Health and Neurosciences, GMC Srinagar. I love the institute. I love all of you, the PG students from that place. Thank you very much for coming over. Dr. Ajaz, who is my senior resident, Sajid, Himayu, all are dear to me, my PG students from my department, and all the PG students across North Zone and faculty who have joined us today for the inauguration. Thank you all for being here, and we'll be joining again in just 5 minutes. Have a cup of teas in your rooms, or we'll have in this hall only. We'll be joining again in 5 minutes, and we'll start our scientific program. Thank you very much. Thank you all.
Thank you. Excellent inauguration. I want to say hi to our ma'am, Dr. Savita Malhotra, my dear friend, Dr. Nimesh Desai, and
thank you, sir. Thank you, sir.
Dr. Ravi Gupta.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you very much, sir. Thank you very much. Thank you. Thank you. ज्यादा लंबा लंबा किसी का नहीं बोल हल्का कर देना भाई
And sir. Third is Assistant Professor and Head Department of Psychiatry, GMC Baramulla. Third has done MBBS and MD from GMC Srinagar and has done fellowship in geriatric psychiatry from NIMHANS, Bangalore. Dr. Tajamul Hussain, sir.
Thank you very much. So I request everybody to get seated. Respected eminent faculty members who have joined us online, and all the eminent faculty members who have joined us here in Srinagar, all the PG students and all other who have joined us, I welcome you all to the first session of this postgraduate development program. I'm Tajamul. I work at GMC Baramulla. The weather outside looks gloomy, but let us make it bright and very interactive here inside. So, as Majid sir usually says that to open the innings, we have our best batsmen. So, our first session is on concept and clinical assessment for metabolic syndrome. And the speaker is none other than Dr. Sandeep Grover, sir. So I'm sure all the PG students who have been joining the Wednesday CME programs must be knowing sir quite well now. So for this session, we have three chairpersons, three eminent, experienced psychiatrists. But currently we are joined by Dr. Rastogi sir and Professor Makbul sir. Dr. Rajesh Rastogi sir has more than 38 years of experience in the field. He has worked in past as head of the Department of Psychiatry in Safdarjung Hospital and Medical College, New Delhi, and has also worked as consultant in National Mental Health Program. Sir has been past president of IPS North Zone and has held various other eminent posts in different forums. And Sir has numerous publications in national and international level. Sir is very popular figure. He usually gives his various TV programs and radio programs as well. So I welcome Rastogi sir to this first session. Our other chairperson is our own Professor Makbul sir. Sir is currently head of the Department of Psychiatry at GMC Srinagar. He has almost 20 years of experience in the field. Sir has many national and international papers to his credit, and he has played a pivotal role in getting the Center of Excellence for the Department of Psychiatry at GMC Srinagar, which is now called Institute of Mental Health and Neurosciences. Sir's areas of interest are mood disorders and spirituality, and one of the most humble human beings I have come across in my life. So we welcome you, sir, to this first session.
Thank you, Dr. Tajamal. Thank you very much.
So now I request Dr. Sandeep, sir, to kindly start. Yes, I would request Rastogi, sir, to take over and introduce the topic, and after that, Makbul sir can introduce the speaker.
Thank you. Good afternoon, everyone. And it has been a pleasure again doing session along with Dr. Makbul Dhar, whom I have been closely associated when I took over as president of IPS North Zone in Srinagar, and we had a lovely time at that particular point of time. So, good afternoon, Dr. Dhar. The scientific session starts with the key speaker, Dr. Sandeep Grover, for this postgraduate development program.
So you are not fully audible. Can you be a little louder, sir?
Okay. Am I audible, Dr. Tajmul?
Now it's fine, sir.
Okay, great. I was just saying that it has been a pleasure again co-chairing the session with Dr. Makbul Dar, with whom I had been when I took over as president of IPS North Zone in 2016 or 17. At that time, I had a good time with him. Now, as far as the PG development program is concerned, we all know the theme is metabolic syndrome and the psychiatric disorder. And this is the first session. And we cannot have a better person than Dr. Sandeep Grover to start the first session. And we all know Dr. Sandeep Grover. So I do not want to go into the detail. And he has been most, as somebody has rightly said in the inauguration, that the people envy because he is visible everywhere. The reason he is visible everywhere is he's sincere, hardworking, and good orator. So that's the reason why he is there and he's wanted by everyone. And we also wanted to start the session with him for this. The first topic is that he's going to talk about the concept and the clinical assessment for metabolic disorder. We all know that metabolic disorder, just to give you a 2-minute brief, that metabolic disorder is a collection of risk factors which increase the chances of developing heart disease, stroke, and diabetes. Why it is relevant to psychiatrists? Why we have chosen the theme? This is very important because this is particularly relevant to the practicing psychiatrists as well as the people who are becoming psychiatrists. Am I audible? Because at this end the light has gone. Am I audible?
So you are audible, yes, sir.
This is important because there are many disorders in psychiatry which has been associated with the metabolic syndrome, as well as our psychotropic drugs, particularly the antipsychotics. They are notorious to cause, specifically the second generation, the increase in the blood pressure, weight gain, and the lipid and glucose level. The risk factor, because we do not know exactly, but yes, there is a combination of genetic and lifestyle. Diagnosis, I'm sure Dr. Grover is going to talk about in detail how that clinical assessment should be done. But usually there is no unanimous approach and there is a difference in the opinion as far as the various guidelines are concerned, even of the WHO. But they all agree that if you have three or more of the following, like waist circumference, high glyceride level, increased blood pressure, high density, low high density lipoproteins, and elevated blood sugar. If you have three of these, then natural. Why it is important? Because the prevention is very important. And what the Keda surgery book beautifully says, what mind does not know, eyes do not see. So if as a budding psychiatrist, you are not aware of the entity, probably you are not going to look into it. And with this, there is no set treatment as such. We need to manage individually the risk components. With this, I'll request Dr. Maqbool Dar to take over later on and do this conclusive part or the conclusion part. But with this, I invite Dr. Sandeep Grover to the podium and start his talk, please. Dr. Sandeep Grover.
Thank you, Chairperson. Thank you, Chairpersons, and my dear friend, Dr. Majid and Dr. Sandeep Goyal, and the CME Chairperson, Dr. Rajesh Rastogi, for asking me to speak on this topic. This topic is very close to my heart because of particular reason that I have done a lot of research on this area. But what I'll be doing is I'll be just talking about the basics of metabolic syndrome, because all other speakers are going to talk to you about what are the factors which are responsible and how we can manage. So my basic focus would be on the clinical assessment of the metabolic syndrome. Am I audible?
Huh? Hello?
Hello? Yeah. So, am I audible to everyone online?
Yeah, sir. Yeah, you're audible.
Thank you. Thank you. So let's first understand why do we need to bother about metabolic syndrome or the metabolic abnormalities. Slides नहीं चल रहा है यार. Yeah. So if we want to understand the impact of metabolic syndrome, what we need to understand that this metabolic syndrome is associated with high risk of cardiovascular mortality. And it is very clear that about all patients who have metabolic syndrome die about 20 to 30 years before compared to that of general population. And those who have metabolic syndrome, especially the people with severe mental illnesses, die about 20 to 30 years before the general population. That's why it is very important for us to understand metabolic syndrome. And the other important aspect, which is becoming more and more clearer now, that as we are aging and we are seeing more and more of elderly people living long life, now the metabolic syndrome has been linked to development of different kinds of dementia, including Alzheimer's dementia. And now we understand as something as metabolic cognitive syndrome. So from three different aspects, one is the mortality, second is the morbidity, and third, in terms of development of dementia, the metabolic syndrome plays its important role. And if we look at the different mechanisms for development of dementia, now we have clear indication that metabolic abnormalities influence the accumulation of the tau proteins in the brain and also lead to the white matter changes in the brain, and that is where it contributes to both kind of vascular dementia and also the Alzheimer's dementia. So if you look at what are the most
important causes of mortality in patients with severe mental disorders, you will realize that cardiovascular diseases, suicide, and the cancers are the most important in the so-called causes of mortality. And if you look at this, cardiovascular mortality and the suicides are the most important causes of premature mortality. So that's where we need to understand this important risk. And when we look at the cardiovascular diseases, there are two different kind of risk factors. One are known as the modifiable risk factors, the other are known as the unmodifiable risk factors. And when we try to understand the modifiable risk factors, we need to understand that if we are able to identify some of the modifiable risk factors, if we are able to modify them so that we can intervene at the earliest so that the patient's life can be prolonged. So that is the importance of understanding the modifiable risk factors. And when we look at the modifiable risk factors, the most important modifiable risk factors which emerge are the diabetes mellitus, the hypertension, the abnormal lipid profile, the tobacco use, the physical inactivity in people, and the obesity. Now you look at this all independently, all of them are independently associated with development of the cardiovascular morbidity and mortality. And once they are occurring together, they increase the risk of mortality further. So that is an important thing. And when we look at the unmodifiable risk factors, we have the unmodifiable risk factors in the form of age, gender, race, and the genetic variables which may be there with the people, those which we cannot modify them. But if we know that these are the so-called people who are at high risk, those who carry this, again, you will identify high risk people and you can start your intervention early. And how the metabolic syndrome develops or the metabolic abnormalities will develop, that it basically starts with the unhealthy lifestyle of physical inactivity, cigarette smoking, and so-called high diet with high fat and carbohydrates. That will lead to high-risk diseases like diabetes, hypertension, coronary artery disease, cardiovascular diseases, and ultimately the end organ damage. So when we talk about metabolic syndrome, we are not talking about a person having diabetes or hypertension as diagnosable diseases. That's the first thing which we need to understand. Or neither they have diagnosed dyslipidemia. They are at a high risk of developing diabetes, hypertension, or dyslipidemia. That's the important thing. So the intervention when it comes to metabolic syndrome is not in real sense pharmacological. It is preventive measures. So if we don't intervene a person having metabolic syndrome, he is going to go on to develop diabetes, hypertension, cardiovascular disease, cerebral vascular accident. So how the metabolic syndrome has been defined? It has been defined as an abnormality which is composing of a cluster of abnormalities which includes the glucose abnormalities, the abdominal obesity, abnormalities in the lipid profile, and the elevated blood pressure. So that's the thing which you need to remember. And are there any other alternative names to the metabolic syndrome? So the other alternative names include the syndrome X or the Raven syndrome, the chaos, GHO, or the metabolic syndrome. So basically, these are various synonyms of the metabolic syndrome which are presented in the literature and which as clinicians we need to know. The Raven syndrome is used as a name because he is the first person who described the concept of the metabolic syndrome. And are there different definitions of metabolic syndrome? I think all of you must be aware that we have various different definitions of metabolic syndrome, starting initially with the WHO definition, then the most popular ones which came as NCP ATP3, then the International Diabetes Federation definition, and then the American Association of Clinical Endocrinology and the National Health and Nutrition Examination Survey. So, but now what we have, the most common definition is the consensus definition. And in terms of different components of metabolic syndrome, if you'll see that basically different definitions have used different components to understand metabolic syndrome. And this basically again include something like glucose intolerance, which has been studied. Some people have initial definitions have used GTT as one of the parameters to evaluate glucose intolerance, but later on definitions have used something like only the serum glucose levels. Then you have earlier studies used BMI, but now we are using more of waist circumference based definition. Then you have blood pressure based definition, the triglyceride, the HDL, and other definitions. Earlier definitions had used urinary albumin-free excretion and the 2 hours glucose challenge test. But if you look at the different definitions, there are certain commonalities in these definitions and there are certain differences. The most common, if you look at the blood pressure, the raised triglyceride, reduce HDL levels, increase blood pressure, increase waist circumference, and the raised waist fasting blood sugar level. And when you try to understand the consensus definition, you will see that now we have a consensus on with regard to the blood pressure, as blood pressure should be more than 130 by 85. And again, you need to remember when you're remembering the blood pressure definition, it is not both. It is either the systolic is more than 130 or the diastolic is more than 85. You don't need to have both the abnormal readings to define blood pressure. That's the important aspect which you need to remember. Then in terms of triglyceride levels more than 150 milligram per deciliter. In terms of HDL, again, you have gender specific that for women less than 50 and men less than 40. And in terms of the fasting blood sugar, again, the consensus now is more than 100 milligram per deciliter. And again, for the waist circumference, again, you have the ethnic cutoff. So that is again important to understand that 2 things. One is the HDL, which has gender specific cutoffs, and the waist circumference where you have the ethnic level cutoffs to understand. And in terms of defining things, the consensus definition just requires any 3 of them to be present, whereas the so-called IDF criteria earlier required the waist circumference and the mandatory criteria and 2 out of other 4. But now that mandatory issue has gone away, and we are just talking about the so-called any 3 of the criteria. That's one thing you need to remember. But if a patient has already been diagnosed with diabetes, hypertension, or dyslipidemia, and they are getting treatment for that, then although these levels may be normal, suppose somebody who is getting treatment for hypertension, he's on antihypertensives, and his current blood pressure is, let's say, 120 by 80. That does not mean that he does not fulfill the criteria. He still fulfills the criteria because he's on treatment. Same holds true for blood sugar and dyslipidemia. And when we're talking about dyslipidemia, here we're talking about both increase triglyceride levels and reduce HDL levels. So that fact again needs to be remembered. So except for waist circumference, for others, if the patient is on treatment, you need to remember that the criteria will be counted irrespective of the current reading. Okay. Yeah. So this is the basic thing. And in terms of ethnic cutoffs for waist circumference, again, you need to remember that for men, it is 90 centimeters, and for women, it is 80 centimeters. Again, these are ethnic specific, and for Asians, these cutoffs are to be remembered because Asians are considered to be at a much higher risk, because as India is now emerging because already we know that India was considered as a diabetic capital of the world. Now India has become both capital of diabetes and hypertension in this world. So we should be very, very much aware of this fact. And the other fact which we need to be aware of that about the metabolic syndrome, that all metabolic syndrome in patients with psychiatric disorders are not attributed to psychotropics like antipsychotics or mood stabilizers. Studies have shown that drug-naive patients of severe mental illnesses like schizophrenia, bipolar, although they have not been exposed to antipsychotics, but still the prevalence of metabolic syndrome in them is much higher compared to the healthy general population. So that's where we need to understand that metabolic syndrome is an integral part of so-called severe mental illness. And what could happen if somebody has metabolic syndrome? Again, as I've talked about earlier, that we talk about people developing cardiovascular diseases like the coronary artery disease or cerebrovascular disease, but the things don't end up there. You can see a lot of PCOS in women. You can see, as I said, metabolic cognitive syndrome in people. Then these people are at higher risk of developing diabetes, hypertension. These are again important to remember. And something which has emerged in recent times is NAFLD, that is non-alcoholic. Yeah, yes, anybody? Steatohepatitis. Okay, so NAFLD, again, you need to understand that we ordinarily as psychiatrists, we talk about something, but we hardly pay importance to the liver of the patient, which actually metabolizes all your psychotropics. And as the fatty liver increases, it has its own problem in metabolism of various psychotropics. That's the other thing which you need to remember, that we don't talk too much about NAFLD or the NASH. So we again, most of your patients, if they are sent to hepatologist, they will make a diagnosis of NASH or NAFLD, and you don't understand what are they saying about. But again, the management will remain same as prevention. So that's the important thing for us to remember. And so besides metabolic syndrome, because metabolic syndrome we talk about only in relation to the cardiovascular morbidity and mortality, are there any other alternatives to metabolic syndrome in so-called medicine where we assess the so-called cardiovascular risk? So these are certain other alternatives which we need to remember. That is the Birmingham function, and the other is known as the score, which is known as the systemic coronary risk evaluation score. So the score basically evaluates. Can people mute themselves, please? Please mute yourself, please. Those.
Or otherwise, except the chairperson, you can mute everyone. Thank you.
Yeah. So the Birmingham, the Birmingham score and the function, the score, again, these are the alternative methods. And the Birmingham score basically evaluates the 10-year risk of developing cardio or the coronary heart disease, whereas the score evaluates 10-year risk for the mortality. That's the important thing. And besides the metabolic syndrome as the 5 abnormalities which take into account, in these we take into account other factors like smoking, the age, and the gender. So these becomes important in evaluating the risk of either morbidity or the mortality. And when we look at this, the different scores are given for the age, the amount of smoking which you are indulging in, or the HDL levels and the other abnormalities which you have. And then you calculate the total score. And based on the total score, you will evaluate what is the risk of person developing the so-called coronary artery disease or the cardiovascular mortality. And similarly for the score, again, you have different parameters for the smokers, non-smokers, and depending on the various age, the blood pressure and other things, you determine the score, and depending on how much the person scores overall, you will determine his risk or her risk about developing the cardiovascular mortality. And so these are all online calculators which are available, which you can use to calculate these scores. Now, after understanding this basic concept, let's try to understand, so as a psychiatrist, what kind of history you need to collect while evaluating a person with possible metabolic syndrome. Because history is an integral part of understanding the various metabolic abnormalities. It is not just the investigation of it. So in the history taking, what we need to focus on is the personal history. The personal history will evaluate understanding the patient's history of diabetes, hypertension, obesity, smoking, alcohol, the lifestyle, the dietary habits. Does the patient already have some cardiovascular accident or the coronary artery disease? Or there is a history of TIAs, because that's, again, psychiatrists are not oriented to take these histories. We usually focus on, do you have depressive symptoms? Do you have psychotic symptoms? And then we write our negative history without possibly bothering about these factors. So taking a history of the TIAs and the history of weight gain with psychotropic and any evidence of neuropathy. These are the important aspects when you're taking the personal history. We do not move beyond psychopathology. My friend Ravi is sitting, so he will say that always add the history of taking snoring, okay, and the midnight awakening. So those are, again, the important aspects when you're evaluating somebody for OSA, and metabolic syndrome has a very, very strong relationship with OSA. So in psychiatry, because a patient comes and reports that I'm not able to sleep, the general tendency of the psychiatrist is to put him on a medication or a sedative or a hypnotic to sleep, which actually may be counterproductive if he actually has a obstructive sleep apnea. And the other factor which again comes in is when you are using clozapine. with clozapine, patient will develop metabolic abnormalities, developing hypersalivation, and reporting sleep disturbance. He may be actually reporting over-sedation. So these are the factors you should not forget about looking at when you are evaluating a patient's psychopathology. But it's not just the personal history which matters. The family history of, again, the same factors as the obesity, hypertension, diabetes, the cardiovascular disease, or the the cerebral vascular disease and the coronary artery disease, and history of any sudden death in the family. These all, any history of sudden death in the family should be considered as an indicator of either a cerebral vascular accident or a coronary artery disease. So if you are focusing on that, there are more chances that you will not miss out on anything, and having these information will actually in deciding about what psychotropics you may be choosing. If a patient already has a lot of risk factors, you may think of choosing an agent which is less likely to cause weight gain or the metabolic abnormality. So those are the important facts which you need to remember. And then once you have taken the history, the other fact is the physical examination, on which we psychiatrists are possibly very poor. And I always believe in this, that we psychiatrists actually train our students also to practice psychiatry as no touch technique, which I mean no touch technique means we will not touch our patients, as if either we are untouchable or our patients are untouchable. We need to develop this habit of evaluating the person physically. I think that is the most important thing we need to understand. We are first physicians, then psychiatrists. And if we forget our role of a physician, I think we are doing injustice to our patient, because if you touch your patient, you will carry out a good physical examination, you'll get a lot of evidence for the metabolic abnormalities. So the measurements involves evaluating the height, the weight, the BMI, the waist circumference, and the blood pressure. As simple as that. All of you think that we all know about all this, why I'm speaking, but I'll just try to see how much you understand this. So height, how do we measure? Because this is an online session, so I'm not also interacting with you people, because you people don't have a mic there. So how do we measure height is again very, very important, because many of us do it very casually. So we should, when you're evaluating the height of the person, you should ask them to remove all shoes and the socks, make the person stand very close to the wall on a flat surface. If there are carpets or other things, those can be removed, and make the patient stand with the neck to the wall, which is straight, and your shoulders are also very straight, and record the height at the minimum level of about 1/8 of the inch or 1/10 of the centimeter. Again, if I ask all of you, how many of you actually do measurement of the height of your patient? How many of you would like to raise your hand, or you send it to the nursing staff? How many of you do yourself? Yes? Yeah, I'm just seeing 2 hands. That's where I'm saying that we need to change the practice. Okay, because your nursing staff may not be following this habit. Then, how to measure weight? Again, very simple for us, send it to the nursing staff to measure the weight. But again, are they following what you want or not is an important thing. So measurement of weight should be again done by removing various removable items on the patient's body. For example, in the winter, if you measure the weight of a person with all the jackets and everything on, his weight may actually appear higher than what it is actually. So practically, if at all it is possible, that the body weight should be measured with minimum clothes on the body, and all accessories, simple like mobile itself, should be removed, because many mobiles can weigh up to half a kg. So you need to understand that these facts need to be kept in mind. The nursing staff will not keep that in mind, and you may get fallacious reading. And the other fact which you need to understand, the so-called weighing machine which you are using. Is it an electronic machine? Has that been calibrated properly or not? Is the calibration checked from time to time or not? And for example, if the 0 is setting every time when the person, nobody is on there, the minute and the nursing staff will not bother to check that either it is at -2 or +2, and they just make the patient stand and then give you the recording. But that will again give you a fallacious reading. If the machine is already calibrated at -4, then you're actually recording the weight 4 kgs less, or it is set at +4, then you may end up recording the weight 4 kgs more. all of us know this BMI formula. So the height and weight will be used to evaluate the BMI. And although the metabolic syndrome definition does not use BMI, but BMI is used at various other calculations. That's why it's very, very important for us to calculate BMI. And again, this is one of the common questions your examiners are going to ask. What are the cutoffs of obesity? And most of the students, I can tell you, end up giving wrong answer. And anybody can answer this question? What is the cutoff for BMI? Yeah? 18 to 25, yeah? Yes, 20. Okay, we will see that. Okay, we will see that. Okay, yeah. So if you need to understand this, that yes, some of you said that above 30 is obese and above 25 is pre-obese, but remember this thing. Now, what comes in the next slide? This does not hold true for the Asians. Okay, the Asian cutoff for obesity is 25. Okay, it's not 30. Please remember this. We Asians are at a very high risk of metabolic abnormalities. So the cutoff is 25 for the Asians, not 30. And suppose, for example, you are involved in a bariatric surgery unit and everything. In the Western countries, the cutoffs, they use more than 35 for bariatric surgery or more than 40. In Indian setup, more than 30 is an indicator for a bariatric surgery. So that's where it's important that you need to know what are the cutoffs. If you don't know the cutoffs and you just keep on speaking the Western cutoffs in the exams, many of you will have trouble. So remember the Asian cutoffs of the waist circumference and the BMI. They are different from the Western cutoffs. Then what are the different types of obesity? Because this is the crux of the whole concept of the metabolic syndrome. And when we look at this, this is what we understand as the apple and the pear obesity. Now, the apple obesity is the most difficult one and is the major risk factor for the coronary artery disease or the cerebral vascular disease. And if you look at this, the apple is that you have excess of fat in the abdomen. That's mostly the male are involved, and this is the most important significant risk factor for the metabolic syndrome. Whereas the pear obesity, you will see the excess fat in the thighs and in the buttocks, and this is again more common in women, and it is not associated as closely with metabolic syndrome as the apple obesity. Let's look at these figures now. Okay, I'll come to that figure. Sorry. So if you look at this, that the apple obesity is actually associated with all kind of metabolic disturbances. If a patient has an equivalent BMI, the BMI is both the patients is similar. If you look at this figure now, that the age of these two patients are almost similar, and their BMI is again same, 35.4. But if you look at the waist circumference, the patient A who has so-called pear kind of obesity, the waist circumference is 95, whereas the other person has the waist circumference of 100. And if you look at the other parameters like cholesterol, LDL, HDL, and everything, they are raised in a person who have apple kind of a obesity. And so due to the increased waist circumference, there is other metabolic abnormalities start, and it is understood as the basic concept is because of the insulin resistance. I'm not going into it because we have other talks there. So if you look at here, the waist circumference 95, BMI 35.5, but it's the clear kind of an obesity. Still all metabolic parameters are normal. So that's where you need to understand that. So how do we measure the central obesity or the waist circumference? So that's again, my students who are here, they know that this is again one of my favorite questions. And again, I always feel that many people again don't know how to assess. So anybody would like to take up this question here? Yeah, please go ahead.
Firstly, we'll draw a plane from the highest point on the iliac crest, and then other plane on the lower costal margin. Then vertically at the midpoint of the two, we'll measure central. We'll measure the
very good,
abdominal girth.
Yeah. So what we need to understand when we are trying to measure the central obesity, there are two concepts. One is the measurement of the waist circumference, and the second is the measurement of waist-hip ratio. So what you said rightly, how to measure waist circumference, I'll just elaborate on that. So the absolute waist circumference for, again, the Western population is 102 and 88. But for the Indian population, the cutoffs are again 90 and 80. I'm just repeating this. And for the waist circumference, again, the cutoffs for the ratio is more than 9 for men and more than 0.85 for women. So if they are more, again, these indicate the abnormal. So how do we measure the waist circumference? Again, many people have talked about different levels. Please understand this. That's why some people will say that you measure at the level of umbilicus, which is actually not the right way. Some people say you measure at the level of iliac crest. Some definitions use the measurement at the iliac crest, but the most accepted level of measurement of waist circumference is, as he rightly said, the midpoint between the lower costal margin and the anterior superior iliac crest. But there's a catch further now. Anybody wants to take it? How do you do that? Yes. So when you are measuring that, you need to measure that by using a retractable tape and at the end of normal expiration, not the inspiration. Again, many times we don't give importance to this, but in clinical practice, it is very, very important to understand this, because I don't want a patient who deserves clozapine. I just say measure his waist circumference in expiration and the inspiration, and then say no, his waist circumference is very high. He already has a lot of metabolic risk and don't want to use clozapine. So you have to be very, very careful when you're strategizing, deciding about your patient. And the hip circumference is measured at the widest circumference. And so if you remember that the so-called NIH criteria talks about the iliac crest and the WHO criteria talks about the midpoint. So that, again, you need to remember when you're deciding about the so-called the waist circumference. So again, you can ask the patient in today's world, because when we are living in a telepsychiatry world, the biggest problem is you tell your patient that, okay, you get your blood test done and you do get his blood test done and he'll send you the report, isn't it? But what about the waist circumference? What about the height? He may still take help of his family members and measure. Or the weight, he has a weighing machine at home and he will measure. What about the waist circumference? So that is where you need to teach the person how to measure the waist circumference. So ask them to stand in front of a mirror, undress themselves. What I have told, that use a retractable tape, measure at the end of the normal expiration. Okay, so that's where you need to ask the person to measure. And similarly, in the so-called the waist circumference, the hip circumference, again, that can be measured by just standing in front of the mirror. The person himself can do for themselves. So many of you would have been planning your thesis on metabolic syndrome, and because of the pandemic, patients are not coming to your OPD, you would have cancelled it. So that's where I would say that it's still feasible if you know the right technique and if you're able to guide your patient to measure the things in the right way. Okay. And if you try to understand the different cutoffs, again, which have been talked in different guidelines, again, as I said, for men, if the waist hip ratio is more than 90.95, and for women, if it is more than 0.86, these are problematic. Otherwise, any of you can go home and measure whether you are in the excellent range, good range, or the average range. And you can decide about what you need to do for yourself. Okay? Okay. Now, how to measure blood pressure? Yeah. How to measure blood pressure? The blood pressure needs to be measured, again, at a particular way. How many of you are able to do it yourself? And how many of you know the right technique? Yeah? Okay. Anybody wants to take that question? Yes? Give it to her. Yes?
So first of all, we'll ask the patient to sit comfortably for a period of about 5 to 10 minutes. Then we'll apply the cuff about 1 to 2 centimeters above the cubital fossa. And then we can measure by means of palpatory method or auscultatory method. So we have to inflate the cuff first about...
Okay.
Yeah, then we have to follow the method, whether we are doing by auscultatory or palpatory method.
Okay.
A patient should not be caffeinated. He should not have had tea or coffee. and he should be sitting calmly for a period of about 5 to 10 minutes.
Okay, fine. So what we need to again understand that you need to undress the part where you're applying the cuff, make the patient sit comfortably on a chair. Both the feet has to be on the floor properly. The hand where you are measuring the blood pressure at the heart level. Okay, measure the 3 readings, take the lowest of the readings, measure the readings in both the hands and take a mean of that. So because the organizers are asking me to a bit faster, so I'm just skipping this part of it. But again, you need to remember 2 things: the positioning, number of readings, and both the hands. So again, very, very important. Most of the residents again think that by MBBS training, we know how to measure blood pressure, but I feel that this is something which we all need to again practice it well. And in terms of investigation, again, all of you know about the investigation, that fasting blood sugar, PPBS, and HbA1c, because many times the fasting blood sugar may not give you a correct indicator. So HbA1c gives you a much better idea, the lipid profile. And as I said, there's a risk of NASH, so getting an ultrasound abdomen again is often helpful. And you need to understand when you're collecting the sample, it has to be overnight fasting sample. You cannot take the sample after the patient has taken the food in the daytime. And what else do you look at the physical examination? Again, this is something which we often overlook. So you need to look at the so-called xanthellae, which may be indicators of the disturbed lipid profile. And you can just look at the eyes of the patient. That can give you a lot of ideas about the various features of dyslipidemia, or the tendons, close to the tendons, you can see the xanthellae. That will give you certain ideas about what kind of lipid abnormality the person may be having. You don't need to do the investigations there. So there are different sites where you look for different kind of xanthellae, and that's again an issue of practicing the same. Then we talk about the carotid brew. Again, you need to understand here that the carotid brew can again give you some idea about the systolic heart and how things are functioning there. And maybe you can again do that, but you should not be palpating or so-called disturbing the carotid much. If there's a so-called thrombus already there, it can dislodge and it can cause the problem to the patient. Then the physical examination, about just asking. Again, most of our psychiatric patients will come and say that they are having numbness, tingling, and nobody has investigated them over the years. Actually, they have already developed diabetic nephropathy. The neuropathy. So that is where you need to understand that. Look for the signs of neuropathy. All the patients have never been evaluated for diabetes, but maybe they may be having signs and symptoms of the neuropathy, and the typical glove and stocking kind of neuropathy may be there, and patient may be having also so-called muscle atrophy. So that's again which you need to remember. And if you have good friends in ophthalmology, or you have your spouse there, you remember to get your patient screened for the diabetic retinopathy, where you will see that there are cotton wool spots kind of thing you will see. Or if you have want to look for the hypertensive retinopathy, where you will see the hard exudate kind of thing, that's where you need to focus on. And remember that the metabolic assessment is not just a one-time assessment. You keep on evaluating the patient over the time, baseline at 4 weeks, then maybe at 8 weeks, 12 weeks, then 6 months, and then yearly. So that is where we need to understand the importance of evaluating metabolic syndrome in our patients. Thank you. So save the heart of your patients. That is going to make you happy. Thank you.
Okay, there, please. You want to
Thank
comment?
you.
Thank you, Sandeep, sir.
Thank you, Dr. Sandeep. Thank you, Dr. Sandeep. Thank you very much. It was a wonderful presentation.
Thank you,
you talked about history taking, including personal history, then about family history, physical examination. You talked basics of this metabolic syndrome. So thank you very much. It was a wonderful presentation. So my good wishes and Assalamu alaikum, Dr. Savita Malhotra and other senior psychiatrists there, and including and other chairperson, Dr. Rajesh Rastogi. Now, may I have we have any queries from the students, please?
Yes, Dr. Dhar, I am taking that. I have that.
Okay.
Dr. Grover.
Yes, sir.
Oh, you spoke very lucidly, clarity-wise, and in a simple fashion. Beautiful. Now we are having few questions.
Sure, sir.
And that, in fact, reflects that the people are interested in knowing more from you. The first is, who is going to treat? There are two, the content is similar, but two people have asked in different language. Who is going to treat? The physician or the psychiatrist? Or shall we start the treatment as the patient comes for the follow-up if the patient is developing metabolic syndrome, or shall we refer to a physician? That is the first question by Dr. Vimal and Dr. Rahul.
Okay, thank you, sir. Thank you for the participant who have asked this question. As I said, one important thing to remember, metabolic syndrome is a syndrome in which we want to prevent the development of further metabolic abnormalities or the diagnosable diseases. So, as if you send these patients to busy clinicians, to endocrinologists or cardiologists who already have their clinic packed, they are not much interested in talking about the preventive cardiology or preventive endocrinology. It's your job as a psychiatrist to treat metabolic syndrome when patient has not developed the diseases like diabetes or hypertension or dyslipidemia. So the preventive measures, so the so-called physical exercise, dietary modification, this all can be done by the psychiatrists themselves, number one. If a patient develops diabetes, hypertension, then it requires a close network between the psychiatrist and the so-called cardiologist or the endocrinologist to manage these abnormalities in people. The psychiatrist, for me, should act as a so-called the liaison or the person who will be mainly responsible for coordinating the treatment, because the patient primarily belongs to you, and you will be able to better address the issues of the patient than the endocrinologist or the cardiologist. So the decision about starting medication will lie with the cardiologist or the endocrinologist, but the other aspects should be taken care by the psychiatrist.
Another question from Dr. Sheena Shah from Srinagar. Sir, it is possible to have low subcutaneous centripetal fat, but high visceral fat. How do we then determine the risk?
Okay. So when we talk about the metabolic syndrome, again, as I said, the basic emphasis should be on evaluating the waist circumference when we are talking about the fat, because the basic focus is at the waist circumference. So we talk about subcutaneous fat or visceral fat, but the basic fat, visceral fat, which accumulates and is responsible for the metabolic syndrome is the waist circumference. So that is what we need to keep in mind. That's why you need to understand when I talked about the peer kind of obesity, the women have more fat around the thighs and the buttocks, but still they are not at that risk of metabolic syndrome as compared to men or women who have high fat in the abdominal area.
The next is how to create awareness about psychoeducation simultaneously with pharmacological prescription of psychiatric illness. This is from Dr. Bharti Monpuria from Jaipur.
Again, the important thing here to remember is a change in attitude of the psychiatrist, that they should first start understanding their role, which I already have said in my talk, that we are first physicians and then psychiatrists. So we should not forget our role of physician. And it is a habit which we need to change, that we want to provide a holistic care or a person-centered care for our patient. Not just, we are just not that, okay, I'm treating psychosis, you have this problem, go to the endocrinologist. You have this problem, go to a gastroenterologist. You have to talk about a person-centered care. So you need to be the main coordinator, coordinate everything, and then that should come as part and parcel of your psychoeducation. When you want to start psychotropic medication, it's your responsibility to inform the patient that the patient will require dietary modification, the physical exercise and everything as part and parcel of using psychotropic medication. We, in fact, in practice, we neither talk about the side effects to our patients, neither talk about the preventive measures.
Then, just a second. Should the treatment, this is from Dr. Rahul Chakravarti, should the treatment, it has already been answered in the sense by a referring physician, then how to treat? There are a number of questions on the treatment. I think this is not the topic for the treatment. We have further sessions. Dr. Naresh is going to talk about epidemiology, and then Dr. O.P. Singh, and then others. So we can take up that questions little later on. But there is one question here: diabetes and antipsychotic. This is from Insha Malik. Very wide questions, but if you can just answer in a minute. Antipsychotic. I think she is asking probably the role of antipsychotic in creating.
Yeah. Okay. Fine. Number one, yes, the various antipsychotics increase the risk of developing diabetes, and those who have family history of diabetes are much more prone to develop diabetes, and they develop diabetes earlier than people those who do not have a family history of diabetes. So antipsychotics definitely does increase the propensity to develop diabetes mellitus in people, and that is why we need to keep on screening our patients, which I have already emphasized, from time to time for diabetes mellitus. But at the same time, which I practice, so that's why I'm saying it. People may agree, may not agree. But if a patient has a comorbid diabetes mellitus, but he has a disorder which requires use of antipsychotic, you should not stop yourself from using antipsychotic. You should treat the disease or the disorder properly with institution of the preventive measures. That you still focus on the patient's fasting blood sugar, the physical activity, and the diet.
I think we still have 2 minutes, and we can take one more questions. Though it is on the treatment, and I can assure
any questions. Yeah.
I can assure you that there are number of sessions like treatment of depression in diabetes, the relationship of metabolic syndrome and sleep, the diabetes mellitus and dyslipidemia management, and finally we have a panel discussion that should psychiatrists treat. But the last question to Dr. Sandeep Grover is treatment of nephrotic, treatment of metabolic syndrome, if suppose you can say in a minute. Sir.
So as I just need to repeat that metabolic syndrome do not equate it with diagnosed diabetes or hypertension. It it should not be equated with triglyceride levels of more than 150. Should not be equated that you have to use an anti-lipid agent for these patients. No, the first thing you comes to your mind is focusing on patients' physical activity and the diet. So the simple measures are actually the treatment. If you think about treatment perspective, but recognizing metabolic syndrome is actually you want to prevent development of more deadly diseases in future. So you do not require pharmacological management until unless the patient has diagnosable diabetes, hypertension, or dyslipidemia.
There is one more question from Dr. Anjali. The prognosis of psychiatric illness due to metabolic syndrome by Dr. Anjali.
Sir, I have already said this again, that the mortality rates are much higher in patients who have higher rates of cardiovascular diseases, diagnosable diseases, and there is in terms of morbidity, we have more coronary artery disease, we have more risk of developing various kinds of dementia, the cerebrovascular accident. So from that point of view, prognosis wise,
I think we should stop, finish now the session.
Still there is 1 minute till 4 p.m. Still there is 1 minute. We are within time. Don't worry.
Sir, there are people on the floor here. They want to ask 1 or 2 questions.
Yeah. So please let them ask. Yeah, let them ask. We still have 1 minute to 4 o'clock, and we started little 2 minutes late, so we can.
Sure.
Okay,
I have no problem, sir. I have no problem.
Okay.
We can allow 1 question, okay, from the floor.
Sir, while discussing about the metabolic syndrome, usually we talk about TG, we talk about cholesterol, but the main predictor of a cardiovascular risk factor, that is an apolipoprotein B48 and lipoprotein A.
Yeah.
I want to know about your say about that.
See, again, when we understand the concept of metabolic syndrome, we need to understand that these are the more biological parameters which cannot be done routinely in clinical practice. So if you want to take the patient for these kind of costly investigations, which cannot be practiced in day-to-day practice, the compliance is actually going to go down further from the clinician. If you ask me, I always tell my residents, do only one thing, measure the waist circumference. That is the best indicator, because that is the most common abnormality in patients with metabolic syndrome. You look at across the studies across the world, the most common abnormality is raised waist circumference. So just use the simple measuring tape. You do not require anything. No, it is the cheapest instrument which you can use in your clinical practice to decide whether a patient has metabolic syndrome or not.
Thank you, Dr. Sandeep. No more questions. Thank you very much. Thank you, Dr. Tajamul.
And in that, we would like
No more question, no more question, please.
Thank you. Thank you, Dr. Sandeep Gaur, sir.
the organizing committee for providing this session along with my co-chairperson, Dr. Maqbool. Thank you for the Executive Council of IPS North Zone. Thank you.
Thank you so much, sir, for participating. Thank you so much. Before we conclude this session, we have, at the end of each session, we have kept prizes for the participants who are most active and who ask the best question. So the at the end of this session, I think
Rastogi sir, are you there? If you could tell us.
Yes.
If you are there and you could.
Yeah, but it would have been much better if I can tell along with Dr. Maqbool Dhar, Mohammad Ahmad.
Sir.
So just a minute. Dr. Dhar.
Okay, sir.
If you are in agreement, then shall we take this question about the centripetal one? That it is possible to have low subcutaneous centripetal fat but high visceral fat. How do we determine the risk? Shinal Shah from Srinagar.
Okay.
Okay,
Who is the person? You are here? Who has asked it?
This is online.
He's not here. Okay. Thank you very much, sir. So we have two people actually. One who has asked the best question and one who was the most attentive during the session. And congratulations to both of them. Yeah. And they have participated actively. That would encourage others to participate as well rather than playing with their mobile phones. Thank you very much. Dr. Alia and Dr. Sabha can come and collect it for Sheena. You can give it, I will give it later. यार अपने colleagues को photograph उठाओ ना. Thank you very much, Dr. Alia, Dr. Sabha. So then we have the memento for chairpersons. Online will be delivered later on, but offline we have moderator first, Dr. Tajamul. Kindly come forward. Dr. N.N. Raju would do the honors of giving memento to Dr. Tajamul, who is heading the Department of Psychiatry at GMC Baramulla. Thank you, Dr. Tajamul sir, for gracing the occasion. Then our speaker, the person who has started the show, Dr. Sandeep Grover. Thank you very much, sir, for deliberations. And thank you, Rajesh Rastogi, sir, and Dr. Maqbool, sir. Thank you very much for being the part of very first session of the PGDP 2021. So we move on to the next session. I think we have speakers as well as moderators connected. Dr. Manmeet Singh, are you there?
Yes, sir.
So I can see Dr. Naresh Bhai as well there, the speaker.
Yes, sir. Yeah.
Smiling face always. Thank you very much for joining us. Dr. Manu Arora is as well there. So in place of Junaid Nabi, we have moderator Dr. Manmeet Singh because of some preoccupation of Junaid Nabi. Suddenly he had to leave from this place. Dr. Manmeet Singh is heading the Department of Psychiatry at ESCOM's Jammu. It's a newly born department like ours in SKIMS. Dr. Manmeet Singh, kindly take over.
Thank you, Majid sir. I would like to thank the organizing committee of IPS North Zone for giving me the opportunity to introduce the chairpersons for the second session. To start with, it's really being an honor to introduce the respected Dr. Debashish Basu sir. He's being currently the professor and head of department psychiatry PGI Chandigarh. He is having a teaching experience of more than 30 years. Research projects carry out more than 40. Sir has a publication of more than 300 books and book chapter more than 20. He's being the founding editor of World Social Psychiatry. He is having awards like the NIDA Invest International Research Fellowship Award, NHS International Fellowship, Honorary Fellow, World Association of Social Psychiatry, and Marfatia Bhagwat and Valiant GC Boral and an Oration Award. Sir's main areas of interest is in addiction psychiatry and dual diagnosis as well as the social psychiatry. The next is our colleague from Government Medical College, Jammu, Psychiatry Department, Dr. Manu Arora, who is currently heading the Department of Psychiatry. He has a specialization in DPM and MD Psychiatry from the Central Institute of Psychiatry, Ranchi. Thereafter, he worked in a hospital at Adelaide, Australia, in the Department of Psychiatry. Apart from that, he was past honorary secretary, Jammu and Kashmir Psychiatric Society. He received the prestigious Dr. R.B. Davis Gold Medal Award for his immense contribution in research. Received the prestigious BPSS National Award in 2006 for the best research paper in psychiatry at the annual conference of Indian Psychiatric Society, Mumbai. He has about 35 publications in reputed national and international journals and dedicatedly involved in community mental health programs. Over to you, sir, for the session. Thank you.
Thank you, Dr. Manmeet. Am I audible?
Yes,
Am I audible?
Yeah, sir. Yeah, please.
Yes, yes. Dr. Naresh is joining like me virtually. I think he's also joining virtually.
Yes, sir.
It's always nice to introduce him. Dr. Naresh Nimrani. He works as a professor, additional professor in Department of Psychiatry and head at AIIMS Jodhpur. We've been known to each other for a very, very, very long time. He's an avid researcher, has a number of publications. He's a dear friend. And I think after the ball has been set rolling by Dr. Sandeep Grover about the concept, the understanding about metabolic syndrome, it would be wonderful to understand about the epidemiology. I think we'll just go through that and then we'll have questions. Over to Dr. Naresh, please.
Thank you, sir. Good evening to all. My gratitude to organizing committee for giving me the opportunity, and a special thanks to all the dignitaries present on the dais and dear students and virtually connected seniors and colleagues. Hope I'm audible and my slides are visible. I'll be talking about prevalence of metabolic syndrome in patients with severe mental disorders. Please accept sincere greetings from All India Institute of Medical Sciences, Jodhpur. And I'll try to put some light on this topic. But before that, let me express my acknowledgement to my esteemed teachers at PGI Chandigarh, because when I think that, because my PG started in 2006 and finished in 2008. In 15 years ago also, there was a lot of discussion about metabolic syndrome during the ward rounds and discussion. And somewhere it was inculcated in the training. So I'm thankful to all my teachers, and a special thanks to Grover sir, because I worked under him on various projects of metabolic syndrome, and I continued that interest, and that's why here our team is also working in these areas. It doesn't have anything to disclose. I worked in this area on the metabolic syndrome of schizophrenia, bipolar, depression, who are on treatment, also drug-naive patients of schizophrenia and depression, and also try to see the effect of close-up in the patients with schizophrenia. And subsequently, we worked on cardiovascular risk scores for schizophrenia and bipolar. And later in Jodhpur AIIMS, we started to see the effect of metabolic syndrome on inflammation, liver markers, as well as vitamin D. We thought to conceptualize some service models, and also we tried to work on some piloting on these initiatives. As we know the importance of topic, it is highly relevant because the morbidity is high, mortality is high, as said by Grover sir. And again, thanks to Grover sir for starting with all conceptual things. So my job is relatively easy. And yes, there is a poorer course with severe mental disorder as well as metabolic syndrome. When they co-occur, then it is more difficulty. Further, it increases the cost and issues subsequently we'll discuss. Both the things are pretty prevalent. That's why this is of public health importance, metabolic syndrome as well as severe mental illness. Yes, we need to have more and more awareness in this area. That's why this talk has been planned to fill the gap in practice. Because yes, we don't know many times, but yes, whenever we know, we are not practicing. I'll be briefing later on this. So we'll try to have more reflection as well as quality improvement in our practice as well as service. And yes, finally, I hope we'll be addressing the gaps in the management as well as the screening of metabolic syndrome. So as all the things have been conveyed by Grover sir about the conceptual part of metabolic syndrome. So my job will be to talk about severe mental disorders, the epidemiology of figures, as well as correlates of metabolic syndrome. I'll be broadly targeting schizophrenia, bipolar, and depression. I'll be discussing brief about updated research, and I'll be also briefing about management focus, specifically non-pharmacological and brief strategies, because other topics have been going to be covered by other speakers. As we know, metabolic syndrome is pretty prevalent entity. If we see the general population, then it is around 20%. So 1 in 5 of the individual in general population has metabolic syndrome. But once we see the severe mental illness, then it is about 1/3 of the population has metabolic syndrome as per various systematic review meta-analysis. So presence of metabolic syndrome in patients with severe mental illness could lead to greater disability, considering both the disorders co-occur and cause further disturbance and further burden for the patient as well as family. And here we see the patient with metabolic syndrome along with SMI have greater risk of metabolic syndrome because of their illness, their lifestyle factors, the psychotropics, as well as various healthcare issues we'll be discussing later. Once we just touch upon the metabolic syndrome in SMI, I'll be using SMI for severe mental illness. It is one of the ways synonymous of severe mental disorders. So it has been seen that severe mental illness patients have significantly increased risk of metabolic syndrome. Relative risk is around 1.58. And as per systematic review meta-analysis published in 2015 in World Psychiatry, the pooled prevalence of metabolic syndrome in SMI is around 32%. And the figures for all three broad disorders are almost similar as per this severe systematic review meta-analysis. And they found that correlates older age, higher BMI, and antipsychotics. Dear students and colleagues, since it is about epidemiology and data, so it might look boring many times, but please keep yourself awake because we'll be discussing many clinically relevant things. And again, we'll be waiting for lively interaction later on. Let me start with schizophrenia, and let me start with the patients who are drug naive, because a lot of discussion started to be focused on antipsychotics. So I want to see the people who are drug naive. Here, this is the study pooled prevalence of 3 centers from PGI Chandigarh, AIIMS Delhi, and SCARF Chennai by under Grover sir. So here, 137 patients who are antipsychotic naive or treatment naive presented to the respective clinics, and their metabolic syndrome prevalence was 19%. So substantially lesser than the patients who are on treatment. But here, one thing came very clear, that about 40% of these patients who are otherwise not having metabolic syndrome but fulfilling at least one criteria of metabolic syndrome component. As Grover sir briefed, 5 components to diagnose metabolic syndrome, at least 3 are needed as per consensus criteria or most of the criteria. Another 1/4 of the patients who are not having metabolic syndrome but fulfilling 2 criteria of metabolic syndrome out of 5. So here is the risk group sitting with us, and once we start treatment without thinking much, yes, after some time, the metabolic syndrome prevalence increased drastically. And here we had a small endeavor of the small population of 55 patients with schizophrenia and 55 healthy controls, and we found about 34% prevalence of metabolic syndrome in patients, and while the control were having about 14% of metabolic syndrome prevalence, while another more than 50% of the patients were fulfilling 1 to 2 components of metabolic syndrome, public metabolic abnormalities. And as said earlier, the most common metabolic abnormality we found, higher waist circumference, which is consistent in most of the studies. And about more than half of the patients were obese. The correlates of metabolic syndrome we found again age, weight, BMI, obesity. Dear audience, these correlate or predictor of metabolic syndromes are almost consistent in most of the studies, if we remember. And again, a larger study in schizophrenia, 126 patients with schizophrenia in PGI Chandigarh, it was found again similar prevalence, 36% prevalence, and again similar predictors, additionally duration of illness. And again, one of the study has again tried to see the effect of clozapine under the guidance of Grover sir, published in our IPS North Zone Journal. Here, 60 patients were recruited who were, we were willing to give them clozapine because they were treatment resistant. But what did we do? We assessed their metabolic syndrome profile prior to clozapine. It was 33%. And after clozapine therapy, after 3 months, we again assessed them. That was 53%. And again, most common metabolic abnormality was raised waist circumference. So here we got one more message that whatever metabolic syndrome occurs with clozapine, it is not solely clozapine, but some proportion is contributed by the earlier agents as well as the illness and other variables. But it has opened our eyes for the newer dimensions. And have a look on the broader database. It is a systematic review meta-analysis. And it is the data of 25,000 patients out of 77 studies. And there they found prevalence of metabolic syndrome about 32%. Here the author highlighted there was minor difference between the criteria of metabolic syndrome, as there are several criteria as per different studies. Also the treatment settings, the hospital, community, country or origin, but there was no appreciable difference as per the gender, though some of the studies are found. And they found the correlates duration of illness as well as older age have more metabolic syndrome. And one very important point highlighted in previous session, that waist circumference was quoted as the most useful tool to predict metabolic syndrome. As said, it is the cheapest instrument and the minimum time we need for waist circumference assessment. Patients themselves can do well. Sensitivity and specificity was about 78-79% of the single component of metabolic syndrome to predict MS. And again, another meta-analysis for the Indian study, again, worthy effort by the Niman's team. And here they did assess for 14 studies. They found pooled prevalence of metabolic syndrome 29%. But when they just took the separate group of community patient as well as hospital-based population, there was a wide difference. In community patient, it was 10%, while in hospital-based population is 33%. And the same they try to assess the drug-naive patient, it was about 11%. So again, remarkable difference in drug-naive to the treated patient in terms of metabolic syndrome prevalence. And based on that, they had odds ratio of about 3. Compared to the control, they have significantly higher risk to develop metabolic syndrome. And they also concluded that these figures are comparable to the figures reported in Western countries, as we have seen in another meta-analysis. If we see the correlates, we have covered most of, but again, additionally, regular physical activity significantly decreases the risk of metabolic syndrome. And clozapine significantly doubles the risk of metabolic syndrome, as we have seen in the study as well as in the latest publications. And here the one more correlate is homocysteine. When the cases with hyperhomocystinemia, it substantially increases the risk of metabolic syndrome almost 8 times. And other correlates we have already discussed. But again, one very important variable, they try to see that what about the relapse in the subjects with metabolic syndrome. It was a quoted study, 185 patients, when they followed up for 1 year, and they found about 1/3 of the patients have relapse in 1 year, and metabolic syndrome strongly predicted the relapse. Almost 3 times risk increases once the patient has MS for relapse. So again, it's a clinical concern for all of us. Importantly, the studies have also assessed, does it remain stable, whatever figures we are talking, or it increases or it decreases? Yes, most of the studies have found it increases over the time. From the PGI study, it was from 32, it increased to 41% over the period of 6 months, the metabolic syndrome. And another latest publication, again it increased, but then it further increases when the patients have more daily consumption of added sugar, cholesterol, and fatty acids. And another quoted trial has also found, for which they had 428 patients, and they did follow for 2 years. But they found that whenever the patients have negative symptoms, it predicts poorer cardiorespiratory fitness, their larger waist circumference, their higher HbA1c and lower HDL. But once they see the patients who have better functioning as well as cognitive functions, it correlated positively with cardiorespiratory fitness. That is opposite to the problem. They are more fit and have better HDL levels. And employment of any kind is also going to give them better cardiorespiratory fitness, which is again we know, but we have to apply in clinical practice. Again, the studies have assessed the cardiovascular risk calculator, which Lower sir suggested earlier, and they found a greater risk in the patients with deficit schizophrenia, and especially who are having more obesity. I'll be now touching up to bipolar disorder. And in that, again, in the drug-naive patient, under the group of Manish Patla sir, it was about 1/3 of the population had metabolic syndrome in the drug-naive. And most common abnormality they found, lower HDL level. and they found more association of metabolic syndrome with bipolar depression. But again, most of the patients are on treatment. So the study with 72 patients from PGI, they found 62% prevalence of metabolic syndrome. Another study found 53%. While we are seeing these figures, definitely it is much greater than schizophrenia population. So again, when systematic review tried to analyze, they found about 1/3 of the patients have metabolic syndrome and about 7,000 patients over 37 studies. And again, they found with the greater risk the patients who are older in age as well as who have been treated with antipsychotics. And yes, this risk is substantially higher in bipolar 1 than bipolar 2 patients or depression. The correlates they found BMI, age, number of mood episodes, especially number of depressive episodes and duration of illness. Again, the substantially lesser risk in the patients with bipolar 2, as I mentioned earlier. But again, this study tried to see, does it progress? They followed up those patients for 12 weeks after the medications. And what they found, it increases even the short duration, about 10% increase of metabolic syndrome risk. And again, there were predictors for BMI, waist circumference, as well as buttock circumference. Like schizophrenia, it also progresses. Various researchers have found significant progression and specific correlates are same, but additionally antipsychotic, because in this population, not always antipsychotics are used, but whenever it is used, it adds in the risk of metabolic syndrome. And again, this under SIR, this project was done. And again, there we have assessed their cardiovascular risk through the two formulas which he has used in previous interaction, Framingham score to see the risk of developing coronary heart disease over the 10 years. And the second was a score which is to see the risk of mortality because of cardiovascular reason in next 10 years. And what we found there, about 10% of the patient has high risk of CHD and about 6% patient have high risk of mortality next 10 years. And compared to females, males had the greater risk for Framingham score as well as the significant risk of CHD. Once we see the outcome because of metabolic syndrome, once the patients are under treatment, it has been seen the people who are receiving second generation antipsychotic with mood stabilizer risk is almost equal to the cases who are receiving second generation antipsychotic. But again, the metabolic syndrome is substantially less the subjects who are receiving only and only mood stabilizer, which we can see in our clinical practice that does happen, but we have to open our eyes many times to see this. But patients with metabolic syndrome had here more hospitalization, severe tardive dyskinesia, poor insight, poorer global function, and more impairment in executive function. As the question asked in previous presentations twice, it does affect the course. And as said, the studies, when they tried this, both the population in one study, substantially greater risk in bipolar patient than schizophrenia in studies from India and other countries. Briefly, I'll connect with the depression, but in depression, we see very clear literature about bidirectional association. Dear students, please understand the patient with metabolic syndrome has greater risk to develop depression, as well as what are we talking here? The patients with depression also has risk to develop metabolic syndrome greater than the general population. But it is vice versa, and almost odds ratio is 1.42. So in that way, both the type of studies are available. We did the study for 382 patients from the Jodhpur, and here the patients with depression and compared with the healthy control. And what we found, about 1/4 of the patients had metabolic syndrome. Here in this study, the most common metabolic abnormality was lower HDL levels, and the correlates of metabolic syndrome was greater age of onset at depression, greater illness duration, lesser physical activity, as well as lower nutritional scores as touched in previous interaction as a therapy for metabolic syndrome. Another study for inpatients with depression in PGI, and there the prevalence was greater than the outpatient figure what we have quoted. And here, what was found, interestingly, the most common abnormality, waist circumference, is found in most of the studies in both the population control as well as patients with depression. But again, patients with recurrent depression has almost double risk of metabolic syndrome than first episode depression, which they found. And greater proportion of patients had increased blood pressure, abnormal fasting sugar, and abnormal HDL levels. And about 46% of the patient fulfilled additionally 1 to 2 criteria of metabolic syndrome. So again, add-on risk for these patients to develop metabolic syndrome in future if we don't target now. So they found the predictors almost similar. Additionally, being married was the one predictor, as most of people are married in our country, and multiple episode of depression. Rest were the similar predictors as reported earlier. Here we try to see the expansion in the same cohort of the patient. Does it associate with liver function and inflammatory marker? So we found positive correlation of metabolic syndrome with liver marker as well as inflammatory marker, as well as association with metabolic abnormalities. And here in that study, the CRP was the only significant predictor to predict metabolic syndrome in that patient of 382 population. If we see the cognition as touched previously, yes, metabolic syndrome does affect neurocognition. That's why it is called neurocognitive metabolic disorder nowadays. So this was a study, again, two center, Chandigarh and Chennai. What they found in 121 outpatient, that the metabolic syndrome patient had significantly poorer performance in cognitive processing as well as selective attention, auditory and verbal memory, and executive tasks. And whenever the patients were having greater number of metabolic abnormality, they did present with greater cognitive dysfunction. And in systematic review meta-analysis of 23 study, it was found similarly the obese patient had impaired cognitions. Metabolic syndrome causes the greater impairment in their executive function, and their individual risk factor, be it hypertension, diabetes, dyslipidemia, they also affect cognition. And it was found in biological side that obese patients have greater brain imaging abnormality. I'll be touching some important facts just to keep the interest live, as well as for the people who are more biologically driven. But later I'll come on general strategies. I'll try to cover on time, but I'll be faster. So people have found the association of metabolic syndrome with complete blood count, especially total leukocyte count, as well as the DLC. And it was found significantly with associated with other metabolic abnormalities. In many studies, people have also assessed the association of metabolic syndrome with uric acid. And they found the patients of bipolar significantly greater prevalence of hyperuricemia. And the patients with metabolic syndrome has substantially greater prevalence of hyperuricemia, almost 3 odds ratio. Yes, our sleep expert is sitting there in the Srinagar. So sir will highlight more, but yes, people have found in the big study, PSBD cohort of 752 patients with bipolar, that sleep disturbance is pretty prevalent, more than even metabolic syndrome. More than 50% patient report some of the sleep problems. And there they try to correlate with chronotype. It's a very interesting concept. And the patient with evening chronotype were more alert in evening, have higher triglyceride level. And evening chronotype had increased atherogenic index of plasma odds ratio more than 4, almost reaching to 5. There are novel pathways where people have assessed the association of metabolic syndrome with genes of prolactin pathway, oxytocin, methylene tetrahydrofolate reductase gene, catechol O methyltransferase gene, and subsequently what are they seeing? They are trying to see the therapeutics for metabolic syndrome or reduce the risk. Again, there are studies on role of folate supplementation, some success and some are underway. Effect of endothelial nitric oxide synthase gene on metabolic syndrome, as well as serotonin polymorphism related to antipsychotic induced metabolic syndrome, especially with olanzapine, have been seen in various studies. Other is the complement pathway, leptin, adiponectin, and potential biomarker for metabolic syndrome, orexin A, because the people who are on less obesogenic drugs, antipsychotics, just like aripiprazole or other neutral agents, they have greater concentration of orexin A. That's why orexin A reduces the risk of metabolic syndrome. There are other genes with estrol regulatory binding transcription factors. I'll be touching on monitoring, which is the heart of this, but again, I'll be talking more on non-pharmacological because in my knowledge, it is not as a separate topic. And as told by sir, there are recommendations for monitoring. Yes, especially history, physical examination, lab tests, psychoeducation, choice of psychotropic medication, and appropriate and timely referral. If you remember 2, 3, and 4, physical examination, all the anthropometrics, laboratory tests, all for the criteria of metabolic syndrome, and simple psychoeducation. These 2, 3, 4 should be done at baseline, at 6 weeks, at 12 weeks, at 1 year, and every yearly. This is somewhere different in different guidelines, but it is a brief overview. But since the monitoring has been told by all the associations, but I'm sorry to say it is monitored and followed very low in outpatient, in hospital as well as community setting. Why we need to look within and ask the answers? We know the answers partly. But again, if we saw about the management, then the best approach is integrated approach. And again, there is a support of systematic review that interventions which are delivered in integrated manner by psychiatrists, nurses, dietitian, psychologist, counselor, alone or in the liaison that does better. And yes, the psychiatrist is a key component. Again, the question asks who needs to treat? We need to treat metabolic syndrome, and yes, we. And the component is dietary nutrition. As we all know, healthy diet, discouraging maladaptive food practices, emphasizing appropriate intake, calorie restrictions, healthy diet, weight management involving the physical activity through exercise, yoga, modification of dietary habit, psychoeducation, information about the illness, medication, need for lifestyle modification, cessation of substance, need for relapse prevention, and yes, integrated program is wellness program, which is holistic to cater all these components along with the sobriety, cessation of substance, and healthy lifestyle, monitoring and reduction of weight, BMI, blood glucose for other parameters as monitoring part. Why I'm elaborating, because we all know these things, but we need to ask how many of us are following it religiously or judiciously. So definitely there's a gap in practice. What we know we don't follow, and I'm sorry to say we don't follow. Most of us don't follow. So that's why there are practical suggestions. We need to have metabolic screen checklist. We need to have point of care metabolic screen program. And yes, we need to have metabolic clinics as well, as suggested by several authors. So we need to start need assessment, highlighting with the relevance and rationale, designing the services and sensitization of all stakeholders. Yes, emphasis on team approach. We can't do singly everything, and many times I agree. Preparing the training module for our own practice and center, implementation and timely evaluation with having some brief SOPs and guidelines, but effective liaison is must, which should be accessible and affordable and available at all the corners. And it needs multidisciplinary approach with also involving physician, cardiologist, endocrinologist. So whenever need, the patient can go to them, and they should be pretty sensible to look with the patients of severe mental illness, because I'll be covering this later. They are not diagnosed timely. So one component of metabolic clinic is also there. But we need more sensitization, motivation, our daily reflection and expert opinions and further evaluation. So hope this program will take this to the next height, because yes, it is pretty missing area at most of centers, I'm sorry to say. So, but it has been seen in the research, a simple initiative, just employing a nurse practitioner with the busy clinician has increased the screening significantly with positive reporting. Single educational intervention to patients have also improvised, but also improvised the observation of waist circumference issues in different corners of the world. We also try to see these with this small endeavor of recruiting 30 patients and assess their profile, the patients with schizophrenia who are having illness duration of equal or more than 2 years. We assess their metabolic profile at baseline, 1 month, 3 months, and 6 months with all the component what I told you earlier. And what we found, it was the baseline metabolic syndrome prevalence was 53%. It was 16 out of 30 subjects were having metabolic syndrome. But out of them, 14 subjects continued the meeting with us for next 6 months. So we finally assessed the 14 patients who were retained, almost 46% patients remained with us for this program. And what we found that out of 14, 11 patients who were earlier having metabolic syndrome at baseline, out of 11, 7 became negative for metabolic syndrome after 6 months. Where in all these studies we say it increases, yes, it increases. But whenever we try simple psychoeducational intervention, it does reduces. It has been seen by other studies as well, not as easy, but yes, it does. So our reversal of metabolic syndrome out of those 14 patients was 63%. And for other 4 patients, they remain metabolic syndrome positive at the end of the study, but additional 3 patients have been found to have reduced number of metabolic abnormalities, though they were positive, but their metabolic syndrome abnormalities from 5 reduced to 4 or 3. So that's why there are many studies to support this. Yes, there are various psychoeducational interventions are there, which has shown significant weight reduction, significant reduction in BMI, reduction in waist circumference, reduction in blood glucose levels. And again, there are specific studies by by the dietitian or nurse-led interventions as well. So yes, it does work as quoted by systematic review. Briefly touching, though, will be taken by other experts. The metformin has been found the best studied molecule once some risk is developed, not routinely, very clearly not routinely, but yes, few people are giving. But other options are topiramate, aripiprazole, reboxetine, sibutramine as a query for various other problems or listed. But importantly, the calorie restrictions with exercise program is there, the heart of all the programs, even along with pharmacotherapy when it is needed. Solely pharmacotherapy, big no everywhere. So there are novel therapies just to generate more interest. Yes, there are positive trials with omega-3 fatty acids to reduce the metabolic risk as well as to improve cognitive function. And they also found to raise BDNF levels. Therapeutic lifestyle changes with the smart devices, mobiles or smartwatch, that was found that home-based devices in community has done better than the conventional clinic-based approach for lifestyle changes. And again, one positive trial with melatonin therapy to reduce the metabolic abnormalities, but other trials are having mixed results. So there are quality improvement interventions, but I told in line with that only, if you sensitize the team with sensitization as well as some templates, it increases the screening over almost of tenfold because people don't screen. That's the one irony. So there are general recommendation at the closing site. As we mentioned, the routine screening at baseline, 6 weeks, 12 weeks and yearly. And again, the males above 40 and female above 50, there should be assessment of their cardiovascular risk assessment through a score chart. Further, we need to choose the antipsychotic with low potential for metabolic syndrome. So whenever we are initiating prescription, please talk to your heart, and then your heart will guide, and also in coordination with the brain. This is for all of us. It does better. And again, augmentation of switching of the agents with to low metabolic syndrome risk. If people are already on high risk of metabolic syndrome, but they are on treatment. Healthy eating habits and regular physical activity should be conveyed to patient and family at each and every clinical interaction. Advise to them to stay sober, no to drugs, smoking or alcohol, with appropriate and timely liaison with other experts. There are all the guidelines for diet, for exercise, for losing weight, for controlling blood pressure, as well as target levels of this biochemical parameters. And this is the last sum up slide, because once we talked about there were risk factors in previous talk. Yes, there are risk factors, but what we can do, the implications, genetics, yes, there should be early risk assessment and various immune, HPXs, leptin and microbiome alteration. Then yes, there are other immunometabolic modifications somewhere in the pipeline to have more effective trials. But yes, heart is lifestyle risk factors. That's why modifiable risk factors quoted in previous session. We need to put our heart and brain to advise our patient and family to quit smoking and other drugs and regular physical exercise. We all should also follow dietary guidance. And yes, the modification of their psychiatric care with the choice of the psychotropics, dose modification, switching appropriately, and adequate symptom control, very importantly. But the last part, since the risk exists, under treatment, under diagnosis, poor access to healthcare, that's why we need to gear up with early detection, regular screening, and adequate training treatment. I'll be just finishing in 2 minutes. So just to conclude, metabolic syndrome is highly prevalent, which we have seen, and just to open up our eyes, and I know most of us were knowing it. Likely multitude of factors are contributing. Psychotropic medication, yes. Their unhealthy lifestyle, yes. Poorer medical care of psychiatric patient. Whenever they go, they are not getting appropriate attention by many specialists. It has been seen many times. Their genetic and pathophysiological vulnerability always is there, which is contributing. But yes, we as a psychiatrist need to be aware about one, risk factors which are included through the psychotropics. Two, risk-benefit assessment while choosing the treatment option. Always implementation of necessary screening assessment, proper referral and liaison with other specialists, and promote healthy lifestyle intervention early in the course of illness. With duly educating the patients and family early in the course, then definitely we can manage much better than already it is set in. The last slide, my take-home carry message, screening, prevention, and timely management of metabolic syndrome is doable, very much doable, and with multidisciplinary approach. So last is the quote from somewhere, the goal is far ahead to see the appropriate metabolic care for our patients because they are dying because of metabolic risk factors. much more than suicide and other natural deaths. But we have to shape. Potential is inherent, but we need to seek it. Thank you very much for your kind attention. I'm open for all the questions. Thank you very much, Chairperson, sir, and dignitaries present on the dais and off the dais.
Thank you, Dr. Naresh. It was wonderful going through the concept, the epidemiology again of the metabolic syndrome. I think we can take a few questions.
So, Chairperson, sir, may help me because it is not in the chat box at my end.
Naresh, you can't see. Dr.
No,
Mano,
sir.
you can't see chat box. There are no questions.
Sir,
Even I don't see any questions.
Last is good evening by girls, sir.
Hi, chat box. No question. Anybody from the floor? Yeah.
Yes.
I'm Dr. Nilofer. Sir, I have to ask because sir, depression inherently increases the risk for metabolic syndrome, and such patients also have low motivation for changing their lifestyles and adhere to the medication. And I want to ask how much the antidepressants contribute to increase the risk for the metabolic syndrome. Number two, what are the safest antidepressants for use in such patients? And what are the risk-benefit ratio of treating the depression or increasing risk for the metabolic syndrome?
Yeah. Thank you very much. The first is yes, as mentioned about that they have the poor motivation for various things, but yes, fortunately what we are addressing here in the metabolic syndrome prevention as well as the non-pharmacological for depression is almost same. So we need to put our focus once only, which will give us credit in both these sides. So most of the studies have found no much direct association with antidepressant except the one or two quoted antidepressant like metazapine. But again, the sole contribution is not the drugs, as like in schizophrenia has been quoted more. But again, further in the trials, it has been seen the most of drugs cause lesser contribution. But yes, the more safer options is bupropion, agomelatine, milnacipran, and these agents are the upcoming. But wherever the already risk is there, avoid the drugs. One, metazapine, and second is tricyclic antidepressants. And the third one is the cost-effective or risk-benefit. Yes, it is definitely beneficial to treat both depression and metabolic syndrome. But again, fortunately, the figures are lower than other SMI for prevalence of metabolic syndrome and depression. So most of have also seen it is much less. And as mentioned in some studies, if the number of psychotropics are less, the risk is substantially less. So please underline in our practice, when someone is on single agent, definitely the risk is much lesser. And once they are better from the depression, it will help them to take care of their metabolic syndrome and their obesity as well, because they'll be more mobile, more functional, and more active.
Yes, there are a couple of questions now.
So I also seen, so with the permission of chair, can I read and answer, sir?
That is perfectly fine. Please go ahead.
Done. Thank you, sir. From Syed Mehwish, that what can be done to enhance seeking the non-psychiatrist specialist care for metabolic syndrome of our patient? Dear, I will advise, please do from your side as much as you can do. You will be the greatest person to help. But yes, wherever needed, some specialist, maybe endocrinologist or physician or cardiologist, then take the help. But don't advise the help of every person, because many times patients don't go and many times the specialists are not available. But yes, whenever you're not able to handle, then yes, take the help of other colleagues and other professionals for a specific thing which psychiatrists cannot deal with this. And I know my teacher will also answer from the floor for this. So wherever the answers are half from my side, so I'll be happy with that. The next question, Sabha. Did psychological weight reduction therapy perform well than pharmacotherapy for weight reduction? Yes, for weight reduction, the behavioral intervention does much better than pharmacotherapy. And whenever the pharmacotherapy has been advised with the golden words, but yes, people don't follow. I'm sorry, many experts and specialists don't follow this. But yes, whenever we are advising any pharmacological option for weight reduction, behavioral intervention as the first part of that prescription, then the medications, not only the medication at all. But yes, many times people prescribe, which is not right way. And yes, any role of topiramate, as I mentioned, the biggest evidence is with metformin for metabolic syndrome, followed by topiramate. But yes, there's a full lecture on this. So other learned speaker will talk about this. But yes, blindly prescribing topiramate to just prevent metabolic syndrome along with a long prescription, I'm sorry, it's wrong. Many people prescribe, but it's wrong. So please keep the relevant practice, not offending to anyone. Other one is the code. I'm sorry.
Thank you. Before you take, you have answered fully, or you want to continue your answer?
There are 3-4 more questions. So
you can take offline question to make it a bit diverse. You can take an offline question from floor.
I'll be happy.
Good evening, respected sir.
Yes.
I'm Dr. Ajaz, and my question is, how much prevalent is metabolic syndrome in patients with ADHD, as these kids are always hyperactive, and what is the mechanism of that? Thank you.
Done. Thank you. There are studies, but again, much lower on the cards compared to schizophrenia, bipolar, and depression. Once we see the prevalence figures in child and adolescent, then it is somewhere in most of the studies between 10 to 20%. We have also studied from the PGI cohort, and it was near to 20% in the CAP population presenting with different psychological problems, but none was on ADHD management and ADHD diagnosis. But again, the figures will fall nearly to 10% or 10 to 20 because it is compared to the healthy control, it is greater in the child and adolescent population, but ADHD comes much lower on the card. And since they are hyperactive and they are prescribed, most of agents are not contributing. And since their own energy consumption with their own deeds also affects lesser risk of metabolic risk, but yes, who are on antipsychotics, again, it is adding the risk, just like as a bold statement mentioned, but sometimes they are added with antipsychotics. So we need to be cautious, but on other side, the ADHD management, especially methylphenidate, does reduces the weight and also causes the growth suppression and hunger suppression. So this side effect has been quoted much less in MPH patients who are receiving methylphenidate. In my clinical experience, I haven't seen in any. Any other question from the floor? Or with the permission,
Thank you. But he should not be counted as one of the nominees for the award. He's literally my consultant, so he's not a PG resident. So he's out of contest as far as award winning is concerned.
Over to
so yeah, you can take up online questions, and we have a last question from floor.
Yeah. So Alia has asked. Previous question was also from Alia for topiramate. That quoted in a study on the prevalence of metabolic syndrome in patients with close-up. Since close-up is given in patient of treatment-resistant schizophrenia or mood disorder, can we deduce any association between the treatment-resistant psychiatric illness and metabolic syndrome? Yes, very important question. Even if we have discussed in a previous study from PGI Chandigarh that recurrent depression has substantially greater risk, almost double risk of metabolic syndrome than the first episode depression. So same applies here. The patients who are treatment-resistant, they have more symptoms, more retardation, be it depression or be it schizophrenia, more load of psychotropics, and yes, more dosages of antipsychotic as well as close-up in prescription if it is schizophrenia. So risk of metabolic syndrome is again substantially high. And again, whenever we try behavioral intervention, it takes more efforts than the other patients. So yes, it is more, but we need to be judicious in our prescriptions. And as mentioned in previous lecture, that whenever it is needed, we need to prescribe the rational prescription, even clozapine. Why? Because if person improves, then he or she will cooperate more for behavioral intervention. And in that way, we can see the reduction of risk. It was seen in a rosy way in most of the studies whosoever tried any behavioral intervention. Next question by Vishal Verma from our center. Which is the most effective non-pharmacological method of prevention of metabolic syndrome? It was already answered in previous interaction. So I'm again clarifying the both physical activity as well as nutritional counseling and nutritional care, because it has been seen in the studies only physical activity that gives lesser result, but it is coupled with the nutritional part, then the results are much better in most of trials. Now, all the simple strategy as well as staying sober and the wellness program as mentioned. Any study done in your center to explore the association between, no, I haven't done any on uric acid and metabolic syndrome. As I mentioned, one study. So very less number of studies I could find in my general search. And again, it was earlier question was again Alia. The next question again by Vishal. As Indian population have more level of lipoprotein A level and it's more sensitive indicator of cardiovascular disease as compared to LDL, TG, should we include metabolic syndrome criteria along with other criteria? Again, those criteria are by the body's expert opinion, but are more feasible tests, which are not more costly. That's why those it is not included. And again, as partly it was answered in previous interaction, there are many more to come. So that may be individual choice rather than as a general consensus criteria. With the permission of the chair, can I take? There are 3 more questions. I should finish in 2 minutes.
I think we are just going maybe another 1 or 2 questions because we just about to finish on time and along with that.
Sir, from my side, I'll finish in 1 to 2 minutes, sir. Thank you, sir. Sabha has asked what could be the reason of higher prevalence of metabolic syndrome in depression other than other mental disorder. As I mentioned, much greater in bipolar in most of studies, followed by schizophrenia. So depression comes lesser after these disorder. But again, it is more common, more studies are available. So we can see, but again, the factors are all, as I mentioned, the biological as well as this, the lifestyle factors, as well as some is the therapeutics, whatever they are getting. Reasons, next by Syed. Reasons for increased incidence of metabolic syndrome and schizophrenia, again already answered. Vishal, again question, antipsychotic associated with maximum rate of metabolic syndrome. Very clearly quoted clozapine. I'm sorry I didn't touch, but I mentioned the clozapine increases risk almost 2 to 3 times, followed by olanzapine high on the card. But it will be covered in the very bright lecture by one of my senior. Vishal again asked, antipsychotic is the last question I'm touching. Antipsychotic is associated with the highest risk of metabolic syndrome. Which is the most effective non-pharmacological method? Again, I mentioned in prevention. I answered in the previous question. This same, nothing golden rule for any particular specific scenario. Physical activity, nutritional. Third is the sobriety. And the fourth is the other lifestyle factors, including the substance and XYZ things and sedentary lifestyle. Thank you very much. Over to Chairperson, sir. If any question from the house.
Sure.
Yes. Yeah. We have 7 minutes, 6 minutes remaining. We'll take 2 questions, quick questions.
Please, sir.
Good evening, sir. So my question is that how prevalent is metabolic syndrome in patients with normal waist circumference? Psychiatric patients with normal waist circumference.
Very good question. Again, the data exists. That's why the components have come, because earlier people were relying only on waist circumference. But when we see the clinical experience, the most of patients who are positive for metabolic syndrome are also having increased waist circumference. But again, the some proportion, I can just quote with the rough figures. Sir will correct me if something. So less than 1/3, maybe lesser than that, where the waist circumference is not there, but other parameters are affected. Because here again, the 2 components are there. One who are already diagnosed with diabetes or on oral hypoglycemic or only medication, and second is pre-existing diagnosis of hypertension or on any antihypertensive. So this covers 2 risk factors or metabolic component. If any other third factor comes, be it triglyceride, be it the other component, this is the HDL, then it is positive for metabolic syndrome. But in clinical practice, it is very less number of the patients. Any other question?
Yes, sir. So my question is about antipsychotic polypharmacy. Like it's not like in patients with clozapine, we have to augment patient. Like we can't call it polypharmacy there, but in clinical practice, when I look at the prescriptions, I see patients with polypharmacy there. Like if I have to augment a patient who is on clozapine for resistance, like if I will give another drug, which itself has metabolic side effects, or I can prefer aripiprazole. Are there any studies or what we should prefer taking the metabolic profile like in mind?
Thank you. Very important question. Since assessment of metabolic syndrome in screening is most important before prescribing any agent. So again, we need to do. 2 is, again, if patient is already vulnerable and having metabolic syndrome positive, we are thinking of clozapine because somebody's treatment-resistant schizophrenia. Then again, as you yourself has answered, the one of the neutral agent is aripiprazole. But in the study, it has been found the patients on the polypharmacy or multiple psychotropics has greater risk of metabolic syndrome compared to who are on monotherapy on any disorder. But yes, there are studies where seen the first generation antipsychotic polypharmacy versus clozapine. Then yes, risk is more in clozapine. But yes, in with the clinical experience, if the person is well on clozapine, then he or she can definitely contribute for better physical care. Then in later run, if we advise all these intervention which we have briefly narrated here, then we are going to see the rosy picture of reduction of metabolic syndrome despite clozapine. Those studies are yet to be seen. I haven't located those studies, but can be possible after clozapine as well.
Thank you, Dr. Naresh. Before I hand it over to Chairperson to conclude and adjudge the best question, we have Professor Rakesh Chadha. We acknowledge his presence in person in Srinagar. Chadha sir wants some input. We want some inputs from Chadha sir as well.
Since we have many young budding psychiatrists sitting here, one important thing is we don't write about the non-pharmacological interventions in the prescription. So whenever you're writing prescription, also write daily walk for 40 minutes, controlled diet, means some of those, and that can be written in every prescription when you're starting any psychotropic in a patient. Definitely it's bipolar disorder or schizophrenia, not the anxiety disorder where we don't expect. Even in anxiety disorders also, we should write about the specific like breathing exercises. So non-pharmacological interventions, if we start writing in every prescription, that sensitizes the patient that the other things like daily exercise or control of diet, those things are also important, and that helps. That goes a long way in preventing the development of metabolic syndrome and other lifestyle illnesses, because our patients often have to take medication for long periods. So this thing is also important, that we should write about the other instructions. Don't stop at the medication. After that, you can write 4, 5 this thing. So that makes a big difference. Thank you.
Thank you, Chadha sir. It's a very wise thing. Normally, our psychiatrists in Kashmir would write priorities and psychoeducation on the prescriptions, but we think we need to add a dietary, balanced diet and exercise as well on the prescriptions as a first treatment for that matter. So we would, with acknowledging the presence of Professor Rakesh Chadha, who is head of the department, All India Institute of Medical Sciences, New Delhi, very, very senior psychiatrist, we would like to acknowledge his presence by presenting a bouquet to him, sir. Thank you very much, sir, for coming in person. Thank you very much, sir. Thank you, Dr. Manu. It's over to you.
Thank you, Dr. Majid. If it is for me to decide the best question, I think there was a question by Alia Khanam regarding clozapine and treatment-resistant schizophrenia and association between that. I think that's a relevant question, but very aptly answered by Dr. Naresh. I think the overall tempo on starting with metabolic syndrome, the conceptual issues, and going to epidemiology, coming to some touches of non-pharmacological management, and further down, I think it will be wonderful at the conclusion to have a wonderful understanding about metabolic syndrome. Rightly chosen topic and rightly being discussed till that moment. Thank you.
Thank you very much, sir.
Thank you, Dr. Naresh, our speaker, Dr. Manu Arora, our chairperson. Thank you very much for being there, and your mementos will reach you as promised by our academic partner, Sun Pharma. Thank you very much.
Thank you very much, sir.
We present the memento to the best question that has been adjudged by Dr. Manu Arora. Alia Khanam is, again, she is the shining star of the day. She has won the second award in a row. Dr. Alia Khanam, please come forward. Dr. Sandeep Goyal would hand over the memento to her. Yes. Thank you. If she keeps on winning lives, that she might have a store of her own of pen drives. Thank you very much, Alia, for being very active. We move on to the next session, and we have a lead panel of faculty, starting with Dr. Aseem Mehra, who is the assistant professor and would be moderating the session. Then we have chairperson, Professor Awasthi sir. I think he has joined us. Professor Awasthi sir, kindly.
I am already there, sir.
Right, sir. Thank you very much. We miss you a lot here in Srinagar. You have been always part of the events being organized in Srinagar, but somehow. Thank you very much, sir, for joining.
So often forgotten, you know.
Right. Thank you, sir. Thank you very much. Dr. Subhash Das is another chairperson. It's over to you, Dr. Aseem, for rest of the proceedings.
Thank you, sir. First, I would like to thank to the
organizing team to provide me this opportunity to introduce the chairpersons. I would like to welcome my esteemed teacher, my guru, the teacher of teachers, ex-HOD of Department of Psychiatry, PGI Chandigarh, Dr. Ajit Awasthi. Sir is a well-known personality in psychiatry, and sir doesn't require any formal introduction, because for the introduction, sir's name is enough. So I welcome sir.
Thank you very much.
I also welcome Dr. Subhash Das, who is currently professor in the psychiatry in Government Medical College, Chandigarh. Sir is also working as a medical superintendent in Mental Health Institute in Government Medical College itself. And sir has a lot of publication in international and national journals. Sir also have won a number of awards like Dr. B.V. Sethi Award, J.K. Trivedi Award. And sir also hold a number of academic and administrative posts like General Secretary of TPS Society, past Assistant General Secretary of Indian Association of Social Psychiatry. And sir also used to, is very interested in game, like sir used to play football, also interested in tracking. So sir, I welcome Dr. Subhas also. And next chairperson is Dr. Sandeep Goyal, who is currently president of IPS North Zone Society. Sir is a good leader, a humble person with good intention for the upliftment of the psychiatry. Sir has a number of publications in national as well as international journals. And sir also have won a number of awards. So sir, I welcome also. With this, I would hand over the session to our esteemed chairpersons.
Well, thank you very much, Dr. C. Mehra, for a wonderful introduction. I don't know, it was so flattering that I almost thought that I should go below and hide myself somewhere, you know. I'm a very ordinary professional in the field with such illustrious people sitting there. I think, first of all, it's my delight to see some of my good friends. But more than friends, I must say that in their official capacity as the current Vice President and President-elect of the Indian Psychiatric Society, it is my delight to see Dr. N.N. Raju at Fortune Haven in Srinagar. It's such a great delight, and that shows the importance which the Indian Psychiatric Society national body attaches to the PG development program of the North Zone. You know, so this is a great honor for all of us since I belong to this zone. Thank you very much and welcome, Dr. Raju. I'm also very delighted to see my very dear friend, who is not only a friend but a younger brother to me, and he is Dr. Rakesh Chadda. He is there despite his very hectic schedule. He is the one who is organizing the vast Asia Pacific Conference, and which is just a week away. And despite that, he has found time to be in this place. That's a great honor to all of us. I am very grateful to Dr. Sandeep Goyal, as well as Dr. Abdul Majid, for giving me the honor of chairing this particular session. Why I say an honor? Because I have two wonderful co-chairs with me in Dr. Sandeep Goyal and Dr. Subhash Das. They are the future of psychiatry in India. I am a setting sun, you know. Now, as far as the real honor is because of the presence of my very dear friend, another dear friend, whom I regard more as a younger brother than as a friend, and he is none other than Dr. Om Prakash Singh. Dr. O.P. Singh is, Professor O.P. Singh is a remarkable person. I wish the younger psychiatrist spent some time in his company to pick up some of the sterling qualities that he has. His topmost quality is the congeniality, which he affuses, and he makes everybody feel so comfortable in his presence, you know. Coming to his accomplishments, as you all know, he is the current honorary editor of the Indian Journal of Psychiatry. And he has taken Indian Journal of Psychiatry to such dizzy heights that I wonder the people who will step in his shoes, how will they keep pace with the standards that he has already set for us? Today, we can feel very proud of having our official organ of the Indian Psychiatric Society in such a position where every year its index is rising, and that is a great achievement for Dr. O.P. Singh. Dr. O.P. Singh, with this, I will not take much time. The rest of the proceedings will be now handled by Dr. Sandeep Goyal, Dr. Subhash Das, and Dr. Aseem Mehra, of course. This is probably one of the major programs after nearly 3 decades that I am not in Srinagar. So I miss being there. But hello to everybody who is there in the hall. Thank you. So Dr. Sandeep Goyal can take over now. Sir, you are not audible.
Thank you, sir. We are also missing you here. Now it is my proud privilege and honor to formally introduce Professor O.P. Singh. He is a friend, a humble human being, and editor of the Indian Journal of Psychiatry. As sir has already said, he has increased the value of Indian Journal of Psychiatry. He is the past secretary of IAGMH, and he is the International Distinguished Fellow of APA. Sir has more than 90 publications and has edited 2 books. We welcome you, sir.
Thank you.
And kindly start the presentation.
Thank you. First of all, I'm audible.
Yes.
First of all, my thanks and regards to IPS North Zone CME chairperson for inviting me. And of course, Sandeep Grover, who is a dear friend, and he is responsible for a lot of achievements of the journal. And Sandeep Goyal is also a friend, and Dr. Subhash Das. And less said about Dr. Awasthi is better. He is the one of the shining lights of Indian psychiatry or international psychiatry. And he has been always kind to me and blessed me always. And I have learned many things from him. And I'm really sort of apprehensive, feels like a student in front of him chairing this session. And there have been 2 beautiful presentations before me. Professor Sandeep Grover and Professor Naresh has already talked about basic concepts and prevalence in psychiatric disorders. My job is slightly different, and I will be talking about etiology and biomarkers in metabolic syndrome. So I know that already it has been introduced, but what is the main features of metabolic syndrome is from the ribbon that it was a cardiovascular risk. So main important thing is that all this increase the cardiovascular risk and diabetes mellitus risk. And there are questions that whether all the components are interrelated, or they occur due to common origin, or they influence each other, or sum is more than the whole is more than the sum of all the components. So these are the things still being debated in metabolic syndrome, but still they occur in together, and I will be discussing what are the main major factors for them occurring together. So basically, major biological factors related to pathophysiology of metabolic syndrome is, of course, the main feature is insulin resistance, pancreatic beta cell function, cellular dysfunction by protein kinase and phosphatases, suppression of insulin receptor substrate 1 and 2 gene expression and function. So these are the mechanisms, and also obesity and lipid toxicity, oxidative stress and glucose toxicity, chronic inflammation, circadian rhythms, genetics and epigenetics, gut microbiota, and dietary effects. So all of them in isolation and in combination almost work together and bring this syndrome, which is called metabolic syndrome. Before that, I just want to touch upon since glucose is a major part, or insulin sensitivity is a major part of this, I will just want to recapitulate something of the glucose metabolism. So plasma glucose, rate of glucose appearance is described, is dependent on intake, then glucagon, and rate of glucose disappearance is determined by insulin and glucose disposal in tissue, muscles, and adipose tissue. And incretins, what is called incretin effect, which is now the medicines are also available for diabetes. It was found that when food is taken or glucose is taken orally, its effect is more than when it is infused. And two peptides, GLP-1 and GIP, were found to originate from gut, which influence glucose metabolism. So insulin resistance is the key factor again to the etiology of metabolic syndrome. It is further potentiated by several other biological factors. Normal glucose functions in insulin, what it does, it lowers the blood glucose level by enhancing the entry of glucose into the skeletal muscle and adipose tissue via GLUT4 receptors. It stimulates the lipoprotein lipase enzyme, thus breaking the deposited triglyceride from adipose tissue. In the liver, insulin inhibits hepatic lipase, thus inhibiting the breakdown of hepatic triglyceride. So in the liver, glucose is generally converted into pyruvate and acetyl-CoA. Insulin resistance promotes excess gluconeogenesis in the liver, resulting in increased glucose levels. Increased glucose produces more acetyl-CoA, which can be used, and that is channeled for more fatty acid synthesis. Increased fatty acid inhibits the insulin function, thus further promoting the insulin resistance. This vicious cycle leads to increased release of free fatty acids in blood that promotes increased TG levels in tissues, atherogenesis in endothelium, and increased prevalence of cardiovascular disorders. So one thing leads to this cascade of events. Then again, there is a theory of calorie excess. The response to calorific excess is influenced by Professor Sandeep was talking about modifiable factors and non-modifiable factors. So genetic factors which predispose to development of insulin resistance in the skeletal muscles, adipose tissue and liver, and which predispose to obesity and dyslipidemia. With environmental interactions, smoking, sedentary habits, excess alcohol, etc., obesity, and lack of exercise. Lack of exercise affects in many ways. Decreased lipoprotein lipase activity in blood vessel endothelium that leads to increased triglyceride levels in the blood, increased TG in circulation, consumption of HDL cholesterol leading to decreased concentration, and increased chances of atherosclerosis. Lack of exercise also leads to decreased heart function and oxygen uptake, leading to increased chances of hypertension. Insulin, together with glucose, stimulates glucose uptake from circulation into cell for glycolysis or is stored as glycogen in the liver, muscle, or adipose. This results in the suppression of hepatic gluconeogenesis. GLUT4 is one of the most important glucose transporters, mainly expressed in muscle and adipose tissue. Under the stimulation of insulin, GLUT4 is mobilized from cytosol to the cell membrane to transport glucose from outside the cell to inside. This is the rate limiting step in glucose uptake and muscle glycogen synthesis. So what happens in insulin resistance? There is loss of initial secretion, then hypersecretion, which ultimately leads to beta cell fatigue and apoptosis of beta cells of pancreas. Nowadays, people are talking about different kinds of diabetes or different kind of insulin resistance. So CNS insulin resistance, which is important for appetite regulation and feeding behavior. Adipose tissue resistance, inflammation, and hyperlipidemia. Hepatic insulin resistance is responsible for hyperglycemia. Cardiac insulin resistance is responsible for heart failure. And pancreatic impaired beta cell regeneration. In muscle and bones, glucose homeostasis is impaired, and vascular endothelium hypertension. And individual components ultimately lead to a global kind of insulin resistance. This is a complex diagram. I will just tried to simplify and say this. Insulin in presence of glucose binds to insulin receptors, which binds to IRS1, IRS2. There is two major pathways. One is called AKT pathways and one is MAPK pathways. Mainly AKT pathway is the main for metabolism. So there is a phosphorylation at tyrosine residues, which leads to conversion of PI3, and this kinase acts on AKT. So there is a cascade of phosphorylations. Ultimately, net result is GLUT4 is transported from cytosol to membrane, and FOXO1 is inhibited. It goes from nucleus to cytosol. It is responsible for hyperglycemia, hyperphagia, inflammation, hypertension, and also gluconeogenesis. So this is inhibited if it is normal. When insulin's resistance occurs, FOXO1 is not inhibited, and there is again GLUT4 translocation is also impaired, and there is less activation of this protein kinases and phosphorylation cascade. So cellular dysfunction by protein kinases and phosphatases are responsible for insulin resistance and also in the process of development of metabolic syndrome. There are suppressions of IRS1 and IRS2 gene expression and functions by different mechanisms, which again leads to insulin resistance and decreased utilization of glucose. Hyperinsulinemia results in serine threonine phosphorylation of IRS, which promotes IRS degradation and prevention of tyrosine phosphorylation, which is the classic phosphorylation in insulin signaling pathways involved in PI3K to AKT to FOXO1. Also, pro-inflammatory cytokines such as tumor necrosis factor alpha and genetic defects, AKT gene abnormalities induce insulin resistance. Obesity and lipid toxicity. Adipose can secrete some adipokines that can communicate with other different tissues, including the brain, immune cells, etc. For example, leptin is secreted by adipocytes and signals the brain for satiety. As fat cells expand, more leptin is secreted to the brain to signal the termination of eating behavior. Leptin resistance can happen in obese individuals, like insulin resistance, and in these individuals, even high level of leptin cannot create satiety. Leptin may also regulate glucose homeostasis, pancreas, beta cells, and insulin-sensitive tissues. With the growth of adipose tissue during obesity development, angiotensinogen AGT, a precursor of angiotensin II that enhances sympathetic nervous system and blood pressure, is drastically overexposed, and that leads to hypertension. AGT is suggested to be a FOX1 target gene in the liver. Failure of insulin-suppressed FOXO may promote angiotensin II production that increases SNS and blood pressure, sympathetic nervous system flow, and blood pressure. Fat cells also secrete adipokines like adiponectin, which increases insulin sensitivity. Already I have talked about leptin, and particularly macrophages, this secretes cytokines. TNF alpha and MC1 attracts monocytes, which again turn to macrophages, and macrophages again increases cytokine secretions. TNF alpha, already I have said, that decreases insulin sensitivity. Nuclear factor kappa light chain enhancer of activated beta cells and JNK phosphorylations are main pathways for inflammation. So coming back to insulin resistance as the major etiological factor. Insulin affects the hepatic lipase in the liver and lipoprotein lipase in the endothelium of blood vessels in opposite way. Insulin inhibits the hepatic lipase and it stimulates the lipoprotein lipase in endothelium. Hepatic insulin resistance results in increased hepatic lipase activity, leading to increased breaking down of hepatic triglycerides into fatty acids. These fatty acids increase the free fatty acid levels in blood, skeletal muscles, and adipose tissue that further potentiates the insulin resistance in these tissues. Increased fatty acid delivery to the skeletal muscles and adipose tissue result in increased triglyceride synthesis and its deposition in these tissues. Lack of insulin sensitivity in the adipose and skeletal muscle tissue decreases the lipoprotein lipase activity in these tissues. This results in decreased breakdown of TG from adipose and skeletal muscle tissue and leads to fat deposition in adipose tissues and skeletal muscles, potentiates the chance of obesity and further insulin resistance. So this is a vicious cycle. Fatty acids inhibits, and then adipose tissue is deposited in muscles. And again, this leads to insulin sensitivity and decreased utilization by glucose by muscles. And this vicious cycle leads. So what are the combined effects of both hepatic and peripheral insulin resistance? Increased free fatty acid flow from the liver that potentiates further the insulin resistance in peripheral tissue. Increased delivery of free fatty acids into adipose tissue and skeletal muscles. Decreased LPL activity in peripheral tissues allows excess deposition of fats in these tissue, promoting obesity. So the overall effects are increased triglycerides level in peripheral tissue that leads to obesity, increased free fatty acids in circulation that potentiates the insulin resistance further. So both combined and peripheral insulin resistance leads to development of metabolic syndrome. So insulin resistance, then triglycerides are increased, leading to hypertension and endothelial damage. So these are the major components of metabolic syndrome. While talking about epigenetic and maternal nutrition, I was talking about epigenetic principles. So epigenetic principles are important for intrauterine programming. So poor maternal nutrition, maternal obesity, rapid postnatal weight gain prepares for poor nutritional environment. So what happens when the environment is not poor nutritionally? That leads to development of METS, MET syndrome. And there is a theory that this epigenetic changes can be transmitted in generation. And for Indians also, for a lot of populations, particularly in Bengal, famine and others, this has been that we are more prone to metabolic syndrome because of these epigenetic changes. It also decreases expression of PDX1, a key transcription factor regulating pancreas development. And of course, in animal models, it has been found that GLUT4 expression is decreased in muscles of intrauterine growth retardation in rats. So a lot of epigenetic and nutritional and environmental factors work, and which also can be transmitted genetically. Excessive fat results in pro-inflammatory state owing to alter production of inflammatory leptin and anti-inflammatory mediators. I already have talked about recruitment of macrophages to adipose tissue and secretion of pro-inflammatory cytokines. These pro-inflammatory cytokines increase the chances of atherosclerosis and CVD. Both obesity and insulin resistance stimulate the chances of hypertension by increasing the sympathetic nervous system outflow and stimulating the renin-angiotensin system. The succinate receptor GPR91 may explain the link between elevated glucose and renin. So we can see that all are interrelated in some way or others, and disorder in one pathways lead to disorder in cascade in other pathways also. Endothelial dysfunction is another hallmark for MS, which occurs due to several factors: elevated glucose and hence elevated glycation of important proteins, altered lipid profiles, obesity associated pro-inflammatory molecules, and oxidative stress. So this leads to endothelial dysfunction, and some people say that endothelial dysfunction is one of the major component of metabolic syndrome or cardiovascular risk or any kind of other disorders. So atherosclerosis and microvascular disease bring out the major sequelae of MS. Damage to the heart due to myocardial infarction promotes changes leading to the heart failure. Microvascular disease involves damage of the small arteries and can affect the functioning of kidneys, brain, and heart. people have talked about distribution of fat and sex differences. So whether it is more in male, slightly less in female, what is found that visceral fat and subcutaneous fat have different inflammatory signatures. Visceral fat has been found to be associated with insulin resistance, whereas subcutaneous fat has not been found to be associated with insulin resistance. And it is found that males have more visceral fat, whereas females have more subcutaneous fat. And this is one of the reasons that abdominal adiposity is more important than BMI, and people were talking about waist-hip ratio and other things. So basically, the BMI sometimes do not give a true picture of fat which is in body. And visceral fat is more important for development of metabolic syndrome rather than subcutaneous fat. So final interaction of the biological factors in metabolic syndrome. So caloric excess, physical activity leads to visceral adiposity, interacting with ectopic overload, insulin resistance, plasma lipids, leads to HDL reduced, triglyceride elevated, inflammatory milieu, hypertension, beta cell failure, diabetes, cardiac dysfunction, leading to heart failure, atherosclerosis, myocardial infarction, glucose toxicity, microvascular diseases. So all are interrelated and ultimately increase the risk of heart failure and heart diseases, cardiovascular diseases. So this is a simple representation of organs involved. So there is more CRP, more VLDL, triglycerides synthesis from the liver, more free fatty acid synthesis from the adipose tissue. Then again, TNF alpha and IL-6. This leads to also fibrinogen and prothrombic state. Adiponectin is decreased. Triglycerides, intramuscular droplets. So muscles have insulin resistance, and ultimately this leads to endothelial damage and hypertension. So this is the basically in summary of etiology of metabolic syndrome. Now from there we can move on to biomarkers. To be very true, they have been defined as characteristic that is an indicator of normal biological process, pathogenic process, or responses to an exposure or intervention. So that they may denote a pathological process, response to a treatment or intervention. They should be, can be measured with high reproducibility, should be accessible for detection and measurement. Plasmatic marker, genetic marker are detected by histopathological or image neuroimaging techniques. Coming to classically, if we say the components of metabolic syndrome are all biomarkers rather than disorders. So, but since they are used in definition and already has been discussed much, I'm not going in to discuss them. But classically, they are biomarkers rather than disorders. So increased glucose, increased waist circumference, hypertension, all these are biomarkers of metabolic syndrome. Biomarkers can be pharmacodynamic, predictive biomarkers, safety biomarker, susceptibility risk biomarkers, diagnostic biomarkers, and monitoring biomarkers. They can also be genomic markers, proteomic markers, transcriptomic markers, and metabolomics markers. So epigenetic, we know that a lot of techniques are available for epigenetics, for genomics also, for transcriptomics also nowadays, proteomics, mass spectrometry, then HPLC, and metabolomics, NMR spectrometer, high resolution mass spectrometer. So we can manage, measure many components now. If you go, there is one of the significant biomarkers are extracellular vesicles or exosomes, which are formed from the membrane or from the endosomes which are secreted. It was found that there is increased significant quantities of extracellular vesicles in circulating blood in Met syndrome compared to the healthy controls. So these were considered as a biomarker, and they also contain different kind of molecules like mRNA vesicles, which are again being investigated as biomarkers. Then protein biomarkers. We have already talked about adiponectin. It is significantly decreased in obese. It is negatively correlates with BMI. It is found in hypertensive. So with each component of metabolic syndrome, it decreases. So threshold is less than 4 microgram per milliliter of plasma. So adiponectin is a very sensitive kind of biomarker. It is increased in obese. It is negatively correlated with BMI, low in hypertensive, and it is related to every component, decreases with every component of metabolic syndrome. And leptin, higher levels in Met syndrome, independent of obesity. It was found that even the person is not obese, other features of metabolic syndrome he is meeting, then again leptin was higher in them. People are trying to find, well, measurement of leptin, there is still, standardization is quite poor. So people are trying to find that and find the ratio, which is more useful biomarker than either of them alone. Then there are circulating DNA markers. Genomic gDNA polymorphism in the adiponectin gene, ADPO-Q is a potential biomarker. There are at least 42 SNPs were found. 45 plus GG was significantly higher in mates compared to 45 plus TG or 45 plus TT alleles. So this was one of the findings, that SNP 44 plus GG was significantly higher in metabolic syndrome, and frequency of L164T was found much higher in people with 3 abnormalities. If it is increased in 1, if people have 3 kind of abnormalities like hypertension, obesity, and increased glucose, it was found much higher in those people compared to the people who are not having these 3 kinds of abnormalities or metabolic syndrome. This is a list of microRNAs which control lipid metabolism and cholesterol efflux, glucose homeostasis and insulin signaling, and adipocyte differentiation. So these are all being investigated, has been found to be associated with metabolic syndrome. Then there are circulating RNA markers. mRNA in adipose tissue biopsy, it is not being found in blood. It has found that 6-fold decrease of aponectin mRNA levels in obese individuals. Another molecule is zinc-dependent neprilysin, which is expressed in adipocytes in mouse with developed metabolic syndrome-like picture. Then we can measure oxidized low-density lipoprotein as a marker of oxidative stress and also metabolic syndrome. Then clinically useful biomarkers of inflammation, which we are using, CRP, HSCRP, which is more sensitive, used in coronary risk assessment, metabolic syndrome, value greater than 3 milligram per liter, high risk for metabolic syndrome. Then acute phase serum amyloids, which correlates with central obesity. And all the cytokines, IL-6 is nowadays routinely measured. Osteoprotegerine, role in mediating cardiovascular damage. CD40 ligand, it plays an important role in cascade of inflammatory and pathothrombotic functions. Other associated biomarkers are pentraxin-3, is a cluster of serine proteins, Increased PTX3 levels are associated with metabolic syndrome development and progression. Pyroxenase, POM1, though through its antioxidant and inflammatory effects, could have important roles in lowering the progression of metabolic syndrome. Apart from interleukin-6, interleukin-10 is a potent anti-inflammatory cytokine, which is a reverse of IL-6. It also plays an important role in modulating insulin resistance and atherosclerotic development. So they can be also measured as a decreased risk. Ultimately, this leads to cardiac problems. So cardiometabolic markers, we know that classical markers, glucose and HbA1c, insulin resistance, which is very difficult to measure, which is measured with impaired glucose fasting, impaired glucose tolerance, and also by a method like homeostasis model assessment of insulin resistance, which cannot be used very clinically. So other things are measured, and other metabolic related markers, thyroid hormones, parathormones, etc. Cardiac risk markers, I have said that HSCRP, which is very high sensitivity CRP levels, now done routinely. Less than 1 is less risk, 1 to 3 is moderate risk, above 3 is high risk. Then of course homocysteine levels, then LDL-HDL ratio, and then uric acid, which is very easily measurable, very old, which shows catabolism, and it shows, it denotes the CV mortality and morbidity. So coming to the end of my presentations, there is few biomarkers apart from the clinical biomarkers which are already used in the definitions, and some DNA biomarkers and mRNA biomarkers are there which are common for metabolic syndrome. But there are a lot of biomarkers which denote a single thing like inflammation or inflammatory markers or cardiovascular risk due to metabolic syndrome. So we have to use them in combination and predict the risk of having cardiovascular disease due to metabolic syndrome. Thank you. Thank you so much. Acknowledgements I have taken extensively from them. Thank you.
I congratulate Professor Dr. O.P. Singh for making this difficult concept of etiology and biomarkers in metabolic syndrome very simple. I request my co-chairperson, Dr. Subhash Das, to take up the online questions.
Thank you, Dr. Sandeep. Thank you, O.P. sir. It was really a comprehensive presentation, and though has got all the nitty-gritties into this a little bit, I say, complicated kind of presentation. But anyway, things were covered in such an extensive manner. I must congratulate the speaker. And at the same time, I also feel honored and privileged to be here. And I thank all the office bearers of IPS North Zone. It's a privilege to be with Avasti sir and Dr. Sandeep. We have some questions, online questions. So what I can see is that these have been posted by two persons, Saba Yunis and Dr. Nilofer. They have posted together 6 questions. I think first I will take one question each from each one of them, and then maybe somebody from floor might be having some questions. And in the event we do have time, then again we'll get back to the other questions of this persons, so that all have somewhat equal kind of opportunity to get their questions posted. So first of all, a question by Saba Yunis. What is the role of thyroid dysfunction in metabolic syndrome?
Thyroid dysfunctions again leads to decreased glucose utilization, generally if hypothyroid, and insulin resistance can occur very fast.
Hope that answer, you are okay with the answer, Sabha. We will move on to the next question posted by Dr. Nilofar. Of course, we'll come to other question if
Second
time
question
permits.
is,
Nilofar,
all the inflammatory markers are increased in, all the psychiatric disorders have oxidative stress and inflammations. Particularly, we have done on OCD, schizophrenia, bipolar, and of course, depression. Though we talk much about bipolar depression, but inflammatory markers are much increased in bipolar disorders. And they are sometimes etiologically related. So, of course, there is high prevalence and comorbidity with both metabolic syndrome and our psychiatric disorders. Dr. Naresh have already talked about it. It may not be related only to treatment, but it is related to disease also.
Okay, that was the question. That was related to role of anti-inflammatory agents and antioxidants. There was another question.
There is a jury's out whether giving antioxidants does decrease inflammatory response or not. There are some studies which say that it does. There are some studies which are against this. But what is important is yoga, exercise, and this decreases oxidative stress. That is very clear. So rather than oxidative stress, we should promote antioxidants. Prescription, we should promote this lifestyle changes.
Okay, thank you, sir. We can come back to these questions again. Dr. Sandeep, I mean, there could be people from the house.
Yes,
I mean,
let me take a question from the floor. Anyone wants to ask a question? Kindly first introduce yourself and then ask the question.
Good evening, I'm Dr. Ejaz from Postgraduate Department, SKIM Psychiatry. So I have a question, is there any role of interleukin-18 and leucine variant mutation in pathogenesis of metabolic syndrome?
10-18 are also involved. I'm not very sure of interleukin-18. So more of 6 and 10. So anybody can add on this, Sandeep or anyone.
No, that's okay, I think. That's a proper answer. Can we go ahead, please?
Anyone else from the house wants to ask question? No more questions from the floor. Dr. Subhash, you can move to online questions.
Yeah, there are a couple of more questions, I mean. One is like, there is increased IL-6 levels in COVID-19 infection and depression as well. Can this lead to higher prevalence of metabolic syndrome and depression in COVID-19 patients?
That should be because depression is occurring due to other mechanism and inflammatory mechanism where serotonin is being decreased. So depression and suicidality is being found in COVID survivors. And same mechanism, again, since a lot of comorbidity and sharing of common pathways is there, metabolic syndrome is likely to occur higher, and all the other acute reactant inflammatory markers are increased, which has to be followed. At least people are saying to follow it at least for 3 months and 6 months, because the cardiovascular risk is increased. So both are likely to increase in post-COVID patients.
Okay, thank you, sir. Sir, there is a question posted by Dr. Ashish Bandari, who has asked that as few biomarkers are similar to inflammatory conditions, can it lead to chronic inflammatory disease?
These are all how we conceptualize is important. We can conceptualize them as chronic inflammatory disorders, cardiovascular others, but I'm not sure of the risk of rheumatoid arthritis or other things with this.
Okay.
Because pathway may be different.
Definitely.
But this is all our conditions where there is a chronic inflammation in the body. Our psychiatric disorders also and cardiovascular risk factors also.
Okay. Sir, as you speak about psychiatric disorders, so a question has been posted by Dr. Nilofer, who has asked that what's the association between stress, psychiatric comorbidity, and development of exaggerated inflammatory state? What's the association between stress, psychiatric comorbidity, and development of exaggerated inflammatory state?
Now, of course, the stress increases HPA axis activations, and which leads to, again, this cascade. Insulin is increased, cortisol is increased, and we go into this cascade of inflammation, and which may lead to metabolic syndrome production. In fact, diabetes is very difficult to treat in people who are having stress or depression. So stress is directly related, and people are now, of course, thinking of gut microbiota as management of metabolic syndrome and obesity and others. You know that one of the major, in fact, challenges is management of obesity, and a lot of dollars are there. A lot of research is going on, but we are not still near to any answer.
Okay, sir. So that also probably answers another question by Dr. Nilofer, who had asked about the role of gut microbiota in development of inflammatory state and metabolic syndrome. So you have also addressed that part of the question as well. Sir, there was another question again by Dr. Nilofer, who wants to know, is there any association of gout and metabolic syndrome and effects on its treatment?
Gout is basically is a symptom, increased hyperuricemia, that is a sign of destruction, rather than it is not sign of the pathophysiology. So only treating gout is not going to help in treating metabolic syndrome per se.
Okay. Sir, we have a question from now another individual, different individual, Hadia Kaur. The question is like, why TSH is not included in the metabolic screening panel if hypothyroidism is highly associated with metabolic syndrome risk?
In fact, a lot of hormones are related, but these are etiologically related, and this panel is almost occurring together. And that is the thing which increase the cardiovascular risk. Other associated factors may be screened, like thyroid.
Okay. Sir, another question by Dr. Nilofer, like what's the predictive value of measuring inflammatory mediators for prediction or early diagnosis of development of metabolic syndrome?
They have predictive value. And if we get them, we should be trying to manage them. So they have predictive value.
I think these are the questions which I have seen here in the chat box as well as in the digital platform. Over to you, Dr. Sandeep and Avasti, sir.
Thank you, Dr. Subhash. With the permission of Avasti, sir, and consent of Dr. Subhash, may I announce the Best Question Award?
Sure, sir.
Best question is, why TSH is not included in the metabolic screening panel if hypothyroidism is highly associated with metabolic syndrome risk? By Hadia Kaur. Congratulations.
Can we see the person who is getting the award on the wider screen?
You can see her.
Now he is visible.
Thank you very much, sir. Thank you.
With this, I request Avasti, sir, for the final remarks.
Well, friends, there is, first of all, my pleasure to see two stalwarts of Indian psychiatry. The senior most president of Indian Psychiatric Society among us is here, and who are watching the program, and he's none other than Dr. Shiv Gautam. You can unmute yourself. Anyway, we'll be listening a lot to you in the next session. So it's a joy seeing you, Professor Shiv Gautam. Okay. That's fine. And also I see Rajesh Rastogi, who has done such a wonderful job for the IPS North Zone and at the national body also. And one of our young scribe, and that is Dr. Gulbihar Sidhu, whom I can see, there. He writes in the, in the newspapers, and only yesterday I happened to see one of his latest write-up, people should follow his writings, Those are, fictional writings, but full of a lot of, the pleasure in behind those. Anyway.
Thank you.
Well, friends, I think the greatest gain that we psychiatrists had out of the metabolic syndrome is that it mainstreamed us in the general medicine, like nothing else. You see, there was a time when the psychiatrists would have to scratch their heads and tails to find out whether any, tests they could order for the patients. And the patients would wonder that we have gone there with some illness and they have not any biochemical tests or any other, investigations. So what kind of doctors they are there? But the metabolic syndrome, courtesy the introduction of the SDAs, it did, bring the serotonergic, dopaminergic, antagonistic drugs. It did bring about such a change that now there is hardly a psychiatrist who is not enjoined to monitor his patients through an investigative profile, periodically. And that makes them look more like, the mainstream physicians. And that's one of the major gains. I think this was the best topic that could be chosen. And I'm so happy to see some of the people who have extensively researched in this area, like my very dear friend, Dr. Sandeep Grover. He's there, and I heard the talk of Naresh Nebnani, who has also worked in this area. Dr. Rakesh Chadda has worked in this area, and so on and so forth. So it is such a joy to be in this program and not taking any further time. I think there is my friend hiding somewhere who is supposed to be coordinating us, and he is none other than Dr. C. Mehra. So the last word has to be with Dr. C. Mehra. Dr. C. Mehra, sir, where are you?
Yes, sir.
There you are. That's right. Yeah.
Sir, it was a wonderful session, and thank you to all for kind listening. And sir, that's all.
Thank you. So back to Dr. Abdul Majid.
Thank you very much, sir. It's always an honor and pleasure to host you, although it has been virtually, but nonetheless, you are close to our hearts, sir. You are here with us in Srinagar. We are very pleased and proud that we had a lead panel of speakers, chairperson, faculty, and moderator in the form of Asim Mehra. Thank you very much, sir. The mementos to the speaker and chairpersons will be delivered later on. And we have chairperson who was here offline and who is the president of IPS North Zone, Professor Sandeep Goyal. May I request Dr. Rakesh Chadda, sir, to present memento to Dr. Sandeep Goyal. Thank you very much, sir. We are spot on time. I think we are going very well that way. We are sticking to the time and in fact ahead of time. And we start with the next session. And I already can see in the panel, we have teacher of teachers, Professor Shiv Gautam sir, who is chairing the session. We have Dr. Gulbahar Sidhu, my dear friend, who is already there, although a bit dark of a picture. I don't know why he keeps his screen always in dark mode. And Dr. Mansoor could not join us, and the honors will be done by Dr. Ajaz from my Department of Psychiatry, Skills Medical College. Over to Dr. Ajaz.
Thank you, sir. Good evening, respected dignitaries. Hope you are having wonderful and inspiring session. I feel great honor to introduce chairpersons for the next session, who are the stalwarts of Indian psychiatry. Our first chairperson for this session is Dr. Shiv Gautam sir, who is currently Director, Gautam Institute of Behavioral Sciences and Alternative Medicine, and is member advisory board as Health National Human Rights Commission, New Delhi. Sir is also advisor, Rajasthan State Human Rights Commission. Sir is the president of Mental Health Foundation Jaipur. Sir has actively served and made differences at various important positions as President of Indian Psychiatric Society, Member Medical Council of India, Member Secretary Rajasthan State Mental Health Authority, and many more positions. Sir has received numerous awards like Bhagwat Award, Marfatia Award, Life Achievement Award, and many more awards. Thank you so much, sir, for being us and made the difference in Indian psychiatry. Our next chairperson for the session is Dr. Gulbahar S. Sidhu, sir, who is consultant psychiatrist, Doaba Multi-Specialty Hospital, Jalandhar, Punjab. Sir has post-graduated from the Department of Psychiatry, Dayanand Medical College, Ludhiana. Sir is presently honorary treasurer of the state branch of Indian Association of Private Psychiatry and EC member of the IPS North Zone. As a research is concerned, Sir has numerous articles in national and international journals. Thank you, sir. Over to you, sir, for the further session, sir. Sir, kindly acknowledge Gautam, sir, and Dr.
Majid?
Sir.
Okay. Well, friends, it's a great pleasure to be a part of this program. I don't know whether I have to introduce Samir as a part of the protocol, but I distinctly remember he was our guest in Jaipur in one of the clinical practice guidelines workshops. And I'm really impressed by his work. Today's topic, that is the psychotropic medication and metabolic syndrome, is very relevant to all psychiatrists in the country and elsewhere as well. I remember about 6 years ago when I was attending one of the conferences of American Psychiatric Association. There was a symposium and the title was, "Am I an endocrinologist or am I a psychiatrist?" Because with the second generation antipsychotics, which are widely in use now, there is a lot of occurrence of metabolic syndrome. It needs to be monitored, especially with clozapine, risperidone, and the newer ones. We have to, all psychiatrists for that matter, as a part of their monitoring the patient, we have to look after his blood sugar. We have to look after his lipid profile. We have to look after the central obesity which the patient develops, and then the risk factors of metabolic syndrome. It has become all the more important with the latest reports which have come in, which I am sure Samir is going to talk about, and I will not go into the details. I distinctly remember one of my students, Parth. I had given him thesis topic, comparative study of 5 second-generation antipsychotic drugs with haloperidol and chlorpromazine. And in that study, which we have published in the Indian Journal of Psychiatry, as well as the book brought by the Indian Psychiatric Society, that it is clozapine which is most notorious, and olanzapine followed by aripiprazole and risperidone. So let's see what the latest is, what Samir is going to tell us, and what is his advice in data for the practicing psychiatrists. With these opening remarks, may I request Dr. Gulbahar Sidhu to introduce Samir further and let the session be started.
Good evening, everyone. It's a great honor for me to be chairing a session along with one of the stalwarts of psychiatry, Dr. Shiv Gautam. And I really wish we were there physically and I could have shared some very enlightening moments with Dr. Shiv Gautam. Dr. Gautam sir, I don't have the bio slide of Dr. Samir. Could you please introduce him for the audience? Over to you, Dr. Shiv Gautam.
So thank you very much, and I think does not need further introduction. He is a great scholar. So I start his session, please.
Good evening, everyone. Thank you, Gautam sir and Dr. Gulbar. I'll introduce myself, no problem. I'll just, so I am working currently in Kasturba Medical College, Manipal, in Karnataka. I'm head of department there. So I'll be discussing today this particular topic on psychotropics and metabolic syndrome. At the outset, I want to thank the organizers for giving me this opportunity, specifically Dr. Sandeep Grover, Sandeep Goel, and Dr. Majid, I can see, and all others. So I'll just share my slides and then I'll begin. Yeah, I hope my slides are visible.
No, not yet, Dr. Samir.
Not yet?
No, sir, not visible yet.
Not.
Yes,
yeah,
sir.
now it's visible.
Now it's there.
Now
Yeah.
it is visible.
And I hope I am audible enough.
Yes, sir.
Yeah, yeah. Thank you.
Yes, you.
So yeah, I wanted this one to be a more interactive session, but with the limitations of this online hybrid mode. So I'll try to convey as much as I can, and then we can take up questions at the end of the session. So I'll be a little bit more practical in my presentation. So although I have not done a lot of research in this particular area, I'll review some of the recent literature and then maybe add a little bit of my own experience also. Try to keep it a little bit more practical. We had 3 sessions, I think already a lot of information we discussed about metabolic syndrome. There are some questions that we encounter when we, in our practice, like let's say when you are giving medications to your patients. I hope some of the patients would be asking these questions to you. So can I stop my medications? So already you have been giving these medications for let's say a few months or years, and then it's a common question, isn't it? And many a times we just keep on prolonging, okay, continue for some more time and that way. So, and many patients actually accept that way. Some would come up and say, okay, I'm doing yoga. So is there any need for medication? So yoga will take care of whatever mental illness that I have. So can I stop? Or maybe they will ask very specific questions. How long? At least some people who are little knowledgeable about the conditions. So do I have to take this for lifelong, or can I stop at any point of time? And there are other questions as well. I don't know. I mean, I'm sure some people would be asking there also. So most of the patients will have this concern that all allopathic medications affect kidneys. So will it actually cause problems? like that. So a lot of questions, and we spend a lot of our time, actually consultation time, besides making diagnosis, just explaining these things. And of course, another thing which is really problematic, I'm much better now. The symptoms are under control. I'm not hearing voices. My thoughts are clear. So I'm able to do my work. But the problem is I'm getting fat. And so that is a common problem nowadays, specifically with the newer medications. So with that, we'll just look at the different medications which can lead to these kind of problems. Of course, we discussed a lot about the different components of metabolic syndrome. We would have discussed about different ways of making diagnosis. So there are different diagnostic criteria which are there. And of course, we discussed about that it's not just obesity that is there, obesity that was specifically visceral obesity that we are discussing about, not just body weight, not just BMI, but visceral obesity. I mean, waist circumference is one measure, but that's not an absolute measure actually. So even waist circumference can be a little bit problematic. So people talk about specifically, if you want to really measure visceral obesity, you may need to do MRI or something like that to see actually the extent of fat in the abdomen, which is usually not a very practical thing. We still resort to measuring waist circumference or body weight, BMI, that way. I think Dr. Sandeep would have already covered in the first session regarding the measurement part. Hypertension, another component, again, that's not very difficult to measure. Actually, we routinely measure the other two measures, lipid levels and blood sugars. Also, we do measure nowadays, now that we are more aware about these components. We do measure this before starting the medications. We continue to monitor this over a period of time, see whether they're developing problems. So that's a good practice, I would say. What we actually fail to measure is the other components. And if you discuss with different specialists, let's say if you are discussing with, let's say, medicine people, they will be talking more about obesity, hypertension, dyslipidemia, diabetes. But the moment you start discussing with other specialists, like let's say endocrinologists, they would say, no, I'm not happy with just looking at sugar levels or lipid levels. I should actually be looking at whether there is actually insulin resistance, which is much more important. Similarly, there are other markers which are coming. I think the previous session, Dr. O.P. Singh covered in detail about different markers. So pro-inflammatory markers, pro-thrombotic markers, there are so many things which are coming. But these are actually the core. So possibly what we are measuring is something which is very superficial. There are many more things which will come over a period of time. So possibly will change our practice as well. But for the time being, let's say for clinical practice, we'll be sticking mostly to measuring, let's say, the anthropometric markers, hypertension, lipids, and sugar levels. And that's good enough for the time being. And as I will tell you, let's say most of the studies that have already been done for most of the psychotropics have actually focused mostly on antipsychotics, and most of the markers are actually the components that have been studied very well is essentially obesity. The other markers have been studied also, but not as extensively as obesity. So hypertension, dyslipidemia, diabetes are studied less. Insulin resistance and prothrombotic markers and pro-inflammatory markers even less. So we don't have a lot of data to say whether that will actually affect our practice at this point of time. Okay, we discussed about the risk factors for metabolic syndrome. Genetics is very important. So we all know most of the disorders that we discussed, the multifactorial conditions. So there are several genes which are actually responsible for metabolic syndrome, the components of metabolic syndrome, you can say. And of course, it's not the genetics. It has to be the environmental factors as well. Unhealthy diet, specifically sugar-rich food, is something which is problematic because only having a genetic risk is not good enough. And inactive lifestyle, we know that actually doing a little bit of exercise actually reduces insulin resistance, which is the core of metabolic syndrome. So inactive lifestyle, basically insulin resistance will be higher, and then that's a big risk factor for metabolic syndrome. So we know about all these things and about the environment per se, where we are now at this point of time. If you see in India, the affordability is better. I mean, people have access to different food, and it's not that we all have only home cooked food. We all go out to, we have McDonald's everywhere, we have burgers, pizzas, all those junk food everywhere, and it is available cheap, when not only in big malls, but in roadside stalls also, people will have access to this kind of food, which is actually to say it's basically obesogenic environment that we are living in. And with the kind of access to this kind of food, I mean, it's very difficult. It's basically, it can give rise to epidemic, obesity epidemic. And of course, the other factors which are also important, like gut microbiome, we discussed about that. Childhood adversities, this is something interesting, because at some years before, I never thought about, okay, childhood adversity, how can this be a risk factor for metabolic syndrome? So now the studies are pointing towards this. So we need to understand. When you are doing our assessments, it is not just the family history or the diet or the lifestyle, but many other things that we need to think about, even the childhood adversities. Socioeconomic conditions, of course. I mean, again, that can also lead to a lot of, which can contribute to actually metabolic syndrome as well. Okay, I'll go to the topic proper that we need to discuss now. Is psychotropic drugs. So which are the drugs? Like I said, it's basically the antipsychotics that I'll be discussing the most, and followed by little bit literature is there on antidepressant, and I'll add a little bit on mood stabilizers. I am not touching other group of medications. But one thing that we need to understand is whenever a patient develops metabolic syndrome, psychiatric patient develops metabolic syndrome, we always blame the antipsychotics. I think in the previous session, we already discussed about metabolic syndrome can be part of the pathophysiology of different disorders like schizophrenia, bipolar disorder. So that is also we need to understand. And in addition to that, other medications. So patients with, let's say, psychiatric disorders, schizophrenia, bipolar disorder, we know that many of them, they have diabetes, comorbid diagnosis. And these patients may be on insulin. They may be on other medications like sulfonylureas and other medication, anti-diabetic medications, oral medications, which can cause weight gain. And we know that weight gain per se is a risk factor for other components, although the relationships are not very linear. But we need to keep in mind that it's not just the psychotropic medications that the person with psychiatric disorders, which is causing weight gain and other components, but the anti-diabetic medications itself, which can contribute, like insulin is a major cause for weight gain. Some antihypertensives like beta blockers can actually add on to this. Similarly, some patients would be requiring steroids, which can also lead to. So keep in mind that there are other drugs which psychiatric patients may be using, which can contribute to metabolic syndrome. So it should not always be just pointing fingers at antipsychotics and antidepressants. So having said that, so we'll examine the effects. Let's say start with antipsychotics. So I was looking at the literature, and there are a lot of studies actually on antipsychotics and metabolic syndrome. So I thought I'll focus on a more comprehensive review and a recent comprehensive review. So rather than summarizing many studies and then and if you see, actually most of the studies where the findings would be similar. I think when Dr. Shiv Gautam summarized about his experience, the study that he said that 5 antipsychotics, I think he had summarized all whatever I had to say. So it still remains the same. So we'll just go through this systematic review. This is a large systematic review and a network meta-analysis, which was published in Lancet Psychiatry 2020. Almost 100 RCTs. So this is one of the most recent that I could find. The only thing that you need to note is the median treatment duration is just 6 weeks. So essentially what data that we have is basically short-term. And this is true for most of the studies. I mean, all real-world studies are, most of the studies will be short-term. Long-term data, again, is very patchy. This is what we call the network graphs. So don't get confused. I mean, there's nothing. I just want to highlight just one point. So if you see the different components of metabolic syndrome that we are discussing, so weight, cholesterol levels, so that way, what you need to see is the more the number of lines, the more the number of studies which are available. So if you see the densest one is the for weight change. So you see there are so many lines which are there, and you see specifically olanzapine, quetiapine, the lower part, which is very dark. So it means there are more studies available for those molecules, and there are less studies for, of course, the newer antipsychotics. So similarly for BMI, for total cholesterol, LDL cholesterol, so these are the studies which are available. And so the red dots are the specific medications which are there, and the lines indicate, the thickness of the line indicate how many studies are available or what is the sample size. So similarly for other things you can see, so for lipids, if you see in the previous slide also and this slide, so weight gain, we have a lot of highest number of studies. So for the lipids, actually the studies are less. So glucose, we have some studies which are there. So now, what are the studies that that we have, and what do they say? So we'll examine one by one. So starting with, let's say, weight change. Now this one actually summarizes the weight change that is seen with the antipsychotics. As you see, there are many antipsychotics which have been studied this way, and almost 83 studies are there. And the weight change, the mean weight change, is something, if you see. So again, clozapine and olanzapine and zotapine. So these are the ones. So zotapine we don't use much. Certindol not available in India. So besides that, it is same clozapine and olanzapine, which are the dirty drugs which cause the most weight gain. So I mean, whatever we learned before, it has not changed much. If you see the mean weight change, the mean weight change is not very high. It is around, let's say, 3 kgs on an average. One thing that you need to understand is this mean weight change actually doesn't reflect, this is a mean change. So it doesn't reflect different subgroup of population. So there will be patients who would be actually gaining weight, maybe 10 kgs to 15 kgs over a period of time, short periods of time. Whereas there are some patients who would be gaining very less. So there is a lot of inter-individual variation, okay, which is not reflected when you look at the mean figures. But if you, to have a very comprehensive idea, so if you see, so the drugs which cause weight gain, atypical antipsychotics, clozapine, olanzapine, iloperidone, quetiapine, risperidone, paliperidone, even asanapine. So these are the ones which cause some weight gain. And the other medications which are almost towards the negative side is ziprasidone and haloperidol. Essentially, they don't cause weight gain. They might actually cause reduction in weight, but which is very less. I mean, less than 1 kg, so it is not very significant. So that essentially you can call them weight neutral rather than saying that they will promote weight loss. So that's where we stand. Similarly, if you see BMI, it is again the same. Olanzapine, clozapine, quetiapine, which are the problematic molecules, risperidone, these are the ones. And neutral ones would be aripiprazole, haloperidol. Similarly, if you see cholesterol change, so again the dirty drugs, 3 dirty drugs you can say, clozapine, olanzapine, quetiapine. Here a good profile, if you see, is iloperidone. cariprazine, which is not yet available, but it is going to come, and ziprasidone, lurasidone. These are quite better in that sense. But if you see, the studies are also less for cholesterol, only 36 studies. Similarly, the other components, if you see, it's mostly the same medications. If you see the other components of, let's say, lipids, it's olanzapine, quetiapine, same way. Clozapine studies are not there for this, so that's why you don't see cholesterol, HDL cholesterol. If you see the molecules which actually increases the most, which cause most problem with respect to HDL cholesterol is amisulpride. So which is not there for other conditions like weight gain, but HDL cholesterol, it will have a lot of effect. Olanzapine, again, the dirty drug. So again, if you see the right hand side, so clozapine, olanzapine, quetiapine, so these are the drugs which are the dirty drugs. And the glucose change, if you see, again, it is clozapine, which is the most prominent. So if you see, again, the ones which are neutral are basically amisulpride in this sense, and lurasidone, asenapine, ziprasidone. So these are the ones. And yes, aripiprazole, actually, it's actually causing little bit of glucose change, but then I'll come to this one about aripiprazole later when I'm talking about a little bit about the treatment part. So these are the medications which we know can cause problematic changes, all the components of metabolic syndrome from the recent meta-analysis. I also need to understand that not everyone has the same kind of weight gain, not everyone has the same, like I said. So the baseline weight also determines some of the things. So if the baseline weight is more, the changes of the glucose levels is also higher. So as you can see, the right-hand side graph, there's a very linear relationship. The baseline body weight is more. They're more. So this is a heat map. Essentially, this summarizes what I was trying to present in the previous slides. So in one go, you can see. So the red ones are basically the ones which are problematic drugs. So as you can see in the weight things, olanzapine, clozapine, zotapine, satindol, these are the ones which are problematic. BMI, you see again olanzapine. One particular problem with olanzapine, which was reported earlier, quite some time back, is for most other medications, there will be changes in weight, but then it plateaus at some point of time. But with olanzapine, it may not plateau. Actually, it continues for a longer period. The problem with interpreting those data is we don't have many long-term studies to actually say whether other drugs also have similar kind of effect. But olanzapine that way is pretty problematic. But I'll come to the other aspect of olanzapine also in subsequent slides. And we know about clozapine. I mean, when we need to give clozapine, we need to give clozapine. There is no other option. So we have to treat diabetes. We have to treat whatever metabolic syndrome comes. But we'll have to give clozapine. There is no alternative for clozapine. Same glucose again. So clozapine is even bad than olanzapine in terms of glucose. LDL cholesterol, total cholesterol, it is olanzapine which is problematic. HDL cholesterol, like I said, amisulpride is little problematic along with olanzapine. And triglycerides, so again, clozapine, olanzapine are the ones which are more problematic. Now, you can ask the question. I mean, we're talking about atypical. It all started with atypical antipsychotics. No? Before that, we were not discussing much about metabolic syndrome. We never. So before we had all these newer drugs. So is it only atypical antipsychotics, or what about other medications? So another meta-analysis which actually looked at this. That almost all antipsychotics result in weight gain. So this is an analysis which will make you think. So because like I said, the previous meta-analysis, it was specifically short-term studies. So given a long exposure, so we will be giving medications in bipolar and at least in schizophrenia, I will be giving for years together. So given prolonged exposure, all antipsychotics are associated with weight gain. This is something we need to keep in mind. And it is much more if it is person is antipsychotic naive who has never been exposed to antipsychotics. And we know that, I mean, adolescents, they gain more weight than adults. So there are other differential effects which we can see with antipsychotics. So the baseline weight also determines weight gain. So yeah, I'll come again in the treatment part. I'll just tell a little bit about this again. Once someone develops actually antipsychotic induced weight gain or metabolic effects, it's very difficult to actually reverse. So losing weight is not easy, and the only way to actually avoid this is preventing weight gain. So that is something that we need to understand. So just again to highlight the same point that I tried telling, is it just atypical antipsychotics? So if you see here, the high risk of course, olanzapine, clozapine, but then you see also the moderate risk of weight gain with medications like thyroidazine and chlorpromazine. Thyroidazine we don't use much, maybe low dose people would be using nowadays mainly for sedation. Chlorpromazine sometimes we do use still, specifically young patients who require maybe for sedation or for controlling agitation, we do use. Although, I mean, the usage has come down, but we should be very careful because these medications also cause a lot of weight gain. Many times we start these medications in the acute phase, but then fail to stop these medications. And patients, they're lost to follow-up. They'll come with a lot of weight gain. So this is something that we need to also remember, that it's typical antipsychotics also which can cause weight gain. Of course, not haloperidol, which is more neutral. I will not discuss about the mechanism of metabolic syndrome. Very complex mechanism we discussed in the previous presentation. A lot of things our understanding is quite less. So why this is happening? There are so many things which have been proposed. So rather than going into theory, I'll just tell you that the mechanism is quite complex and then very difficult to pinpoint a single thing that way in a particular patient. Now, another question I want to ask is weight gain or this metabolic effects are necessary for therapeutic effect? So there have been several ways in which it has been discussed. Some say that weight gain actually precedes therapeutic benefit. I mean, if there is weight gain, there will be therapeutic benefit. Some people say no, because there is a therapeutic benefit. I mean, a schizophrenia patient who is not taking meals properly, or bipolar patient, a depressed patient not taking meals, but then once they start eating properly, they gain weight. So it's more like a byproduct, no, more like a epiphenomena. Some people say that no, it is the antipsychotic drug action actually leads to both therapeutic benefit as well as weight gain. I'll come to this point again. Or some say it is just the dissociated effect. So weight gain, therapeutic benefits are totally separate. So you can have therapeutic benefit in absence of weight gain as well. So there are 4 different scenarios. But one thing that we need to always think of when you see this kind of scenario is we're not dealing with a single schizophrenia, or we're not dealing with a single bipolar disorder. They're all a heterogeneous group of conditions. So some patients may be having let's say pro-metabolic syndrome kind of profile, which is part of pathophysiology. Some people have other genetic vulnerabilities. So we're dealing with more than one type of illnesses. That brings to this concept of metabolic threshold. I hope some of you would have heard about this metabolic threshold concept. Neurotic threshold, I think you all know that when we have to choose an antipsychotic, we need to see whether it is adequate dose or not. How do we find out? We look at, specifically with the older generation drugs, we would look at mild EPS and see that, okay, now that we are giving this dose of medication, possibly we are giving a correct dose, and the patients would respond because it's blocking enough D2 receptors. What do you do for atypical antipsychotics? It doesn't, except for risperidone. Maybe risperidone, you can apply the same principle. You can look for minimal EPS. Now, if you are giving quetiapine, which is more like a hit and run drug, so it binds to the D2 receptors, but there is a fast off. It dissociates very fast from the receptors. So it actually has a very transient effect. Now, how do you know whether it is the dose is adequate? Some people have thought, okay, whether metabolic threshold is a concept which is similar to neurologic threshold, which has been proposed to identify so this group of patients who respond. There's a study done in Nimhans. He looked at this effect. So essentially, they found that there's a close relationship between this the side effects, specifically weight gain and other metabolic adverse effects, and clinical improvement. So they proposed so whether there is a neurometabolic threshold for second generation antipsychotics, and whether we can identify responders based on this. Now, if we go back to the meta-analysis that I quoted initially, so you see something similar again. So the meta-analysis of all the studies, antipsychotics. So changes in body weight is clearly associated with symptom improvement. So possibly the body weight BMI specifically, although like I said, the literature on lipids and glucose and other parameters are a little less, but BMI, so changes in body weight actually correlates with improvement in symptoms. So possibly there is a truth in, at least in a subset of patients. Okay, so again, like for others also, there is little evidence, but again, the sample would be very smaller for the other lipids. Okay, let's look at antidepressants. How do they affect these components? Now, there is a study which has looked into long-term follow-up study which has looked into antidepressant use and in general, I mean, any antidepressant. They found there is an increase in weight gain risk with use of antidepressants over a long period of time. So again, all antidepressants. So that is something very surprising. So it's a combination of not just tricyclics, the dirty antidepressants, but even the newer ones. So when they combine all drugs, still there is a almost 21% increased risk in long term with antidepressants. So now this is a more like a summary slide of many different studies. So basically, if you look at this, the mean weight change, if you see again, around 2 kgs more with amitriptyline, metazapine, paroxetine. So these are the 3 medications which cause the highest weight change. So as you can see here, even SSRI. So SSRIs also are known to cause weight gain in long run, maybe except for fluoxetine, which is slightly weight neutral. So keep in mind for practice point, so amitriptyline and of course other tricyclics as well, but highest with amitriptyline. Paroxetine among all SSRIs, and metazapine, that we all know. It not only causes weight gain, but also increases the risk for dyslipidemia and diabetes. Bupropion is one molecule, and fluoxetine, which have little negative kind of effect. So they don't cause weight gain. So again, if you see another review basically which has looked into antidepressant use and metabolic syndrome. So if you see, it actually correlates with depression severity as well. So number of metabolic syndrome components increases as the severity of depression increases. So we are discussing about, I think the previous presentation we discussed about different disorders which can give rise to metabolic syndrome. So depression per se can cause metabolic syndrome in the sense, I mean, there may be a common pathophysiology. Also antidepressant use. And this particular review basically tells you that tricyclics has the highest level of chances of developing metabolic syndrome components as compared to SSRIs and other antidepressants. Again, if you see the specific components, if you see the lower part, the antidepressant use rather than the other depression and anxiety severity, if you see antidepressant use, so tricyclics, if you see the highest level in obesity and other components as well. So lipids, sugars, and hypertension. So highest risk is with tricyclics as compared to no antidepressant use or SSRIs. The only thing is the samples are very small, so difficult to draw meaningful conclusions from this data. Another longitudinal study, so specifically which looked into the use of antidepressants. So very large sample and more like a naturalistic cohort. So antidepressant use leads to almost 9% annual increase in the odds of metabolic syndrome. So that is one data which tells you long run. Like I said, most of the conditions will not be prescribing for short term. So there are very few studies which have actually looked into the long term effects. So, and most of them, they say that the risk will be much higher. Interestingly, gender analysis showed that this particular association with antidepressant use and metabolic syndrome is much more in men as compared to women. And the odds, if you can see, although in this particular study, they found SSRIs causing more weight gain. Like most of the short-term studies, they found tricyclics having more weight gain, but the risks are also as good with SSRIs. So this is the problem that happens when you don't have data regarding long-term studies and focus only on the short-term studies. The mechanism, again, most commonly they say it is H1 mechanism, which leads to weight gain. And so higher the H1 effect, the higher will be. So mirtazapine, amitriptyline, those are there, causes highest weight gain. Whereas the other end, if you see, tail end, if you see bupropion and other molecules which have less of weight gain. But it's not that simple. I mean, it's not just H1. There are many other things which, again, I'll not go into the details. Mechanism, there are very complex mechanism, and it will be different for different medications as well. Let's look at mood stabilizers. So we have actually very less data on mood stabilizers, if you see, on metabolic syndrome or its components. Lithium is one molecule. We all know that lithium causes weight gain, but surprising to see actually very less literature, because those days it was not being studied very well, metabolic syndrome components, and nowadays people don't focus on lithium. So, but nonetheless, actually, whatever we have seen, lithium patients actually gain quite a bit while on medications, and specifically much more if the baseline weight is more. So that is another thing that you need to remember. So this is a comparison of lithium versus lamotrigine. So that lamotrigine is relatively safer. Among other anti-epileptic drugs, again, the data about weight gain, you'll have some data from epilepsy studies rather than from studies from psychiatry per se. So sodium valproate causes weight gain, so that we all know. And the other medications like carbamazepine, oscarazepine, these also cause weight gain, gabapentin, pregabalin, common medications which are used. No effect if you see, lamotrigine, relatively safer. And there are some which are used for weight loss like topiramate. So that's what sometimes we use. So, so most of the conventional antiepileptics, if you see, actually cause weight gain. Now this is more like a summary slide just to give an overview about so which group of medications cause more weight gain and other components of metabolic syndrome. So if you see, so more the number of pluses, so higher the chances of weight gain. So amitriptyline, mirtazapine, clozapine, olanzapine, so all 3+. So they are the ones which cause a lot of weight gain. And if you see lithium, valproate, quetiapine, risperidone, they are all paroxetine, they are all 2+. So they also are quite bad in that sense. So this is more like a summary slide that way. And now weight liability, if you just put so low to high. So if you see again, so the left-hand side, if you see bupropion, molindone, these are the molindone we don't have, lamotrigine. Short-term SSRIs, like I said, no, long-term, they all cause weight gain. So if you see it goes to moderate range and paroxetine almost towards high range. And if you see the other extreme, the high side, those dirty drugs that we discussed, no, olanzapine, clozapine, chlorpromazine, haloperidol, quetiapine, the molecules which are there. Now, there are some weight-neutral drugs like aripiprazole, ziprasidone, amisulpride, lurasidone, cariprazine, which are the new ones which are coming. Fluoxetine, bupropion among antidepressants, and topiramate, zonisamide. So when you have some situation in which you need to give medications, which patient is already having some risk factors and you want to avoid metabolic syndrome, better to choose from these drugs. But one thing that we need to remember that although we say olanzapine is a dirty drug, the efficacy of olanzapine has been shown to be one of the highest. I mean, if you go by CATI trial, olanzapine is the best antipsychotic among others. And like I was discussing about that metabolic threshold principle. So so those are causing weight gain. Actually, possibly they could be also contributing to therapeutic effects. That also we need to keep in mind. So we have more responders with olanzapine, quetiapine, which are dirty drugs, and of course clozapine. Like I said, if you have to give clozapine, you'll have to choose clozapine, and you'll have to choose early, because the more you delay starting clozapine, the more problematic it can become. The person can may not respond very well if you initiate clozapine. So there is data to say that if you have to give clozapine early. So that way it can be a little bit problematic, but maybe in the initial phase you can try out with other weight neutral drugs, specifically if there are risk factors, and then see. Not working, of course, you'll have to go back to those drugs. So if you have to even reduce weight, sometimes we use these combinations. You add topiramate and other drugs, bupropion. So if you keep this chart in mind, probably it will be helpful. Now, just few more things. I'll take just 5 minutes more. So do we all get fat? No, we don't. So is it all about genes? So we discussed about common pathophysiology. So bipolar disorder, depression, schizophrenia with metabolic syndrome. Of course, there are pharmacogenetics, which is there. So so some drugs interacting with the genes. There are specific receptors which have been identified, like serotonin receptor 2C, which is consistently associated with antipsychotic weight gain. Similarly, many other. So I won't go into the. So there are some which have higher evidence, some which are moderate evidence, and there are many which have questionable level of evidence. So we don't know. But we need to understand, actually, there are some genes which are common for pathophysiology as well as for the effects, the pharmacogenetic effects. Now, if we talk about, let's say, how much food intake and how much exercise that you are doing, I mean, you are taking, so energy intake and how much you are expending will tell you whether you are gaining weight with antipsychotic. Is it that easy to say? So we reduce the intake or we spend more using exercise. I know it's very difficult to spend calories doing exercise. It's little bit easier to actually cut down on the food. But is it that easy? No, it's not always that easy. So there are many other factors. So it's not a very simple equation this way. So there are specific components in the diet which goes beyond the just simple positive energy balance, like taking saturated fatty acids versus polyunsaturated fatty acids, which is much more protective. So this is not just simple energy balance. Fats versus carbohydrate. So which one is taking? So red meat, which is problematic, versus even the processed meat. I mean, much worse would be the processed meat. Similarly, if you're taking simple sugars or complex sugars, so these are all important. Also, I mean, just going beyond just the calorie count. So we need to keep in mind this also is important. Also, when you're talking about let's say, food intake, we need to also discuss about why some people prefer certain kind of food, because it's not just enough to tell that, okay, you cut down on this food. We need to understand why this happens. So many times, many people end up eating this high fat, high sugar diets in stressful periods, which is more related to sort of emotional eating. So it actually helps them calm down their emotions. So this is also very important. So need to educate patients regarding this. And of course, there are many other factors. I will not go into overeating. There are so many things that you can think of, and then these all things we need to keep in mind when we need to educate. And like I said, it's easy to actually cut down on the intake rather than spend doing physical activity. Although physical activity will help in some other way, it will actually help in reducing insulin resistance, and that way it is helpful rather than actually causing weight loss. So what are the medication options? So just 2-3 slides. Metformin, highest level of evidence. The problem is it doesn't cause a lot of weight loss. It may be 1 or 2 kgs mean weight loss, but then in individual patients it can be much more. Like some patients I've seen who have lost around 10 kgs with metformin. So I use it as a standard practice. I use metformin quite often. It's very safe drug, very less side effects. Usually I would give around 1 gram metformin with patients in which I'm giving other drugs, sometimes as a preventive strategy also. You can use it if there are risk factors. And of course, as a treatment also. Treatment actually it is more difficult. It's better if you use it in the beginning. But I have had good results with metformin, so I would recommend this medication. Most of your patients, if they're not, because some people will not be very happy with exercise and diet control. There are other agents like S2 blockers. There are so many medications which have been tried. So difficult to use. We don't have niraparib in any way. The other drugs, aripiprazole is one good molecule that you should be using, not just for hyperprolactinemia, but also for metabolic syndrome. So you can add a low dose of aripiprazole to the existing regime. It actually normalizes sometimes. Although aripiprazole in meta-analysis has been shown to cause weight gain also a little bit, but it's mostly a negative effect that I see. I mean, it causes weight loss. Other drugs you can try is topiramate, difficult drug basically. I had used, but then not something I would recommend because there are other side effects which you need to look for, cognitive effects, other things. Sibutramine we don't use, reboxetine out of market now. So the 2 drugs that I would suggest that you can try out if you need to give medications is metformin, which I regularly recommend, and aripiprazole is the second molecule. A very low dose, not very high dose, maybe 5 milligram. Summary, so metabolic abnormalities are common, like I said. It's not just genetics, but environmental factors are important, diet and other things I said. We need to know the metabolic signatures, which one is more prone, which one is less prone, so that we identify the right molecule. Risk assessment, you already discussed, I think, periodic monitoring that you need to do. Timely intervention, you should advise things, lifestyle changes and medications if needed. And prevention is the most important. So I'll stop here. Thank you. I'll take up any questions if it is there. I'll stop sharing.
Thank you so much, Dr. Sameer sir, for such an informative and very important presentation. Thank you so much, sir. Over to Honorable Chairpersons for the question answer session and final comments. Thank you.
Thank you very much, Dr. Sameer, for a very comprehensive and lucid presentation. Now, the paper is open for discussion. We have a couple of questions on the chat box. So if you would like to address that, and then we can have questions from the floor.
Yes, sir. I'll just go through the questions.
Please.
Yeah.
Is there any question on the floor?
In fact, so there's a flurry of questions. 18, 19 questions have come.
In the chat box, I'm reading those questions.
You can start with the online questions.
Yes. So I think, do NSAIDs have any role in depressive disorders, considering inflammation as a significant part of depressive disorder? Yes, there have been studies on NSAIDs. The thing is, again, it is something which is too preliminary. It is not recommended as of now, but it is still under investigation. If patient has risk factors for metabolic syndrome or has diagnosed metabolic syndrome and has treatment-resistant schizophrenia, can we still use clozapine? What are the other agents to augment a bit resistance without increasing metabolic risk further? Now, if someone has treatment-resistant schizophrenia, there is no doubt that we have to use clozapine. We cannot use any other drug. So we will treat whatever components of metabolic syndrome is there and go ahead with clozapine. One thing that I would like to tell is we usually will go for, let's say, 2 antipsychotic non-response, then plan clozapine. But actually, the definition of this 2 antipsychotic, this started long time back, going back to Keynes and the further studies. The problem is the atypical antipsychotics are different. They are not same as typical antipsychotics. So we don't know if the person has not responded to 2 antipsychotic, they may respond to a atypical antipsychotic, the newer ones. So that is a problem, because I have seen many patients who have not responded to even clozapine in treatment-resistant schizophrenia. They have not responded to clozapine, but I switched to another atypical antipsychotic and they respond. So at least with quetiapine, that's what I have seen. Sometimes even olanzapine. So a little bit difficult that way. So the traditional concept of treatment-resistant schizophrenia and clozapine also is a little bit problematic. But then if you have to give clozapine, you have to give. So no option. So you treat the components and give. Can patients develop metabolic syndrome independent of body mass with psychotropics? What are the treatment implications in treating lean patients? The problem is, again, like those who have baseline risk factors for metabolic syndrome, there will be high chance for developing the full-blown other components as well. The problem with lean patients is, although we call them lean, there is a concept now of lean obesity, lean obese patients. So not all lean patients are healthy. So we don't measure their actual visceral fat. So which is why we may misjudge that way. So we'll have to be careful for all patients, irrespective of whether they have high BMI, low BMI, lean, fat, that way. Does antipsychotic polypharmacy increase the risk for metabolic syndrome? Yes, it will, because it will have additive effects, and because they'll target now different molecular mechanisms, so more chances. Does augmenting doses of antipsychotic increase the risk of metabolic syndrome? So essentially, there are some studies to say that it may be dose dependent for some, but some people have unique vulnerability. They develop even components of metabolic syndrome at lower doses also. So even if you're augmenting with lower doses, you still have to keep in mind components of metabolic syndrome. Can treatment with antipsychotics for brief duration lead to metabolic syndrome? Yes, it can. So the patients who are vulnerable, most of the studies that I showed actually are short duration studies. Long duration, most of the medications cause components, at least weight gain. Short duration also, they have been shown to cause weight gain. To manage a case of treatment-resistant schizophrenia, stable on clozapine, but develops metabolic syndrome. Yes, I mean, if someone develops components of metabolic syndrome, I'll not stop clozapine. The patient has responded to a particular medication. The strategies, 2 strategies that I said, pharmacological strategies. One is, first thing that I would do is add metformin. The second strategy you can think of is adding low dose of aripiprazole. These are the 2 things that I do. There are many other, I mean, if you see, there are at least 15, 20 different drugs which are being studied, including the newer medications like liraglutide, and so we don't have a lot of evidence for those medications. But at least try out the simpler ones, which is easily accessible, available, low cost. So metformin, I would say. And more important than metformin is lifestyle changes. So advising about the diet, about exercise. So what are the predictive factors for development of metabolic syndrome with psychotropics in addition to risk factors associated with metabolic syndrome? There are many actually. So it's not just the psychotropics. Like I said, no, it is the illness. There are so many factors that I said, starting from genetics to the environment that they're, the dietary habit, the lifestyle, even other factors like I said, no, gut microbiome and so many things which are coming very difficult to. So there are a lot of things which are there which can predict, but difficult to characterize. I mean, how much, and so quantification is not something that we can do at this point of time. It becomes a little difficult. Cariprazine and reversal of metabolic syndrome, you'll have to check, but cariprazine is relatively safer for metabolic syndrome. Yes, possible. I mean, but then we don't have cariprazine in the market, so we don't have any experience. Whatever is there in the studies is too early. So unless we have phase 4 studies, no, a lot of phase 4 studies, post-marketing studies, which will tell us about what is the prevalence of metabolic syndrome in patients on SSRI as against those with SNRI and tricyclics. Yes, like I said, short term actually tricyclics are have a poorer profile, but long term even SSRIs have a bad profile. But of course, I mean, we know amitriptyline, the one which causes the most weight gain. Similarly, among SSRIs, escitalopram causes a lot of weight gain that we see, and that is one of the most commonly prescribed antidepressant, I would guess, should be all over India. So SSRI, if you want weight neutral one, fluoxetine is the best, but it has other problems, as you know. How much is bariatric surgery effective or prevalent in patients with psychiatric disorder, metabolic syndrome? Bariatric surgery has its own indications. It's not just the surgery which is important, because like how many schizophrenia patients you would recommend bariatric surgery? We won't, isn't it? So depending on the patient profile also. So I don't know, I'm not sure about what is the prevalence, how commonly people do. I don't know, I have never referred a patient for bariatric surgery till now. How pertinent is it to use low dose antipsychotic like olanzapine and quetiapine, non-psychotic patients? Yes. Yes, so you should actually avoid, this is very important actually, because many a times we augment anxiety and other conditions also, we keep on adding low dose of, so that's not a very good practice. So unless a patient has not responded, really treatment resistant, we should not be introducing antipsychotics which cause, but then you need to also understand that many of the medications which are used for treating anxiety like escitalopram also can cause weight gain. But you need to be careful when you're giving olanzapine. Yes, metabolic syndrome itself has its effect on executive dysfunction. Little difficult, but then yeah, possible. It can have. I would believe there are studies, but it is very difficult to tease out the effects, because that will interact with the diagnosis as well. How many weeks or months does it possibly take to reverse the metabolic effects of a drug once it is withdrawn? Most of the times it doesn't reverse. So that is what I was trying to tell. If someone gains weight, if someone develops components of metabolic syndrome, it doesn't reverse on its own. So most of the patients will have to be with that, stay with that. So that's why we want to prevent, and you identify early, treat early. So that's better. So you can teach them lifestyle changes and other drugs like we discussed. Which parameter of metabolic syndrome improves first? I have not actually looked into this, but I think that's an interesting one. We can look into this one. Adding aripiprazole, does it improve metabolic profile? Yes, there are some studies which say that. Yeah, aripiprazole with olanzapine or clozapine, low dose can be added. It also helps in other condition also, specifically if someone is having with risperidone, let's say someone is having hyperprolactinemia, you can add aripiprazole also, that also helps. Similarly, it helps in metabolic syndrome, but less effective as it helps in hyperprolactinemia. Can we continue psychotropics in metabolic syndrome and rely only on behavioral lifestyle changes? Ideally, the only treatment that we have is behavioral and lifestyle changes, but you need to always rationalize whether we need to continue the psychotropic, whether we can reduce the dose, whether we can switch over to a weight neutral kind of medication. That is something that we need to
Samir,
We'll stop.
I think you have answered most of the questions.
Yes, sir.
And I can see the restlessness of Dr. Majid on the screen. In order to manage the time and the responsibility of the chairpersons also in managing the time. But I think most of the questions have been answered very well. So it is very important that metabolic syndrome is recognized on time, number one. I am just repeating the carry home messages which Samir has given to us. Secondly, the lifestyle management is most important when you deal with metabolic syndrome. Third, the monitoring of the doses effectively, or if possible, a change of antipsychotic or psychotropic drug might help, which we have seen in many cases. But most important thing is monitoring. And monitoring of hypertension, monitoring of the central obesity, monitoring of the blood sugar, monitoring of the lipid profile. All this is very important, and to some extent it might go up. But when it goes beyond certain limit, that limit has to be decided by the clinician in his clinic. We have to see that the preventive measures are taken to see that metabolic syndrome does not occur, because after all, if it goes beyond a limit, it becomes life-threatening. And life is more important than as we have the dictum of medical sciences. I hand over the podium to my co-chairperson, Gulbahar. And
Yes, sir.
then,
Sir, just...
Yes.
Yes, sir. Please go on, sir. Please go on.
No, I think you make your
Okay.
comment before I thank Majid and his team
Yeah. Sir,
for giving us this opportunity. Yeah, please.
Sir, listening to all this exhaustive, very good talk by Dr. Samir, I'm inclined to believe that psychiatry has come a full circle. From being a very exclusive entity a few years back to an all-encompassing inclusive entity. It is time we should all be learning to be doctors first and psychiatrists later. I think that is the most important carry-home message that we should be going to all young doctors sitting here, young psychiatrists. Thank you.
Thank you, Gulbahar. And now is the time that thank Sandeep.
Sir, you are not audible.
Am I audible now?
Yes, sir.
Okay. So this was to thank you, Majid, Dr. Rajesh Rastogi, Dr. Sandeep and your team for organizing a wonderful program. With that, I hand over the podium to Majid. Majid is a wonderful person. I have seen him ever since he was a resident doctor, and he was for me to Srinagar. I remember the phone. Thank you.
Thank you very much, sir. I remember the PGTP we held in 2005, and you were the faculty that time, and I was the resident. Thank you very much. You have been a teacher like always, and keep us blessing with your thoughts, with your experience. So thank you very much. Sir, can I take a minute that you have to adjust the best question out of online? Gulbahar can, I think, or you, sir, can... we can announce it later on. Maybe by the time you can, sir, please go through the questions again.
Can we give this responsibility to Samir? because he has answered all the questions and read them very
Samir,
carefully.
yeah, Dr. Samir, please.
So you decide that question.
So I think I couldn't read. I'll go through and is it okay if I just
please
message?
Yeah, you can
communicate it
convey
to Majid so that
Samir, convey to me later on. Once you're off, you can send me an SMS. We can announce later on. Thank you very much, sir. Shiv Gautam, sir, Dr. Gulbahar, Dr. Samir for wonderful presentation. And may I request Dr. Raju to hand over a moment to Dr. Ajaz, who has been the moderator for session. Thank you very much. We move on to the next session, and I could see the smiling chairperson and speaker on the panel already. Dr. Siddharth Sarkar is the speaker from All Indian Institute of Medical Sciences. And we have our office bearer team, present and past, led by Professor Nitin Gupta, who is Vice President, Indian Psychiatric Society North Zone. He is a well-known face, and he is editor of many reputed journals, and he is also editor of Indian Association of Social Psychiatry. He has briefly worked in, not briefly, I think for a long time worked in UK, and he is passed out from PGI, and currently he is in practice in private practice in Chandigarh. Then we have our past office bearer and currently into the Election Commission, Dr. Ajit Sidana, sir. One of the prominent faces of Indian Psychiatric Society North Zone, who has contributed immensely. He is right now Professor of Psychiatry at GMC Chandigarh, and is still contributing as member, I think he is member Election Commission, returning officer Election Commission, if I'm correct. Sorry. Then we have the most important, who is present here, and I am honored to be her student. She was my MD examiner, Professor Savita Malhotra, who is the past head of the Department of Psychiatry. I remember in 2005 when she came as examiner in our MD exams, Dr. Zayed and myself, and she was examiner of Dr. Arshad as well. So we are honored to have you and to take it forward. May we start with Professor Savita Malhotra, madam, and move on to Dr. Sidhana, sir, and Dr. Nitin Gupta.
Thank you very much. Thank you very much for this kind introduction. And at the outset, I would like to thank Dr. Sandeep Goyal and Dr. Abdul Majid for giving me this honor and opportunity to be here. Srinagar is always a very, very inviting place, and one always likes to kind of, have the opportunity to come, and then their hospitality is exceptional every time. And I'm very happy to be here. And also, I am grateful to Dr. Rajesh Rastogi for fitting me into the scientific program for the today PG development program. Welcome to my two co-chairpersons, Dr. Nitin Gupta, Dr. Ajit Sidana, both of them in Chandigarh. And today I realized that it's the end of the day, 7 p.m. And there has been a lot of metabolic syndrome from the afternoon and continuous lectures. I hope that our participant students who are listening still have some energy left and would be able to know here I must say then, the next speaker is going to capture your attention and you will regain your energy. And the topic is also very, very interesting. Dr. Siddharth Sarkar. He is faculty from, is there any introductory slide for him? Dr. Sarkar's biodata slide, one could share. He is faculty in AIIMS, Delhi. And of course, he is a very, very brilliant teacher, researcher, and academician. And he is going to talk about substance use disorders and metabolic syndrome. Apparently, it may look that as if, what are we going to talk about? But we understand that several the substance use disorders like alcoholism, tobacco, they are very clearly and apparently associated with metabolic syndrome, and they have insulin resistance, hypertension, obesity, and abdominal girth is increased, and so on and so forth. But certain other substance use disorders, like, for example, amphetamines or opiates, heroin, they may be associated with weight loss and so on. So here we are going to listen to Dr. Siddharth Sarkar about the intricacies of this whole subject of substance use disorder and substance use disorders and metabolic syndrome. Before I invite Dr. Siddharth Sarkar, I would like to ask comments from Dr. Nitin and then Dr. Siddhana, and then Dr. Siddhana can invite Dr. Sarkar for the talk. Thank you.
Thank you very much, ma'am. Thank you again to Dr. Rastogi, Dr. Sandeep, and Dr. Majid for inviting me as the chairperson here. It's a pleasure to be chairing this session with Professor Savitam Lotra, my teacher, and Dr. Siddhana, my dear colleague with whom I worked for many years in GMCH. And all the more pleasure to hear from Siddharth, with whom I've been working for many years and troubling him in many ways. I won't say much except ma'am has already introduced the topic, except that I think that one of the substances which Siddharth will be talking about should help the audience perk up a little bit, because that will be the harbinger to the evening which will be laid out after this session is over, that is alcohol. So it has its own positive uses also. I think, I don't know whether Siddharth will be covering or not, but I think apart from the metabolic disorders associated with pure substance use, one of the important areas is also dual diagnosis. I know that is something which can be a totally separate topic in its own entity. But if that is touched upon a little bit in this area, in his presentation, that would be a very useful thing to do. With these brief comments, I'll pass over to Dr. Siddhana to introduce Siddharth to the audience. Thank you.
Thank you, Dr. Nitin. Thank you, organizers, for giving me the opportunity to chair the session with Madam and Dr. Nitin Gupta. The topic is very well chosen. It's a very important topic, but equally ignored area. Hardly we look for any kind of metabolic syndrome in the substance use disorder patient. Our focus is generally on to treat the patient for the substance and to provide the anti-craving medicines and take care of the LFT or even the viral marker. But it's such an important area that we know that patient with substance use disorder, especially the alcoholism, they are likely to have a disturbed lipid profile and the blood sugar profile, the two predominant area. And we all are very hopeful that Dr. Siddharth Sarkar will enlighten us in this area, that how to predict or assess such changes in the patient with substance use disorder and how to manage them. Over to Dr. Siddharth Sarkar.
Thank you, sir. Let me first of all thank Professor Savita Malhotra, my past teacher when I was there in PGI Chandigarh, for the kind introduction, as well as Dr. Nitin and Dr. Siddhana. Let me also thank Dr. Rastogi, Dr. Majid, Dr. Sandeep Goyal, Dr. Sandeep Grover, and others from the IPS North Zone for having me present on this topic. And I hope at the fag end of the day, I still have a little bit of attention from the students as well who have logged in. I really appreciate all the students who have been there posing questions. That means they have been attending to it very sincerely and seriously. And, their interests have been kindled on this topic. So this would be the outline of my presentation. I'll be talking a little bit about metabolic syndrome again, recapturing or for the nth time repeating what has been told. I'll talk about metabolic syndrome in the addiction clinical setting, and then about specific associations of certain substances, predominantly alcohol, tobacco, opioids, cannabis, and maybe a few other substances. And then how can we address such metabolic syndrome in the clinical setting where we deal with addictions. And then I'll conclude with a few take-home points. So again, recapturing, metabolic syndrome is a cluster of conditions that occur together and increase the risk of heart disease, stroke, and type 2 diabetes. So metabolic syndrome, why it is important, is the condition, the cluster of symptoms or the cluster of findings on physical examination and laboratory parameters. They are not a disease by itself, but they increase the chances of having adverse outcomes. So that is why we need to take a look at them, and a specific cluster of them predict such instances. Now, what are included in them? They include increased blood pressure, high blood sugar, excess body fat, abnormal cholesterol, and triglyceride levels. So this is a simplistic kind of definition, and many scientific associations have put forth much clearer, much precise, much more replicable definitions. Compare definitions from International Diabetes Federations, the ATP3 criteria and WHO criteria. They put forth certain elements in different parameters of obesity, parameters of blood pressure, parameters of glucose. One of them uses albumin in the urine as well, not others. Then triglycerides and HDL cholesterol. And the kind of permutations and combinations that are recommended also vary. For example, the IDF consensus, they require abdominal obesity to be present, along with 2 more risk factors. While the ATP3 criteria says that any of these 3 factors are present, then it is, then there is metabolic syndrome. And what the WHO suggests is that diabetes or impaired glucose tolerance or increased insulin resistance plus any of the 2 risk factors, for example, body mass index to be higher, or blood pressure to be higher, or triglycerides to be increased. So there is little bit of variability in how people conceptualize or operationalize in the clinical setting this metabolic syndrome, and this is important because a person might be metabolic syndrome with one criteria and may not be metabolic syndrome by another criteria. So we need to, as clinician, appreciate this fact. So hence, given these 3 variability of criteria, people have tried to look whether all 3 criteria they measure up together or not, and people have found that they do not. So, in this sample of a large population, about 1/3 of the population, that is around 224 participants, they fulfilled all the 3 criteria, while there was overlap between one or the other criteria. But interestingly, there is a subset of people who fulfill only the WHO criteria, not the other criteria. Some who fulfill the ATP3 criteria, not other criteria, and so on and so on. There is considerable non-overlap that is there. So why do we bother about metabolic syndrome at all? So, the simplest reason is that they lead to poorer outcomes. And what kind of poorer outcomes? Occurrence of diabetes in the future, occurrence of cardiovascular diseases or coronary heart disease in the future, mortality in the future, and mortality due to coronary heart diseases or particularly cardiovascular diseases in the future. So why are we bothered about these is because they lead to problems in the future, and that is why we should be considering these conditions in the clinical populations that come to us. Again, they affect a considerable proportion of the population. So not only clinical population, large proportion of the general population may also be having metabolic syndrome. We need to talk about metabolic syndrome generally, not only as psychiatrists, but as doctors as well. We need to consider about metabolic syndrome. But the rates of metabolic syndrome vary across countries and across the population groups. So the first column in very small font shows India, and the rates vary between men and women using the criteria that we have. But the rates would be higher in certain populations and the rates are lower in certain countries. For example, in France, in age group 30 to 60, the estimates are seemingly quite low. In USA, Filipino Americans, the difference between men and women is very high. And in USA, Native Americans of 45 to 49 years old, the rates may be very high, crossing about 50%. So the manner in which you take the population, their age composition, their ethnicity, their residence, their location, that determines what is the chances of them having metabolic syndrome. So not only particular diseases or medications or substances they are lead to metabolic syndrome, but there can be many other factors which portend to one person developing a metabolic syndrome or having a risk of developing a metabolic syndrome. So prevalence, it has been seen that the prevalence of metabolic syndrome seems to increase with age. Again, lifestyle modifications and exercise. What we have been talking about, that exercise and dietary changes, they lead to altering the components of metabolic syndrome, primarily obesity, the lipid profile, the insulin resistance, and even the blood pressure to a certain extent. So these components, like these interventions, lifestyle modification exercise, they lead to improved blood pressure, lipid and glycemic parameters. Not only they improve these measured quantities, but they also have been shown to improve the overall quality of life. So when we address metabolic syndrome using certain intervention, it has ancillary benefits as well. And it has been seen that prevalence of metabolic syndrome decreases overall by approximately 30 to 40% with intervention than control. So interventions seem to work, and it has multiple benefits as well. Now, metabolic syndrome is common in patients with severe mental illnesses like bipolar disorder, schizophrenia, and others. Similarly, studies have tried to evaluate whether metabolic syndrome exists in the addiction treatment settings as well. And I'll present some of the data, and that has come from Chandigarh as well, that in 2013, and that's Indian data, quite relevant to us from our population. So that is why I put it forth first. So in 250 men, substance variability of substances have been taken: alcohol, opioid, alcohol plus opioid, and other substances. And metabolic syndrome was found to be approximately 13.6% with the IDF technique. So there is variability across substances. In alcohol group, it was 21.6%, but it was less than 10% in the other groups. So opioid use disorder, probably less prevalence of metabolic syndrome as compared to alcohol use disorder. What were the predictors of having metabolic syndrome in this population? Increasing age, increasing weight, BMI, and the presence of obesity. So some of these are components of metabolic syndrome, but nonetheless, age, as you see, is an important predictor for metabolic syndrome. Herein I present the details, and I would like to focus here. Now, these are the components which are kind of deranged. And when we look at in the alcohol group, the most common feature that seems to deranged is waist circumference. So waist circumference seems to be the most common parameter, which seems to be present in individuals with in addiction settings who come for treatment and maybe having metabolic syndrome. Now, when we look at other conditions like opioids, again, therein waist circumference seems to be the highest. Similarly for alcohol and opioid group, and similarly for others group as well. And other components are also present, but some of these are much more common than the other. And there seems to be distinction in the occurrence rates of these problematic symptoms of metabolism. Yeah, so this presents the rates of metabolic syndrome being present from more than 20% in alcohol group to less than 10% in all of them. Now, another study by Dr. Manish Batla and all in patients with substance use disorders who came for treatment, consecutive patients, all men, aged 25 to 80 years, alcohol use disorder in 23 of them, and opioid use disorder in 13, and 14 had multiple conditions. So the most common profile of abnormality they found was low HDL, followed by raised systolic blood pressure and raised diastolic blood pressure. Now, metabolic syndrome, according to IDF criteria here, also in around 20% of the patients. So ballpark figure, somewhere between 10 to 20% people in addiction clinical settings, in the usual population, in the usual age group that we see, may be suffering from metabolic syndrome. Now, what do we infer? So metabolic syndrome is present in substance use disorder treatment setting, though it is often not focused on or not inquired into or not looked at systematically, as Dr. Jeet also emphasized, and that is, but nonetheless, it is present in the clinical setting. The clinical encounter provides an opportunity for ascertainment. So many people in general might also be having metabolic syndrome, but contact with the physician, contact with the psychiatrist in the addiction clinical setting, it provides an opportunity for assessment whether metabolic syndrome is present. And intervention can also be planned in such an encounter. And substance use disorders are often considered as chronic disorders. So patient is likely to come multiple times. So the message about whether metabolic syndrome is present or not, and whether something should be done about it or not, can be given reinforced in a reinforced manner. This is different from acute condition. For example, in certain ENT conditions, if the patient is meeting an ENT doctor, this kind of assessment or follow-up might not occur there, but herein we have a good chance. We also infer that the clinical population is varied. So multiple substances, and patients come with combinations of multiple substances. So someone taking alcohol only, someone with alcohol and tobacco, someone with alcohol and tobacco and opioid. So each individual is unique, and addictive disorders are heterogeneous when they come to the clinical setting. Age of presentations also vary. Opioid use disorders, generally they are younger as compared to alcohol use disorders when they seek treatment, because generally age at which presentation occurs for alcohol use disorders is around late 30s or 40s, while in opioids, family is quite interested, there are multiple problems, and the patient comes in within 20s as well. Age of presentation also has a bearing on the metabolic syndrome, and that's why where you look for, probably in alcohol use disorder, you look for much more thoroughly. Looking at various specific disorders, in alcohol use disorders, prevalence overall, when we see multiple studies together in a pooled sample, the prevalence of metabolic syndrome seems to be around 21%, with increased BP seemingly much more common than hypertriglyceridemia, followed by abdominal obesity, then hyperglycemia, and then low HDL cholesterol. So again, among the various components, probably increased BP is much more commonly seen. But again, this is a pooled sample, and individual studies might have a little bit of variation. So some study might have found hypertriglyceridemia to be much more than hypertension, and so on. But nonetheless, when you pool, the risk factors, individual risk factors are probably much more common than what the metabolic syndrome rates you get. Also, psychiatric comorbidity, that is dual diagnosis, either psychosis, affective disorders, they are associated with metabolic syndrome. So when psychiatric comorbidity is present, increased chances of having metabolic syndrome, as Dr. Nitin was also alluding to. Now, again, a study focusing on only alcohol use disorders, which compared alcohol-dependent men with 50 controls and 50 non-related controls. So 50 related controls, that means similar genetic makeup. Non-related control means a different kind of genetic makeup. As per IDF criteria, metabolic syndrome was present in 27%, 22%, and 30% of the patient. Genetic control, that is family relatives, and healthy controls respectively. Similar results were there for the NCP ATP3 criteria. Not much of a significant differences per se, but when you look at difference between alcohol-dependent individuals and their genetic relatives, probably little lesser rates of having metabolic syndrome. So alcohol seemingly increases the rate. From a different perspective, data from South Korea, and this is not looking at alcohol dependence per se, but range of alcohol use disorders and rates of alcohol use behaviors. When they control for education, smoking, and physical activity. So when you control for other risk factors, you find that rates of metabolic syndrome are almost 2 times higher for those who have hazardous drinking. So we use audit criteria, alcohol use disorder identification test, a screening tool that gives you a certain scores, and certain scores are categorized as being hazardous drinking. So when there is hazardous drinking is present, almost two times rates of metabolic syndrome. But when there is problem drinking, that is much more severe, that is either harmful drinking or dependent drinking, then the rates are 3 times. So it shows you kind of more intense the drinking, more problems, more chances of having metabolic syndrome. Now, how do these all occur? And we heard Dr. O.P. Singh tell us very eloquently about the various mechanisms, and it seemingly has multiple routes through which it occurs. So metabolic syndrome occurs through multiple parameters, but alcohol can affect stress or stress reactivity. It can also lead to increased activity of the HPA axis and leading to increased cortisol. It can lead to sympathetic activation, especially during withdrawals. And it can lead to increase in inflammatory cytokines, and all these can be risk factors for developing metabolic syndrome. So alcohol use disorders, yes, increase risk of having metabolic syndrome. And how do the risk actually occur? Through various mechanisms. And alcohol has bearing on certain of these mechanisms. Apart from these, many other things may occur in an individual predisposed, which may lead to metabolic syndrome. Now, moving on to tobacco, metabolic syndrome again is more common among smokers than non-smokers. Odds ratio about 1.8 for women and 1.5 for men. So about 2 times more women who smoke are affected with metabolic syndrome than as compared to those who do not smoke. Similarly, 1.5 times for the men. There is a positive dose-response relationship between the daily number of cigarettes smoked and the risk of metabolic syndrome. So smoking, more amount of smoking, more chances of developing metabolic syndrome. Not only current smokers are at risk, but former smokers are also at risk of metabolic syndrome. So someone who has smoked and has now quit also has a risk of developing metabolic syndrome. Now, again, when we look at among those with metabolic syndrome, the rates of smoking are about 40%. The rates of smoking may be even higher than about 70% in a Colombian study. In a study of India, the rate of smoking was around 26 and 3% in men and women who were suffering from metabolic syndrome. And not only smoke form, but even smokeless form was associated with increased prevalence of metabolic syndrome. So smoking or consumption of tobacco in non-smoke form also leads to increased rates of metabolic syndrome. And a considerable proportion of people who consume tobacco products, they develop metabolic syndrome. Or when we look at population of metabolic syndrome, many of them would have a history of using tobacco, probably more than more than the general population. So how does tobacco cause metabolic syndrome or is related to metabolic syndrome? Through multiple mechanisms, including increase in adiposity, insulin resistance, leptin resistance, low-grade systemic inflammation, endothelial dysfunction, and autonomic dysfunction. So multiple mechanisms have been propounded and have been seen to play a role in development of metabolic syndrome in those who have been consuming tobacco products or smoking. And it is often difficult to disentangle or distinguish between the different mechanism, how much role is one playing as compared to other risk factors or the other mechanisms also. So tobacco cessation seems to lower the risk of developing metabolic syndrome. So cessation helps, though rates of metabolic syndrome have been seen to be higher. But those who leave, it seems the risk becomes a little lower. It has been associated with reduction in the triglyceride level and improved HDL levels. It improves insulin sensitivity as well. Now, one of the concerns people have when they leave smoking is that they will gain weight. There is an increase in body weight after quitting tobacco, which could lead to increase in rates of metabolic syndrome, but it gets countered with the other 2 factors as well. So coming to now heroin dependent or opioids. So when we look at opioids or predominantly heroin, it has been, and individuals who are heroin dependent who are on methadone, it has been seen metabolic syndrome is present in around 30% of the individuals, with low HDL cholesterol being present the highest, followed by hypertriglyceridemia, followed by other parameters like blood pressure, abdominal obesity, and raised blood sugar levels. So raised blood sugar seemingly lowest, and most commonly seemingly HDL cholesterol being used. Metabolic syndrome herein is associated with higher age, higher BMI, and psychiatric comorbidity. Again, psychiatric comorbidity seems to be a risk factor for metabolic syndrome in individuals who have substance use disorder. And probably having medications or having the disease per se becomes one of the risk factors. A longer duration of methadone also associated with metabolic syndrome, probably that indirectly suggests that during the time person is taking heroin actively, and not eating, so the BMI remains low, but gradually it becomes kind of normal and then gradually increases with time as a person is abstinent and as on methadone. What did not seem to make a difference was gender, or having additional alcohol use disorder, or having additional cannabis use disorder, or cocaine use disorder. So when certain other disorders are present or substance use disorders are present, including alcohol, cannabis, or cocaine, that did not make as an impact as did having an additional psychiatric disorder. So certain risk factors seemingly play much more of a role than others. Now, looking at opioids and alcohol and comparing them in a study of 160 male individuals, with 101 of them alcohol dependent and 59 of them opioid dependent, with different ATP3 criteria and IDF criteria, 20.8 and 9.9% had metabolic syndrome. But as compared to other condition, that is opioid dependence, so the rate similar with ATP3 criteria, but with IDF criteria, rate seems to be lower in opioid dependence as compared to alcohol dependence. So good concordance in alcohol dependence, but fair concordance about the different criteria in the opioid dependent group. And probably when you change how you are going to measure, you get lower rates in opioid group as compared to the alcohol. There's some evidence that is emerging for cannabis as well, and some inverse association of cannabis and metabolic syndrome. So in the Australian psychosis survey, about 1,800 individuals with psychosis with some data of cannabis use, the rates of metabolic syndrome among non-users of cannabis, 63%, as compared to occasional users, 51.7%, and frequent users, 43.5%. So seemingly, if someone is frequent cannabis user, probably the rates of metabolic syndrome are lower as compared to those who are not using. But this is in the context of those who have suffered from a psychotic illness. Probably does not generalize to other population as per this study. Another study of patients with schizophrenia, wherein recovery was assessed after early treatment. Cannabis users and non-users had similar rates of metabolic syndrome at baseline, but at 2-year follow-up, those with cannabis use disorders had lesser chances of developing new onset metabolic syndrome. So again, some preliminary evidence which suggests that cannabis may be otherwise inversely related. But again, observational preliminary studies not to be given too much credence until supported by other evidence as well. Now, for stimulants and cocaine, actually not much data is there. One study has looked at prenatal, and I tried to search from various sources and didn't get anything wherein stimulants were followed up or associations with metabolic syndrome were assessed. But one study did look at prenatal exposure of cocaine and development of metabolic syndrome in adulthood and did not find an association. So that was kind of different kind of study where prenatal exposure to cocaine was being seen. While stimulants can increase BP, it can reduce appetite and may not actually lead to weight gain. So I'm not sure whether it would occur. One of the reasons I think that researchers have not paid too much attention is probably in clinical settings, they did not find patients or did not systematically assess them for various parameters of metabolic syndrome. Now, looking at comorbidity or comorbid psychiatric illness with substance use disorders, there can be a variety of comorbidities present, and there can be varieties of permutations and combinations, leading to difficulty in generalizing about comorbidities per se. For example, there can be a combination of alcohol use disorder with bipolar disorder, where the patient is getting antipsychotic and bipolar disorder itself being associated with metabolic syndrome. So rates will be high, maybe higher. But with stimulant use disorder and personality use disorder, probably there might not be too much of a data or too much of an excess risk. So each of these combinations have to be looked at carefully. But often it is seen that in comorbidity, the rates of metabolic syndrome have been, as a group, have been seen to be higher in patients with substance use disorders. So again, emphasizing comorbid substance use disorder and psychiatric illness, they have higher rates of having metabolic syndrome. The causes could be lifestyle, medications, and the illness itself. So multiple causes could be there. It has management consequences while dealing with cases of dual diagnosis. Which comorbidities are at greater risk among substances? Alcohol and tobacco, they have increased risk of metabolic syndrome. And among psychiatric illnesses, bipolar disorder and schizophrenia are prominent, and other disorders also have increased rates of metabolic syndrome, including depression as well. But these two are the major conditions where rates of metabolic syndrome are high. Now, when should we assess for metabolic syndrome in the clinical setting, in the where we deal with patients with addiction as well? Should we make it a generic assessment that we should screen all treatment seekers, or should we focus on certain focused population of people who are seeking treatment for addiction, including those who are obese, who are of increasing age, or who are having tobacco and alcohol? So this remains the discretion of the treating physicians as well. But nonetheless, we need to consider this view, because the assessment time may be a constraint. And so therein we need to make on-the-fly judgments as well, or we may have institutional policies per se that we are going to look for metabolic syndrome in everyone, or we are going to look at metabolic syndrome in certain risk cases as well. When do we intervene, or when should we do something about it? So I would like to suggest that we should intervene when the acute condition for which the patient has sought treatment for the substance use disorder is stabilized. Acute withdrawals are subsided. When there is violence or harm to others are addressed already. And when the management is progressing to the phase of maintenance. Sorry, I think I missed a word there. So these are the conditions where we would like to kind of start the management and continue the management. Now, what to do about metabolic syndrome in such situations? The primary goal is to reduce the risk of arteriosclerotic disease, is what we overall finally want with the management of metabolic syndrome. So what we do is to reduce the major risk factors, the LDL cholesterol, hypertension, and the diabetes risk. We try to manage these so that the person does not progress towards the risk of arteriosclerotic disease. So what can we do? We encourage physical exercise, and what can be advised is suggesting for 30 minutes of regular moderate intensity exercise, more than 5 days a week. Moderate intensity aerobic exercise. So people may construe exercise in different manner. Here, what we want is some degree of exercise which is aerobic in nature. And we need to be cautious when medical conditions or medical comorbidities are present. So therein, we need to individualize our suggestion. And if there is chest pain already, we need to go a little cautiously in those situations, or other problems are there, or even mobility problems are there. We cannot just simply suggest. We need to consider each patient's condition individualized. Again, we try to suggest for addressing abdominal obesity, and we suggest to reduce 7 to 10% of the weight within the first year, and to achieve BMI less than 25 kilogram per meter square. We suggest balance of physical activity, limitation of caloric intake, and behavioral modification program, where we suggest how to be active, at the same time limit food intake, at the same time have regular physical exercise. And this becomes the cornerstone of the management of metabolic syndrome, which is supplemented by cognitive behavioral based interventions as well, where we go with what are the challenges in implementing and how we can. Now in diet, we suggest to reduce the intake of saturated fats, the trans fat and cholesterol. The total fat should be between 25 to 35% of the calories, and simple sugars should be avoided as much as possible. For dyslipidemia, which is present, we target the LDL levels. For high-risk patients who have multiple other comorbidities, the risk is less than 100. But for other patients with moderate risk or lower risk, the targets can be much more flexible of 130 or 160. Herein, again, lifestyle modifications and medications might be helpful. Medications to take care of the dyslipidemia, including statins and including niacin, can be helpful. Now, for raised BP, again, lifestyle modification, weight control, dietary modification, increasing physical activities, and moderation of alcohol. So herein, moderation of alcohol is suggested, or using of less amounts of alcohol is suggested as a risk factor for reducing the increased BP when it is present. Antihypertensive medications are suggested when BP is more than 140/90 or 130/80 when chronic kidney disease or diabetes mellitus is present. And for raised blood sugars, lifestyle modification, again, weight reduction, increase in physical activities, and the target of glycemic control is less than 7%. So less than 7% of HbA1c, probably things are in order in such situations. If it doesn't get controlled, then medications are of use. Of course, metformin and other medications can be used. So a variety of interventions can be used in our clinical setting as well to control the risk factors for developing metabolic syndrome or the occurrence of metabolic syndrome. Now, what happens during smoking cessation? And there are interesting findings that there may be a temporary weight gain, leading to more individuals being classified as having metabolic syndrome, and that's true. But baseline weight might be higher in smokers to begin with. So when they have stopped, they tend to regain their baseline weight, and that might be reflecting as having metabolic syndrome. So an interesting observation was seen where, compared to continued smokers, quitters who had weight gain, the rates of metabolic syndrome or the odds ratio of having metabolic syndrome was almost 2 times. So those who had weight gain, yes, they had increased chance of metabolic syndrome, but those who quit and did not have weight change, so no significant change in weight, they did not have increased rates of metabolic syndrome. In fact, they have lower rates of metabolic syndrome. And quitters who had weight loss, they had significantly lower rates of metabolic syndrome. So what it boils down is, when we are suggesting people to quit, if we are also suggesting them to kind of monitor their weight and try to reduce their weight in case they are obese or having features of metabolic syndrome, probably their risk of developing metabolic syndrome in the future will be lower. What happens when people stop alcohol or when they abstain from alcohol? Insulin resistance seems to decrease, and fasting blood sugar seems to decrease by around 6%. So people who are alcohol dependent, when they stop alcohol, seemingly their insulin resistance decreases and their glycemic control becomes better. So this may have a favorable impact on the metabolic syndrome. Again, so stopping alcohol seems to work and seems to have an impact on metabolic syndrome. So herein, I would like to now conclude with saying that patients with metabolic syndrome are likely to be encouraged to be encountered in the addiction treatment setting. So in addiction treatment setting, we do find patients with metabolic syndrome. It's often we do not focus on them, but they are present. The concern is higher when comorbid psychiatric disorder is present and additionally treatment is going on. So therein, that's a risk group where metabolic syndrome needs to be looked for and probably addressed. And when we find metabolic syndrome is present, we need to suitably address it. So with this, I would like to thank and I would take the liberty to end with this picture that there are various grades of beer belly. Thank you.
I think the mic is not working. On stage mic is not working properly.
All right, sir.
Hello. Hello.
Yes.
Yes. Yes. Thank you very much, Dr. Siddharth, Dr. Nitin sir, Dr. Ajit Nana sir. You can go ahead and then we'll have final comments from Madam.
Okay. Dr. Sana, would you like to take over regarding the questions, please?
Yes. See, I think the presentation was started around 7:15 and the first question came at 7:35. And it is a premature attempt of asking the questions. So I would request Dr. Siddharth that most of the questions were already covered in your presentation. So I request you to filter out those questions and the question which has not been covered, you please take up those questions so that the time can be utilized optimally. Please.
So firstly, before answering the questions, I would like to thank everyone who has put forth the questions. They have listened to the presentations or had at least quite a lot of, they perseverance to go through the presentation and ask a few. Thank you for that. So let me start with the last question that is there by Deeba. Normally we encounter patients with polysubstance, cannabis and opioids. What will be the risk of metabolic in this group? As you very rightly put, that there is a heterogeneous combination of substances when people are taking. Some people are taking only one substance or two substances, and many are taking multiple substances. It is very difficult to disengage, the risks in such situations. So in such situations, we, so risk of metabolic syndrome, again, we look at alcohol, tobacco, and them being used on a regular basis, risk would be higher. When added with opioids, probably with cannabis, risk might be lower. So we are not really sure about what the risk is, but nonetheless, we should go ahead and try to assess whether this person who has come to me for treatment at this point of time has those risk factors and whether I can go in for a diagnosis of metabolic syndrome and try to address the metabolic syndrome in the manner which is beneficial to the patient. The other question, very interesting, is hallucinogens, do they cause metabolic syndrome? So I have not actually particularly looked, but in the kind of reading that I was going through, I did not encounter this. Now, the reason I think that it might not be too much related per se, additionally, apart from other risk factors a person may be having, including genetics, including his ethnicity, including other substance use, is because hallucinogen use is very sporadic. It's very intermittent. So it is very, very rarely so regular as to have an impact. But then we need to see what kind of impact it has. And I'm not sure, whether there are certain mechanisms for regular users, if there are any for hallucinogens, they have, or they have a risk factor for metabolic syndrome. But in them also, we will be looking them in the perspective of having other risk factors as well. But very interesting question. Presence of metabolic syndrome in a patient with opioid dependence is a consideration for initiating opioid substitution therapy with buprenorphine. Okay, again, an interesting question. So a metabolic syndrome is just a risk factor for developing other cardiovascular problems and conditions. So that does not become itself by it may not dictate to a large extent as compared to other factors. How do we determine a patient whether he should get opioid substitution treatment or not? There would be other larger or more pertinent factors therein. For example, the duration of opioid use, whether the person wants an opioid-free lifestyle or wants to continue opioids for longer time or not, whether there are feasibility, whether the person is injecting drug use. So multiple other pragmatic issues and other clinically relevant factors for that patient might be operative. But in case the person has metabolic syndrome, the metabolic syndrome would be addressed additionally through the other lifestyle means. But so for that per se, whether the person will gain weight or not, that is rarely a consideration in the usual clinical scenario. How does poor nutritional status in substance users contribute to metabolic risk? Can we use medications to increase appetite in such patients? Okay, so when we try to increase appetite or appetite is stimulated by certain factors, then the rate of metabolic syndrome or actually developing other cardiovascular. With increased weight, the rates of other cardiovascular diseases will be high. So poor nutritional status, it does not portend to become a particularly a risk factor, but yes, during a poor nutritional status, one may have increased cortisol, and that may increase pro-inflammatory state, but that's pretty much theoretical. If a person is having poor nutrition, the primary goal is to improve the nutrition so that there can be many other problems that may be occurring due to poor nutrition, including infection. So that needs to be taken care of, and poor nutrition needs to be addressed adequately. At the same time, avoiding excess of nutrition. Best antipsychotic antidepressant for persons with alcohol use disorder. I think Dr. Samir very eloquently or very nicely presented in the previous presentation as well. What to avoid: olanzapine, clozapine, and mirtazapine, and what to give probably haloperidol or ziprasidone, and what to give among antidepressants is probably SSRIs. So yeah, certain medications, different. Does the gender of a person taking alcohol also affect the occurrence of metabolic syndrome? So the rates of metabolic syndrome vary across different genders, but having considered that, I'm not able to get clear information at this point of time that whether in alcohol use disorder gender has a difference. But in the study that I quoted of Korea, in which they looked at the population sample, the rates between men and women did not differ too much. But then again, the problem in such studies is the rates of the number of women is lower. So getting significant differences might also be quite a challenge. But in the study that I recollect from Korea, not significant difference among men and women. But generally, there is a little bit of difference in the metabolic syndrome between men and women. Yeah, with the same amount of substance use. So yeah, again, the similar question. Risk of developing metabolic syndrome with OST. So one study I could found about methadone, and which found that the metabolic syndrome is higher or a certain degree in those who are taking methadone, and for longer duration of methadone, more rates of metabolic syndrome.
Okay. Siddharth, can we stop somewhere?
Absolutely.
I understand there are a lot of questions, because if we keep on going at this pace,
I think we have,
yeah.
Any floor question?
Over to chairpersons, online chairpersons, Dr. Nitin Gupta and Dr. Ajit Sidana, sir, for final comments before I hand it over to Professor Savita, madam, for final remarks. And the best question, obviously, Dr. Siddharth, if you could pick up till then. Dr. Nitin, you are muted. Kindly unmute yourself.
Yeah. No, I don't have anything more to add. We are running out of time. I'll pass on to Dr. Sidana for any comments, and then on to Dr. Savita.
It was a very nice presentation, and all the questions were attended very well. So no further addition from my side. Hand it over to Madam.
Well, thank you very much. Dr. Siddharth, thank you very much for this very, very informative and overview of the topic subject. There were lots of practical and clinically useful guidelines and tips given and issues raised. I suppose when patients they come to us for treatment of addictions, they are not focusing at that time on anything like metabolic syndrome. They are not even aware, number one. Even if they are aware, that is not their primary concern. And what we have seen in our clinical practice is that when we tell patients, when we find out that they have also associated problems of hypertension, diabetes, overweight, and all this, and dyslipidemia, and so on, and we tell them to take treatment or advise them like exercise, diet, such things, they don't take seriously. They just do not take seriously, nor does the family take it seriously. They think that they have come to us to psychiatrists for treatment of addiction, and they tend to think that we should do our business is only to kind of get him rid of these substances, and all the rest is fine, either fine or not our domain. Maybe send it to a physician. Maybe वो बोलेंगे जी हम hypertension का इलाज करा लेंगे, या हम जा रहे हैं endocrinologist पे जा रहे हैं, and things of that kind. But I think we as psychiatrists need to be much more aware, and also I think responsible and proactive in persuading patients to seek treatment. Treatment is not as simple as simply taking medication, antihypertensive or anti-diabetic or some such thing. It also requires a lifestyle change, a habit change, a dietary change, and for which a psychiatric intervention certainly is needed. And why we should concern ourselves is also because associated these metabolic syndrome makes the prognosis and outcome worse, and overall mortality is high, premature mortality is high if we do not address these issues. So the families have to be, and the patients have to be adequately educated. It makes the problem much more complex and difficult to treat, but we must address both the aspects, metabolic syndrome and substance use disorder, simultaneously and in parallel. That is what I think we've come to understand and learn from your talk. And with this, I would like to thank profuse amount of thanks to Dr. Siddharth for this talk. And thanks to my co-chair, Dr. Nitin, Dr. Sidana. And of course, ultimately, thanks to the organizers for organizing all this such a beautiful and intensive program of CME. Thank you very much.
Thank you very much, madam. I think that's the end of it. Before we conclude, Dr. Siddharth, have you chosen anybody?
Oh yes, Dr. Ashish Bhandari, who has asked about do hallucinogens cause metabolic syndrome.
Okay. So thank you very much. Ashish Bhandari ji will get his memento or the prize for the best question. And it is first time that it has gone out of home turf. The guys were playing well in their home turf anyways. Thank you very much, Siddharth. Thank you, Dr. Sidana and Dr. Nitin. Thank you very much, Dr. Rastogi. I can see all the way through since 2 p.m. He's logged in. It has been a marathon because he is the basic backbone, the backbone of the CME. Dr. Naresh, thank you all. And we have the time for mementos. May I request Dr. Rakesh Chadda sir to hand over memento to Professor Savita Malhotra. And the online chairperson and the speaker would get mementos online only very soon. Thank you very much.
And online, thank you for that.
Thank you.
Thank you.
Thank you, everybody. Thank you, Nitin sir, Sidana sir. Thank you, Naresh. Thank you, Siddharth. Thank you.
Thank you, sir.
And thank you, my dear colleagues who have had a hectic 6 hours of presentations and inaugural. Thank you all. We'll break for dinner. I wish Dr. Sidana would be here with us to have dinner, Dr. Nitin sir. But anyways, we'll meet soon. Thank you all. Thank you very much.
Thank you. Okay, good night.
Tomorrow morning, for information of everyone, online and obviously offline, we'll be starting sharp at 9, the way we have today finished at 8 o'clock, so spot on time. Tomorrow we'll be starting at 9 o'clock. See you again then. Thank you very much.
Okay, bye. Good night.
Thank you.
Recording stopped.